Hi guys, hope you're doing great. So keep calm and attempt today's questions with logic. And the objective of today's session would be to one, teach you how to persist these long hours, and second would be obviously that this would be a motivational study challenge. So I'm gonna throw some questions at you, and I would like you to answer them in the shortest possible time frame. So do not just listen, but you have to engage today and hit the comment button as soon as possible. But yeah, obviously with logic. I mean, it's not the fastest finger kind of a contest, but what matters is that you have to try and analyze the options, because lots of time the questions that are coming in the paper might be having not direct answers, but they might be having indirect answers as well. So this is a mixed bag discussion that we'll be doing. Like, it's not going to be like, only like surgery question or anatomy or then maybe a ENT question. It's going to be like jumping from subject to subject. So just like in a cricket match, you are able to, like, a lot of boys or guys listening to me would be playing cricket. So a bowler might be delivering a short pitch delivery, then a bouncer. So you would be able to adjust your play according to it. Similarly, here our objective is to make you be able to handle multiple subjects in a single go. So let's talk about some very baseline information today, but that baseline information would help you plan for the bigger D-Day. So I know that couple of the days which are left for the exam nowadays, it's obviously going to cause a bit of jitters, but I think you have come so far and you will go ahead. You will be able to persist and manage all this time. So just give me a thumbs up with respect to the audio and the visual part, and we can go ahead with the discussion. And yeah, persisting 3 hours is the most important thing. Ram Ram to everybody. And Ayush, you made a very, very valid point. So this would be a combination of both. I mean, this should be helping everybody. I think both FMG and NEET PG students. So keep going. And primarily my focus would be obviously because even FMG exam has become more difficult. So if you think that you are up for the challenge, be my guest. Otherwise, like, the session is targeted towards NEET PG. Okay. So the audio and the visual part is perfectly fine. And let's start with the very first question, which talks about not being correct about intraperitoneal rupture of the urinary bladder. And you will not feel demotivated. Like, let's hit the comment button and let's try to focus on the core aspects. So I think this is a fairly straightforward one. Like, let me say two guys are drinking beer and then they have a fight in a bar. So one guy gets kicked in the tummy. And what I mean by tummy is in the lower part of the abdomen. So what can happen in the patient is that there can be a development of a rent or a tear that could be developing in the superior wall or on the dome of the urinary bladder, and you can see the urine that is extravasating out. So it will contribute to development of unfortunately a chemical peritonitis. So what you have in a case of intraperitoneal rupture, you see there are two types that are asked. One is extra and second is intraperitoneal rupture. And there would be chemical peritonitis, and a CT cystogram would be helping in confirming the diagnosis. Blood at the meatus is a feature which is going to be seen if there is an injury to the urethra. So I'll show you a couple of line diagrams with respect to that urethral injury as well, which is usually asked in the paper. But as far as like intraperitoneal rupture is concerned, it will not be having any blood at the meatus. Extraperitoneal, yeah, blood at the meatus can be present if it is associated with injury to the bladder neck, or maybe injury to the injury to the, I can say, the upper part of the bladder neck, or the injury is occurring to the urethra. Now, another question which is very frequently asked in the exam is rupture of the bulbar urethra. That can be asked to you. In case that happens, the urine is going to extravasate. So they usually ask about where the urine will extravasate. So you can notice that in this case, the urine will be accumulating in the superficial perineal pouch. It will tract into the scrotum, penis, and the anterior abdominal wall of the patient. So if you get a question which specifically mentions about blood at the meatus, inability to void, then this would most of the time be a straddle injury, and the straddle injury would be a rupture to the bulbar urethra. But there can be another trick in the question, like he might give you a situation where there might be blood at the meatus. He cannot void, and a high riding prostrate is given on the digital rectal examination. In those circumstances, the urine could be extravasating in the deep perineal pouch as well. And if that is the situation, as you can check out from the image that I've currently shown before you, then you have to answer this as rupture of the membranous urethra, which can occur due to direct trauma to the pelvis of the patient. And if you're having any issues with respect to confusion in these questions, my suggestion is that once I upload the PDF subsequently, you can go through it. And these diagrams are very, very simple, guys. I mean, if you just focus on the diagrams for these questions, then 4 questions can be covered here. The first and the foremost would be intraperitoneal rupture, which is going to be the dome of the bladder. Chemical peritonitis, no blood at the meatus. But if it's going to be pelvic injury, then the anterior wall of the bladder, anterolateral wall of the bladder can be affected, so the urine can leak into the pre-vesical space. This is injury to the bladder. That's one. But then the next issue that they usually ask about is blood at the meatus. If they give you blood at the meatus, there can be two possibilities in questions. One can be a membranous urethra, or it can be like a bulbar urethra rupture occurring in a patient. And these two line diagrams that are given before you would help you differentiate between the two, specifically with respect to the hint that I mentioned, especially if he says a high reading prostrate on our digital rectal examination. So the correct answer for the first question is option number C. And I had very, very good questions which would help you out. And let's move on to the second one for today. If you had any issues with this kind of issues in the bladder, this PDF would make it much more simpler for you, or you can go back to your surgery notes as well. So yes. Moving to the next question, we talk about this guy. He is coming to the hospital with this soft fluctuant mass which is present on the anterior border of the sternocleidomastoid at the junction of like the upper and the middle 1/3. And well, the diagnosis of this case is very, very clear. If you have a swelling like this, what we are talking about is at the moment a brachial cyst. And when it comes to a brachial cyst, lots of time this brachial cyst can secondarily get infected as well. So it does have stratified squamous epithelium, and it has lymphoid tissue as well. I mean, this is a correct statement. Incomplete obliteration of the second brachial cleft. It is derived from the cervical sinus of His. What is cervical sinus of His? Then the second, third, and the, you see, we read about pharyngeal pouches and pharyngeal clefts. So the second, third, and the fourth pharyngeal clefts is which I am calling them as the technical term, the cervical sinus of His. And brachial cyst would be primarily because of malformation related to this. Now, the important thing that you have to understand is that a cyst is not going to be communicating anywhere. A brachial fistula will be. So meanwhile, you are hitting the comment button. What I would like to know from you also is, can you tell me the internal opening of the brachial fistula? External opening will obviously be in the neck of the patient. Most of the time would be like in the middle or maybe in the lower part of the sternocleidomastoid. We could be having is a opening of the brachial fistula. Can you tell me what is gonna be the what is the site of the internal opening? And it, I mean, cyst does not communicate with anything. Na? Yahan pe the logic to be used is that the brachial cyst will not be communicating at all with anything. It is a brachial sinus or maybe a brachial a fistula that could be having an external opening. Otherwise, like there would be no communication with the piriform fossa. Okay, so I had one answer coming up. The internal opening would be in the tonsillar fossa, guys. That's again a question that is asked in your exam because there are two important neck swellings that they love to ask. In fact, three. One I'll discuss subsequently, cystic hygroma. Second, they ask about is brachial cyst, and the third one that they always ask is a thyroglossal cyst. So as far as this one is concerned, yes, it is the tonsillar fossa, guys. It's not the external auditory canal. Most of the time, the brachial cyst would be opening in the tonsillar fossa. So first and foremost, you need to just get the embryology part right with respect to the brachial pouches. That's pretty straightforward. The pharyngeal pouches, you never would make a mistake. So the question was with respect to the pharyngeal clefts. That is one. And second, like I asked you, where would be the internal communication be present? So just you need to remember tonsillar fossa is for the internal opening of the brachial fistula, and also they ask you for the internal opening of the thyroglossal fistula, for which you do a cyst trunk operation. So the opening would be at the base of the tongue, and the base of the tongue would be like the foramen cecum. And one of the dummy choices in this question, which was the answer, was piriform sinus fistula. This would be obviously causing recurrent neck abscesses in a child and would be communicating with the hypopharynx. Image that I'll show you subsequently that came in FMG exam. It is the image is hiding before me. So before I show you that image that came in FMG exam, I just want to go back in my previous slide and just highlight that the epithelium of this is stratified squamous. But along with the stratified squamous epithelium, there is also presence of lymphoid tissue in the wall. That is why ये बहुत बड़ी infected हो जाता है. So lots of time, like because it is infected, the patient went to some local doctor who gave an incision over it, and that would result in creation of a brachial fistula as well. So ये तो practice से हो जाएगा. I mean, this is not a hard way to remember the core aspects which are asked. And then this easy peasy question, you know, you can see matted, you can't feel it here, but yeah, these were matted lymph nodes which are present, and then the pus broke out from it. So it resulted in development of multiple fistulas in the neck of a patient. So every time like you are come across a child or adult with cervical lymphadenopathy, multiple group of lymph nodes that are enlarged, and a couple of them are also I would say, causing a pus to escape, or there's like a continuous discharge that is happening, then we have to think in terms of cervical lymphadenitis in a patient. So this would be a very classical feature for scrofulоderma. And three important neck swellings that they love to ask are the thyroglossal cyst, the brachial cyst, and then is scrofulоderma or tubercular lymphadenitis. Absolutely, Priyansh, you were spot on, and Simran, Tanmay, you guys are spot on with respect to the aspects that I have said for this one. So we sorted for the second one. The answer is D, because cyst is not going to communicate with anything. It's always going to be a fistula. Moving to the third one, again, a easy one and easy peasy one, as you like to call it. Lateral aberrant thyroid, doc. This would be, there would be neck swelling adjacent to the thyroid gland in a patient. No, this would be a midline, close to the midline, whereas the current swelling that I've shown before you is on the anterior border of the sternocleidomastoid. So the location would be grossly different. And another thing that was given in the hint was that this is gonna be, and the swelling was present since birth in a person. Okay, so moving to the next one, a defect is shown, and a common thing that you to understand here is that you can see the genitals of a patient which are malformed. This is actually a girl patient, and then you can notice that the urinary bladder is totally exposed. So this is a malformation, a easy one to pick up. This would be an exostrophy of the urinary bladder. In case of males, it would be associated with epispadias. So one, they can ask you the malformations which are associated. For males, it would be epispadias, and for females, it can be like bifid clitoris or separation of the labia minora with abdominal, lower abdominal muscle defect can be present, and there would be continuous leakage of face in this patient. The apple jelly nodules is a feature which is seen in dermatology. You know that apple jelly nodules is a feature when you do dioscopy. जैसे आपने एक suppose, for example, you made a glass slide, and then you press on it, and that's when dioscopy is being done, that the apple jelly nodules would be present. So TB lymphadenitis is spot diagnosis has been asked, and that's why I decided to show you this image. So when it comes to the bladder exostrophy, I've mentioned about it. And then is obviously gastrochisis, omphalocele, that they also love to ask in the paper. And as far as this malformation is concerned, you will always notice in gastrochisis that the umbilical cord would always be originating lateral to wherever the defect would be present. And they've also asked how would you treat these two conditions, omphalocele and gastrochisis. I think this was FMGE exam where they asked about the management of these. So we'll cover these defects with saline soaked gauze initially, and then subsequently a stilo covering would be made, and we'll try to reduce this into the inter-abdominal wall. Yes, exactly, Avigdas. That would be a stage repair, because if I try to do a repair immediately, it will contribute to compartment syndrome in a patient. So it's like a stage repair that would be done in this case. Yep. So I think this is a spot one and an easy one to pick up. Important thing to be remembered is stage closure would always be done for omphalocele as well as gastrochisis. And let's focus on the next one. Okay. The procedure that is being done, I'll just zoom out of the image. Yes, I think the image is now better. You can see this, a vestigial organ of the human body. On one side, you can see the Babcock forceps. On the other side, you can see the artery forceps, which is crushing the base. So what is happening in this patient would be appendicectomy that is being done. And whenever we are doing an appendicectomy, if you just go by simple logic, you need to use Babcock forceps. You would be crushing it with artery forceps. It would be always located on the anti-mesenteric border. What I mean by anti-mesenteric border is that it would be where the mesentery or the blood vessels would be, because the blood supply would be the appendicular artery. So we need to ligate that, right? I mean, the appendicular artery needs to be ligated as well. And if you look at option number C, it is written purse string suture is applied at the distal end. Suture to यहाँ पे लगाएंगे ना? I mean that purse string suture would be put at this particular end on which the side the cecum would be present, and then it would be inverting the stump into the cecum. I mean, the logic in this place is that purse string suture in a case of appendectomy would be done whenever we are doing the procedure. It would be to invert the stump into the cecum of the patient. So the correct answer for this one is option number C. I did get D as an answer as well. So I'll just show you a diagrammatic representation. I mean, this is what I'm saying. No, the blood vessels would be present like this, no, appendicular artery, and then there would be like blood supply to the appendix. So we need to take care of the blood supply. This is the anti-mesenteric border that I've said. So two structures that are always asked for anti-mesenteric border. One is appendix, obviously. Second is the Meckel's diverticulum, and rule of two is obviously for Meckel's diverticulum. So one, you need to just remember that the purse string structure is applied. I mean, just go by English. No, a lot of these questions that are given on these interoperative images, they can be solved by a simple English interpretation. I mean, you are not going to put a suture on the distal because that part would anyway be removed. It would be on the proximal part, and then we bury the stump. The statement I want to make is bury the stump into the cecum per se. So answer for this question would be option number C. Great. So I had majority of people answering that very correctly and very rightly as well. Okay. Doesn't matter. Some questions can go wrong, some can go right. So you just need to keep on practicing. And now we are having it's a three-way Foley's catheter here. Normally, like we always say, is a two-way Foley's catheter, but here what you can see is a three-way Foley catheter, and this is usually used for CBI. CBI stands for continuous bladder irrigation. That would be done after TURP, because after TURP, when we do this resection of the median lobe of the prostate, they would be bleeding, and that would if the blood clots, it can result in a clot colic as well. So we usually need to do a CBI for at least 48 hours after TURP, and gradually this bleed part would be resolved. The answer for this is option number C. You can also comment in the chat box what fluid will be used for this continuous bladder irrigation. Options can be like distilled water, glycine, and normal saline. Quick answers, please. Which fluid would be recommended? For continuous bladder irrigation, normal saline, then is continuous bladder irrigation. Saline can be glycine and then can be distilled water. Yes, it would be normal saline that would be used and not distilled water. डिस्टिल वाटर नहीं यूज करते ना. आई मीन डिस्टिल वाटर के साथ में क्या कॉम्प्लिकेशन होती है? Yes, yes, I'm getting distilled water as an answer. The fluid that is used is not distilled water, no? It is normal saline that is used. Yes, guys, why don't we use distilled water? Because it will be absorbed into the blood circulation, no? And it can contribute to development of water intoxication, that is absorption via the periprostatic venous plexus. That is one. And in that circumstances, once we have absorption via the periprostatic venous plexus, then this can contribute to water intoxication, that can cause electrolyte imbalance, it can contribute to seizures as well. So that is why we will be using normal saline, or we can be using is first answer is always normal saline, then is glycine if mentioned in options, but usually it is like distilled water is a big no. The reason is what I have currently explained to you at the moment. So the correct answer for this one is option number C for CBI continuous bladder irrigation. As you can see, there are three ports. One is for urine drainage, one is for inflating the Foley's balloon, and the third port is for bladder irrigation, as you can check out in the image that is shown here. Yeah, Aishwarya made a very good point that glycine with monopolar cautery, and with bipolar cautery it is normal saline. So that's a very good statement that you would have read in your surgery notes as well, that yeah, glycine with only monopolar, and bipolar cautery it is normal saline to be used. So that's a very good input that has been provided. And appendix has a variable position, so yeah, has appendix, but it is always connected to the mesentery, na? Even if the appendix has a variable position, it would still be connected to the mesentery, and we need to fix the blood vessels or ligate those blood vessels before the appendicectomy can be done. Okay, so what you can see at the moment is a SPC, that is a suprapubic cystostomy. This is usually seen whenever there's a trauma to the bladder, and that's a two-way Foley's catheter that are currently shown before you. And then as far as Foley's catheter is concerned, they've asked about the French gauze. So French gauze would be like 0.33 millimeter in diameter. They asked about, like, is it the circumference, is it the diameter, and the colors of normal saline causes stones for long term. I think you were mentioning it the wrong way. Normal saline, you were thinking about the balloon being inflated with distilled water versus normal saline. We are not talking about the balloon inflation. We are talking about CBI, that is continuous bladder irrigation. And what you try to mean at the moment is normal saline causes crystallization of salt, right? So that's a totally different concept. Like, what is going to be used for inflating the balloon? Ideally, we should use distilled water, but practically is normal saline that is commonly used. So that is like the crystallization of normal saline concept of the balloon is totally different from what we are discussing at the moment. That's gonna be yeah, external diameter. Perfectly. And then the colors are very straightforward. That would be usually like 16 and 14, orange and green. That would be used. Male more, male M, and then orange, that would be more. So like orange is the color that we usually use, that would be 16, and for female it would be like green color. And the length of the female urethra will also vary. So I thought I should just mention this at the moment. The basic aspect to be remembered is CBI, continuous bladder irrigation, is done post URP, and that's totally different from the concept of that inflation of the bladder. That is yeah, Gori PB is the color that you can be using, but usually that Gori thing will not be, वो click ही नहीं करेगा ना, फिर वो दिमाग चलता नहीं है वहाँ पे ना. तो कि Gori PB is a very common thing on if you just search in Google Images, that's the first mnemonic that will come. But then it's the specific colors which are better to be. Even I could have written in a range only, but then what they ask is a common and a specific answer. So most of the time it would be like the orange or the green one that can be used. SPC indication would be one if there is like a damage to the bladder, right? If the bladder wall is totally busted due to trauma, that is when a suprapubic cystotomy can be done in a patient. Okay. Then is a question with respect to what is correct about the procedure that is shown. So you can see that the anastomosis in this patient is at three areas. I can say this is a triple anastomosis that is occurring. The anastomosis is occurring with respect to the pancreas and with the stomach, and then even with the liver of the patient. So the correct answer for this one would be D, that is a Whipple's procedure. The answer is option number D. The moment I said triple anastomosis, you were able to pick this up. Pretty straightforward data. Pancreatojejnostomy, that is one. Hepatico-jejunostomy, and then a gastro-jejunostomy that would be done. As far as Billroth 1 and Billroth 2 are concerned, Whipple's procedure is what we do for pancreatic cancer. And if you check out this diagram, you can see that what I've shown here is Billroth 1, which is a gastro-duodenostomy. And in the second one, you can notice that we are connecting it to the jejunum. So that would be a Billroth 2 procedure respectively. So in the image or the line diagram that is currently shown before you, it's like a triple assessment on the extreme right hand side. So I'm just mentioning three here. I can say the triple reconstruction that is occurring for Whipple's procedure for cancer of the head of the pancreas. Okay, so the correct answer for this one is D, that is Whipple's procedure, and it was an easy one. So let's move to the next one. That's another neck swelling that they love to ask, and this would be in the posterior triangle of the neck. So the swelling is gonna be increasing with crying, as you can see. And then the important thing is, if I say anything more, then it will become a little more troublesome, in fact. Okay, yep. So if I say anything more, it will become troublesome in a sense that then the question's answer will be out of the box. So yes, this is having transillumination positive, and because the transillumination is present, so this tells me that this is a cystic fluid, and because it's a cystic fluid in the posterior triangle of the neck, so the diagnosis of this case would be given as cystic hygroma. Now, cystic hygroma is a compressible swelling. It tends to increase with crying. That's okay. I mean, because there would be a venous engorgement, there would be increase in the pressure in the lymphatic system as well with Valsalva maneuver. So that that changes in the pressure with Valsalva maneuver, like coughing, crying, that can coughing, crying, Valsalva, they can basically be affecting the size of the cystic hygroma as well. And it does not have any cholesterol crystals. So this would be clear straw colored lymphatic fluid present. It's only it's like a lymphangioma, as I can say. So the correct answer for this is that this is a swelling in the posterior triangle of the neck, that is a cystic hygroma. But the examiner decided to put up options like whether it is gonna be having cholesterol or not. So brachial cyst fluid would be having cholesterol crystals present, but we don't have any crystals present with respect to brachial cyst per se. So you need to basically just figure out that this is a compressible fluid. It contains clear straw colored lymphatic fluid. That's one. And more importantly, what I've also done is mentioned regarding those swellings which are going to be having cholesterol crystals. So let's just quickly revise those that can be having cholesterol crystals. One would be a dermoid cyst, then is a craniopharyngioma. We'll talk about craniopharyngioma even the later part of this discussion. Then, as I was saying, brachial cyst, alphabet B, C, D, and R are to be remembered. Two B's are there, Baker cyst and brachial cyst. Then is craniopharyngioma, dermoid cyst, and rheumatoid nodules. They're all having cholesterol-rich crystals. And a medicine point I can say is every time you have is a rheumatoid pleural effusion, even that exudative rheumatoid pleural effusion can be having cholesterol crystals present. So the correct answer for this would be option number B. And what we can do in this is one option is obviously excision. Another one we can do is sclerotherapy in the patient as well. Okay, rheumatoid nodule is the most common extranodular finding that we see in rheumatoid arthritis. Absolutely right. So that same rheumatoid nodule is what I'm talking about. Okay. Moving to the next one, since you were asking about hydrocele, Then a question came up here. This guy is having basically a decreased sperm count and later on can develop even azoospermia. What you have in this patient is these dilated veins that can be seen on the testis, and that would be a varicocele. And if we are having a varicocele, then the problem is that even the temperature of the testis would be relatively higher as compared to what it should be, and that can explain why testicular atrophy, like you can see that it looks as if the testicular sac is literally empty because testicular atrophy could have occurred in this. So in varicocele, what you will get is a bag of worms appearance. We read bag of worms two times, one in medicine for the heart. If they say bag of worms appearance of the heart, that is ventricular fibrillation. I'll just write it down. I mean, we read bag of worms appearance two times. One is with respect to the heart, where the heart is twitching. That is what we read in medicine. That is ventricular fibrillation. And the second time we read about this bag of worms appearance is with respect to varicocele. And as far as A is concerned, that would be epididymal cyst. So it can be ruled out much more easily. The cluster grapes appearance. An epididymal cyst would require an ultrasound for a better evaluation of a testicular mass that a person has come to us. Yeah, a rheumatoid nodule is not in rheumatic heart disease. Absolutely not. A rheumatoid nodule is in rheumatoid arthritis, not in rheumatic heart disease, right? Not rheumatic, it is rheumatoid that I mentioned. Okay, so we are sorted for question number 8. The answer would be given as option number B, and we move to the next one. We have this 30-year-old guy. He comes to the hospital with pain in the scrotum. The testes is swollen. There's a lot of erythema over the scrotal skin. The inguinal nodes are not palpable at the moment, but the key word is that Prehen's sign, which is given. Because if I was reading about an acute scrotum, every time we get a question on acute scrotum, two differentials are always to be kept. One of them is going to be epididymitis and second is going to be a testicular torsion. So this, I think, is a very easy pick that you have to see, that the elevation of testis reduces the pain in the patient, which will make the answer as option number A. Whereas if I had mentioned in this question, or if the examiner had mentioned that the elevation of testis worsens the pain, then we would have answered this as option number B, that is a torsion of the testis. As far as option number C is concerned, lymphogranuloma venereum, it will present with inguinal lymphadenopathy as well as femoral lymphadenopathy. So the finding that we will see there would be called as groove sign. Why option number C is ruled out is lymphogranuloma venereum will present with a lymphadenopathy, which is not described in this question. I mean, lymphogranuloma venereum does not have any genital ulcer. The only STD that does not present with a genital ulcer is lymphogranuloma venereum. It rather presents with inguinal as well as femoral lymphadenopathy, and the inguinal or the Puppert's ligament between them. So that's why the groove sign would come up. And then testicular cancer will be having presence of an asymmetrical mass in the scrotum. And I mean, there could be lymph node enlargement again present with respect to testicular cancer. So, yes. In this case, it reduces the pain. The giveaway point, the pick-up point in the MCQ, buzzword you wanna call it, pick-up point. I call it pick-up points basically. That would be elevation of testis reduces the pain in the patient. Okay. The answer for this is option number A, and let's move on to the next one. So pretty straightforward, smooth going till now. A patient is coming with blunt trauma to the chest and he's having breathing difficulty also. Then the standard thing, he's going to waste my time by talking about trachea deviation to the contralateral side, and the breath sound in this patient is going to be distant with dullness to percussion. And then he's asking me regarding what is the next step in the management of this patient. And what I usually find is that suddenly the going was going great. And then people tend to rush into answer of a wide bore needle in the fifth intercostal space in the mid axillary line, which is totally wrong, guys. We will not be putting a wide bore needle because this case is not of check out the information, dullness to percussion. In pneumothorax, if it is pneumothorax and if it was tension pneumothorax, when do you say tension pneumothorax, one, the BP should be crashing. There is no crushing of blood pressure given in this question. That is point number one. The second thing is that there is no hyperresonant note that is given in this question, no absent air entry, no absent breath sounds. So the answer for this question is not option number B, because there is trauma to the chest and there is dullness to the percussion. The guy is having a hemothorax. And anyway, before we do all this, first thing to be done in any case would be to go ahead and put a X-ray to check out what is going on in the chest of the patient. So the correct answer for this question would be given as option number A. We would not be putting a needle, wide bore needle, for management of this case. And yep, if the guy is having a hemodynamic crashing, Once we put in a chest tube, depending on the amount of the blood in the drainage bag, we might have to go ahead and do a blood transfusion in the patient as well. But in this case, the first thing would be just do a bedside X-ray, no, because it would make it much more clearer to you, because you want to evaluate, is it hemothorax, is it pneumothorax? Because once a trauma case comes, it's not going to be only a guarantee that it is pneumothorax. It is not going to be guaranteed that it's going to be pneumothorax. I mean, we can do a X-ray and then we can evaluate it subsequently. And the trachea deviation to the contralateral side is again not a pointer towards pneumothorax, because even in hemothorax, the positive pressure will push the trachea to the contralateral side. Tension pneumothorax, I like to clarify for everybody again that tension pneumothorax, the first and the foremost thing is that the BP should be crashing. And second, he should always mention about absent air entry, absent breath sounds. Even when I took out those image-based questions a couple of days ago, people were messing up mainly on X-ray-based questions. So my suggestion to you is that if suppose this question got messed up, because one question like this or two questions like this will surely come, and that's gonna be getting them wrong does not make sense, because you're competing with best in the country. So what you need to do is just check out those X-ray based questions that I have taken even in the image based session, and they'll just make you feel much more confident, because though you read the theory multiple times, now if you go back to your notes again and read the same thing, it will not help you. But what will help you is the information that I'm trying to tell you at the moment, that is with respect to tension pneumothorax in a patient, where we would be putting is a wide bore needle. So that's okay. I mean, that's where yeah, hyperresonant note would be present in a pneumothorax, because air is at positive pressure. Now, pneumothorax is a condition where there would be air at positive pressure. Tension pneumothorax cannot be identified on an X-ray. It's a clinical finding. भाई कोर्ट केस नहीं करवाना मुझे अपने ऊपर में ना, इतना बड़ा डॉक्टर नहीं बनना है कि ऐसी सुई डाल दी है. ठीक है, तो बेड साइड एक्सरे करवा लो. इट जस्ट टेक्स अ फ्यू मिनट्स टू गेट इट डन. इट विल नॉट कॉज टू मच ऑफ चेंज. इफ द गाय हैज कम एंड यू वांट टू इवैल्यूएट अ ट्रॉमा पेशेंट, देन बी सेफ. Yeah, next step after the X-ray would be in this particular case, because there is a bleeding present, we'll assess the patient hemodynamically and we'll do a thoracocentesis. We can see the blood and then we'll put in a chest tube. I mean, for hemothorax, because it's a substantial amount of blood, so in this case, the management is intercostal drainage tube in the triangle of safety. And after putting the intercostal drainage tube that will evacuate the blood in this particular case, what we will do next is check out the amount of blood that is coming. So there's one more question on the same kind of aspect which is discussed later. I will tell you how much blood should be coming for you to decide that then thoracotomy needs to be done, because in some questions on hemothorax, answer will turn out to be thoracotomy. So I will teach you in like a couple of minutes from now in another question, when is it that you decide that you are going to be doing a thoracotomy in a person with hemothorax. But at the moment, because you said what is the next step in the management after an X-ray, we are going to be doing a intercostal, a chest tube would be inserted in the triangle of safety for management of these patients. So yes, very good. Akar Goyal, you are just combining the two things. It is so you guys are giving a good answer there. It is more than, अब तुमने बोल दिया तो मैं भी बोलता हूँ. It is more than 200 ml of blood in 1 hour. If it is more than 200 ml of blood per hour for 2 consecutive hours, जो ड्रेन का अमाउंट है, if that is more than 200 ml per hour in 2 hours, या फिर द ड्रेन अमाउंट इज मोर देन 1.5 लीटर, वो जल्दबाजी में उन्होंने टाइपिंग में ना वो दोनों दोनों लिख दिया, 1200 ml कर दिया. सो इट इज 1.5 सिंगल ड्रेन. एकदम से आप ट्यूब डाले, एकदम से 1.5 लीटर ब्लड आ गया. इधर इट इज गोना बी 1.5 लीटर ऑफ ब्लड, और इट इज गोना बी मोर देन 200 ml ब्लड कंटिन्यूसली फॉर 2 hours. दैट इज व्हेन यू नोटिफाई अ सर्जन, एंड दैट इज व्हेन you need to do hemostasis achievement, that is a thoracotomy. So I'll make a list, when do you do a thoracocentesis, where do you put a wide bore needle, and when do you do a needle aspiration. Question for you guys, in which variety of pneumothorax, I would like everybody to comment, in which variety of pneumothorax would you do a needle aspiration. Let's just invest a little more time here. Okay, because I had a bit of inaccuracies. A needle aspiration, yes, quickly guys. Needle aspiration for which variety of pneumothorax? Yes guys. Yes, your answer is right. It is progressive. It is primary spontaneous pneumothorax, which is of the large variety. If a person is having a primary spontaneous pneumothorax, PSP, that is when a needle aspiration is done. We can take a 20 ml syringe, fill it with a bit of saline, and then aspirate the air which is present, or use a 50 ml syringe. So needle aspiration is for a large PSP. That is one. Very good. Spontaneous pneumothorax. Yeah. Abhishek, you're right. That more than 2 centimeter from the radiological, but it is a large primary spontaneous pneumothorax where needle aspiration is done. But when you read about the word wide bore needle, and you read about this needle decompression or needle thoracostomy, that is gonna be answered only for tension pneumothorax. And the diagnostic criteria for both of them would be that because I'm saying pneumothorax, so in both of them, the air entry is going to be hampered, and at the same time, hyperresonant note would be present in a patient. So it is yeah, patient is unstable, then it is tension pneumothorax. And in both of these cases, ultimately a chest tube would be required. In both of these cases, ultimately, I'm saying initially, in a tension pneumothorax, patient would be requiring a wide bore needle. Ultimately, it would be a chest tube in both of those situations because needle तो छोटा सा है ना, वो कितना एयर निकाल लोगे, वो तो initial step हो जाता है. और large spontaneous pneumothorax, again a needle aspiration, but ultimately, even in a large PSP, ultimately treatment for this condition is a intercostal drainage tube. For treatment of tension pneumothorax, the ultimate treatment is intercostal drainage tube, and you have to connect it to a underwater seal drainage. So the main treatment, if he says what is the treatment that would be offered for these patients, the answer is going to be what I've currently mentioned before you. Then is a question in which he will ask you, when would you do a thoracotomy? So thoracotomy would be indicated in the following situations. Yeah. I mean that wide bore needle, fifth space, second space, वो तो बच्चों वाली बात होगी ना, वो अब we're not getting into it. That we are able to figure out. Thoracotomy, when we open up the chest in a patient, so the first indication for putting in a answering it as a thoracotomy would be that if it is a loculated empyema. If empyema is present, then it is again a chest tube. If he just says the word plain empyema, अगर सिर्फ empyema लिखा होगा, then it is again to be given as a chest tube. But if it is loculated empyema, then a thoracotomy would be required. Then is hemothorax, as I've explained. And this hemothorax is causing a substantial hemodynamic instability with respect to the volume. No, 1.5 liters of blood is a fairly large amount, so it's gonna be 30% of the total blood volume, or little less than 30%. So hemodynamic instability will start occurring in a patient. So it's a loculated empyema, it's a hemothorax, and then would be like, suppose a person is having a cardiac tamponade. Mark my words there. This cardiac tamponade that I'm describing is due to a stab injury. If tamponade is occurring because of, suppose he gives you a case where the tamponade is due to lung cancer, or if cardiac tamponade is occurring due to tuberculosis, then we will go ahead and do a pericardiocentesis in a patient. But suppose the chhati mein chaku maar diya and it has punctured the ventricle and the blood is now leaking from the ventricle into, or there was myocardial contusion, chalo, matlab if I'm exaggerating, the chaku went into the heart, there's a myocardial contusion and there was like blood leaking into the pericardial space, so we need to do hemostasis in those circumstances. So these are like issues where we do a thoracotomy in a patient. And then lastly is the word thoracocentesis. Thoracocentesis can be both diagnostic as well as therapeutic. This would be mainly done for patients of pleural effusion. I mean, whenever we're reading about thoracocentesis, the diagnostic or therapeutic, this would be mainly with respect to hydrothorax in a patient where there is like a fluid accumulation around the heart, which could be due to inflammatory causes. Usually in India, it is either going to be TB or it's going to be lung cancer. I mean, two important causes in India would be either TB or it can be lung cancer that is metastasizing. So I just thought that I mentioned this in one single slide where common things are mentioned, and the data in red that I've currently explained is like the main treatment which is to be done. And before anything, just do a baseline X-ray. Do a baseline X-ray, because without doing an X-ray, if you're trying to just fiddle around and say, okay, this is pneumothorax, this is hemothorax, it would be a combination of the two as well, no? So the main treatment would be that you might have to put two chest tubes in the patient as well. So the correct answer in this case is option number A, and that's a fundamental difference that I would like you to appreciate. And we move to the next one. Okay, so this question has already been answered by me, but still for the sake of completion, a hydropneumothorax doctor will put in a chest tube. If it is large hydropneumo, then we'll put two chest tubes. One tip of the tube will be up, the other will be down. The up one will remove the air and the down one will be removing the blood or the water or whatever is present in the chest. So again, a chest tube. We can put two chest tubes also, tip up and tip down, so that you can help evacuate a large hydropneumo. Okay. So you notice 500 ml of blood in the collection chamber in last 2 hours. That's more than the threshold that we discussed. BP is a little lower side of normal, so I need to be ready with a blood transfusion. So I'll notify the surgeon, and in this case, we will at the same time send the sample for blood grouping and cross matching as well. So yes, guys, perfectly right. This is like a case where there's an extensive trauma to the chest and there's extensive bleeding also. So the X-ray in this case basically exhibits a hemithorax, and this hemithorax that I've currently described is basically a hemothorax only because it is seen post-trauma. So the correct answer would be option number D. Okay, moving to the 12th one. This is regarding a child with biliary atresia, and you guys can quickly comment in the chat box regarding the presentation. Okay, great. Yeah, notify the surgeon because of the aspects that I said. The amount of blood loss is pretty extensive. A child with biliary atresia will usually present by approximately what time? Yes, yes. Quick answers, please. Hmm. Uh, it's always a cause of conjugated jaundice. It's always a cause of obstructive jaundice. The usual presentation will be by 7 days of life. The correct answer for this is option number A. Guys, if a baby is presenting within 24 hours and it is going to be unconjugated hyperbilirubinemia, then we always think terms of pathological jaundice. And option number A, I'm just rephrasing once again. If a baby presents in the first 24 hours of life unconjugated hyperbil, it's pathological jaundice. What is gonna be the most common cause of pathological jaundice? Quick answers, guys. What is the most common cause of pathological jaundice? Meanwhile, we're talking about obstructive jaundice, which is due to biliary atresia, where we do Kasai's procedure, right? That coltoenterostomy that they ask. This is usually by day 7 of life. The jaundice would be occurring. One of the highlights in this particular, no, it is RH incompatibility. The most common cause of why you get pathological jaundice is RH incompatibility. So that is one. Second, they ask about obstructive jaundice in a baby with biliary atresia. The day presentation would be on day 7. The presentation would be that the urine of the child will be mustard yellow in color. Normally, when the baby will pass the urine, the baby will pass the urine in the nappies only. And if you wash the nappy with water, the stain of the urine will go away. But in this case, you will always be having is a diaper staining. So mother will always say that nappies or diaper staining is present. Like normally जो urine होता है यार वो तो अगर पानी से धोते हैं तो बच्चे का urine का जो stain होता है वो निकल जाता है. But here what will happen is that in the nappies of the child or in the diaper, the stain will be present. So that is like she says, I washed it with detergent, but that yellow stain is present. That is bilirubin in the urine. Then they ask about investigation for this condition, that is HIDA scan. And then they ask about portoenterostomy, that is Kasai's procedure. And they have also asked this should be done before, your answer would be before 3 months of age. Otherwise, like biliary cirrhosis can be a manifestation that is occurring in this patient. So answer would be day 7. As far as option number C in this question is concerned, that is presentation of congenital hypertrophic pyloric stenosis. That would be a projectile non-bilious vomiting. Option number C of this question is CHPS, which has to be remembered. Biliary atresia, because it will take some time. Now the bile has to flow out, right? If there's the biliary radicals that are going to be present, so jaundice will take some time for the bilirubin values to rise and the baby to appear yellow. Ekdam say yellow the extensive hemolysis. If the baby is turning yellow on the first day of life, then it is always pathological jaundice. And that would be RH, क्योंकि बहुत सारे आरबीसी टूट जाएंगे ना. But liver has जो पहले अनकॉन्जुगेट बनता है फिर कॉन्जुगेट बनता है, so it will take some time for the conjugate values to rise. So the manifestation would not be occurring immediately. Answer is B to this one. Yeah. Why not day 1 is अभी explain किया ना कि day 1 पे अगर होता है तो it is the RBCs that are getting burst, no, that is unconjugated. तो पहले unconjugated बनता है फिर conjugated बनता है. Liver has the capacity. Liver will take some time for conjugation, ना. Suppose you are saying, sir, why not conjugated on the first day? So it will take some time. First unconjugated is formed, then conjugated is formed. So liver biliary radicals, if they're not working, it will take some time for the entire system to contribute to conjugated bilirubin to rise. But if it is bursting a large number of RBCs, then first day presentation is seen. Yes, the most common electrolyte derangement that would be seen in infantile hypertrophic pyruvate stenosis. I think that's again an easy one because he's losing acid from the body. Because he's losing acid from the body, because he's vomiting again and again, the most common derangement that would be seen in this case is low chloride. Apart from this, obviously, you will be having is the following statement. So I would just like to complete this. There is hypochloremic, chloride is lost. Then there is loss of acid also, so there will be a metabolic alkalosis. Along with this, because aldosterone will become high, so aldosterone will cause urinary loss of potassium, so hypokalemia. The reason for the hypokalemia is the kaliuria component which is present in this patient. And along with this, yes, Sunny got it spot on. There will be paradoxical aciduria. Why are we calling it paradoxical is because ideally in alkalosis patient there should be urinary loss of bicarbonate, but here there is a urinary loss of hydrogen that is occurring because of the action of aldosterone. Both of these are primarily because of aldosterone increase in this condition. And the last thing would be, you guys can help me out. What derangement is seen in these patients? Why not see? Because potassium को lose होने में time लगेगा. Because first he will vomit, then dehydration will set in. Because of the dehydration, the aldosterone will rise. So aldosterone will take some time for the potassium to be removed. So why not low potassium is because you can see the sequence. No, he will vomit, then he will become dehydrated, then hyperaldosteronism, then urinary loss of potassium and hydrogen will be occurring. Yes, the answer for this is A. And what will happen to serum calcium in these patients? Guys, quickly, especially ionized calcium. Yes, guys, what is going to happen to serum calcium in these patients? Metabolic alkalosis always causes redistribution of calcium. Ionized calcium will also become less, so there would be a hypocalcemia. Yes, even calcium is going to be less in these patients as well. Great. So yeah, and now quickly comment regarding what fluid should be given in this patient to correct these electrolyte abnormalities. Which fluid should be given to correct these electrolyte imbalances? You want me to give options, right? Normal saline, ringer lactate, normal saline plus KCl. Quick answers, please. Yes, the fluid of choice in this case is not ringer lactate, it is normal saline. Normal saline will provide both sodium as well as potassium because hyponatremia is the trigger. Hyponatremia is the trigger for development of dehydration and hyperaldosteronism in a patient. So first we will be giving normal saline in the patient. We don't need to even give normal saline KCl to the patient because if you treat the dehydration, the urinary loss of potassium will stop by itself. So it is plain normal saline that is alone sufficient to treat this condition. What is the fluid of choice for metabolic alkalosis? Fluid of choice for metabolic alkalosis. Yes, isotonic, 0.9% only, standard. Okay. What is the fluid of choice for metabolic alkalosis, guys? Yes, absolutely yes. Hypernatremia. Somebody asked, when do you give N by 2 in 5% dextrose? That is for a patient who's having hypernatremia. Yes, we can give normal saline in this patient, and that is more than sufficient to treat the metabolic alkalosis component. So the correct answer for this is option number A. I think we're sorted for this one. Yeah, I mean, I take your point. We can be using isotonic N by 2 saline, considering that this could be a child and therefore lesser amount of sodium correction would be required in a patient. So yes, I mean, I understand that N by 2 component, why it is coming up in a question. But my general statement was, what is the main fluid that we'll be using in our case? That's gonna be normal saline for correction of metabolic alkalosis. So perfectly fine. From the options that I put up, it is NS. Otherwise, we can use 0.45 initially for correction of these patients. Okay. Yes, Boni, you are right. Metabolic acidosis is ringer lactate except DKA, where we use normal saline again. Okay. So the next one is mermaid syndrome, and we have cyanomelia in this case. And he has asked regarding which of the following would be a correct, not correct about this condition. So we are talking about cyanomelia. It is a defect of gastrulation. Gastrulation means that we are having formation of those three important layers: ectoderm, endoderm, and the mesoderm. And yes, this is defective gastrulation cyanomelia. It has a persistent vital line artery. Because of that persistent vital line artery, also the problem is occurring. No, because it causes a vascular steal phenomenon where the blood supply from this artery tends to divert the blood away from the caudal structures, and therefore the legs or the limbs will not be developing properly. And the usual reason why it can be lethal is because there can be renal agenesis, there can be like a pulmonary hypoplasia present in this case, and we can diagnose it with the antenatal. We can diagnose it by antenatal ultrasound as well. So the three options which are correct for this condition would be the ones that I mentioned. The correct answer for this would be option number A. In sacral agenesis, then the back of the patient or X-ray will be shown. X-ray sacral agenesis is diagnosed on basis of an X-ray of the lumbosacral spine. It is not diagnosed by a physical appearance, right? Sacral agenesis, which is a characteristic neural tube defect that is seen in an infant or diabetic mother, is seen on a X-ray of the lumbosacral spine. It would not be diagnosed on like a gross physical examination in this case. So no, focomelia is different, man. Focomelia mein to arms chote chote honge na. Like focomelia would be like this. Like this is the body, this is the trunk, and then there would be hands which are attached like this. In this case, everything is fine. I mean, the upper limb is fine, the arms are perfectly fine. And then this looks like a fish, no? That's why we're calling it a mermaid, no? Because the legs are not affected. So there's a gross difference between the ones like the focomelia part and the one that I mentioned in this case. Yeah, this is more like a seal. Yeah, mermaid. No, mermaid नहीं होता जैसे Disney park you go or amusement parks you go. There's a mermaid, like this half fish and half human is the folklore which is present there. So the total two different things. This would be phocomelia and this is the sirenomelia part. And you need to remember this is the defect of gastrulation and then is failure of closure of posterior neuropore. This is going to be neural tube defects, man. This is going to be neural tube defects. So the current defect that we're discussing is not a neural tube defect. What we're discussing is the vascular steal phenomenon. There's a persistent vital and artery. It is diverting the blood supply away from the limbs. So limbs bana hi nahi. I mean, the feet of the child or the toes of the child are not getting developed. It's just like a seal which are present in this particular case. So the current image that is given is a sirenomelia. It's a defect of gastrulation and the remaining aspects that I said, but it is not a neural tube defect. Pulmonary hypoplasia is very common in any congenital malformation, or renal agenesis and pulmonary hypoplasia, because if the development of the patient is not fine, one reason I can say is the peripheral resistance in the body will not be like a normal peripheral resistance. So the lungs will not be able to form well because lungs would need some kind of, the pulmonary circuit is dependent on the normal systemic circuit. If the normal systemic circuit will not develop, then pulmonary hypoplasia is a common. Like anytime you read about any congenital malformation, no, pulmonary hypoplasia is usually associated because if the systemic circuit is affected, the pulmonary circuit also gets affected. Okay, so next is an easy question. I think everybody can pick up these muscles. This is supraspinatus. Okay, then is infraspinatus. And all you need to pick up is teres major and teres minor respectively. So the muscle that is present inferiorly, the one that I'm putting my mark at the moment, this is teres major. And you guys can comment what is the nerve supply of teres major. You guys have got the question correctly. It would be responsible for internal rotation of the shoulder. And teres minor, the way it is inserted, the one that I'm showing in yellow, it would be for the external rotation of the shoulder. One is internal and one is a external or a lateral rotation of the shoulder. Quick comments there. The one that I marked in yellow would be teres minor. And the one that I marked in red inferiorly is teres major. Quick comments with respect to what is the nerve supply of teres major. Teres major, okay, quickly comment with respect to teres major would be inserted into which, inserted site of insertion of teres major, that is one, and what is the nerve supply. Okay, very good. I think Sunny was the first one to come up with the correct answer for the nerve supply as well, because TDs if they're asking you about muscles which are related to the back, related to the scapula, then these are like common things that would be anyway asked to you. Okay, this is triceps, the one that I marked at the moment with the star mark. This would be called as the long head of triceps. And the one that I marked with the arrow like this, that would be the lateral head of triceps. So obviously, like, the muscles are pretty straightforward ones. Inferior to this, there would be one more muscle also, latissimus dorsi, that I have not shown in this particular diagram. The question of mine was, what will be the nerve supply? Okay, zooming it out. One is the long head, where the star mark is long head of triceps, and the lateral head of triceps, that is one. And my question was, what is the nerve supply of teres major? So for teres major, guys, the nerve supply would be subscapular, and for teres minor, it would be the axillary nerve. So I think it was going vice versa, or maybe like the comments were okay, but you did not mention for major or minor. So A, the teres major part is gonna be subscapular, and teres minor is axillary. And teres minor, as I was saying, it is for minor. Teres major is for medial rotation. So that would be the medial lip or the bicipital groove that was inserted into the humerus in the upper part. And teres minor, if you check out in the diagram once again where it is inserted in yellow, you can see that it is inserted on the back side. So it will be responsible for the lateral rotation part. So just a bit of point regarding teres major and minor among the back shoulders, which has to be remembered here. Okay, answer to this is option number A, and we are sorted for the current image. Moving to the next one, again a very straightforward one. He says, what is the condition which is shown in this case? Quick answers there. Hit the comment button, guys. I think irrespective of whether you are a NEET PG student, FMG student, whether you are a third year student, this is something which you don't need too much of effort to focus on, and you can be answering this very, very easily. You can see adult patient, and the adult patient is having on one side, the shoulder is a little on the lower side, and the the aspect that is mainly focused. Yes, absolutely. You cannot see the scapula in this case. You cannot see the scapula in this case. So if there was, this is not winging of the scapula. Winging of the scapula के लिए the patient should be pushing the wall anteriorly and the scapula medial blade should be visible. This is simply a dropped shoulder. The reason for this dropped shoulder can be that the person ended up with injury to his spinal accessory nerve, and that could have damaged the trapezius muscle. And as a result of this, dropped shoulder as a manifestation is developing. Let me just clarify this once again before you. If they give you an image where the person is pushing into the wall, like here, the doctor has asked the patient to push into a wall, and there is an injury in the long thoracic nerve, the serratus anterior muscle or the boxing muscle is affected, that is when you will be getting this winging of the scapula. But if it is gonna be spinal accessory nerve, then it is gonna be the manifestations of dropped shoulder. And somebody said, why not kipple feel, why not sprangle deformity? तो भाई पहली बात तो बच्चे में होता है, और उसमें दोनों जो स्कैपुला है वो तो स्कैपुला की जो पोजीशन आपको दिखाई देगी ना, आप ये दोनों डायग्राम देखें ना, स्प्रेंगल डिफॉर्मिटी इज वेयर यू विल बी एबल टू चेक आउट द स्कैपुला व्हिच वाज नॉट वेरी मच विजिबल. सो इफ आई चेक आउट द प्रीवियस डायग्राम, देयर द स्कैपुला part was not very much visible, it was only a dropped shoulder that was happening. But if I see that there is a failure or descent of the scapula is very much visible and there is also a shoulder drop on one side, then I'll say it's a sprangle deformity. And then if it is associated with cervical vertebral fusion, कि गर्दन भी छोटी होगी, if it is associated with cervical vertebral fusion, then it becomes Klippel-Feil syndrome. So the main aspect to be remembered is, yes, Gautam, you gave it spot on, right? That sprangle deformity is gonna be mainly related to the image showing two scapulas at two different levels and one shoulder will be down. And if it is associated with the cervical spine fusion as well, that the neck is very, very short, then we'll say it is Klippel-Feil syndrome. So first and foremost for Sprengel and Klippel-Feil, very specifically, they would be giving you questions from the perspective of a child. बच्चे की फोटोग्राफ दे देगा. हमारा जो पेशेंट था उसे यार स्पाइनल एक्सेसरी नर्व इन्वॉल्व हो गई ना, वो ट्रॉमा हो गया स्पाइनल एक्सेसरी नर्व, उसका रीजन जो भी रहा होगा, दैट कुड बी अ ट्यूमर, इट कुड बी इंजरी, इट कुड बी स्पोर्ट्स रिलेटेड इंजरी, बट देन द इमेज बेस्ड क्वेश्चंस वुड हेल्प यू डिफरेंशिएट बिटवीन ऑल फोर ऑफ दीज. तो क्वेश्चन में हमेशा याद रखना कि देखो जो सबसे सिली मिस्टेक मैं बोलूंगा यहाँ पे ना, वो है विंगिंग ऑफ द स्कैपुला वाली. If not every image that they give of the back of the patient is winging of the scapula. That is message number one. Second is, do check out the positions of yeah, yes, Steve, right. No neck is visible like I have shown in the image here, like गर्दन ही खत्म हो गया ना. So those differences are the ones which are mainly to be focused. So finally, guys, I think we are coming to the conclusion here. The answer for this is option number A. And ये तो मैं ऐसे बोलूँगा, this image irrespective whether you're an FMG student, NEET PG student, ये तो गलत होने का मतलब ही नहीं बनता है यार. मतलब we have to get it spot on. And if you are just gonna focus on these images, you would be able to identify this relatively better. लो पोस्टीरियर हेयरलाइन एक्चुअली क्या है यार, वो ना इतने सारे सिंड्रोम में लो पोस्टीरियर हेयरलाइन लिखा होता है. You know, there are so many syndromes in which he mentions that word low posterior hairline, that you know, to use it as a discriminating factor somehow, मतलब मेरे को जस्ता नहीं है. मतलब if they have told you in some kind of a discussion, I'm okay with it, but I think that we need to focus on the discriminatory aspects that I'm trying to say here. So they give you बच्चा with the unequal position of the scapula, then it is like sprangle, और गर्दन का neck vertebra भी fusion है, then we think in terms of okay Klippel-Feil as well. Okay, जी. Okay, so the epithelium that is shown here is having a peculiar appearance. If I draw it before you, these would be the cells that I am trying to show, vertical arrangement, then horizontally arranged. Everybody is hitting the comment button in this case very, very beautifully. So I'm really happy for that quick comments that are coming in. So this is the nucleus that I'm showing. And then the way the orientation of epithelium is slightly changing. So this would be this would be answered as a transitional epithelium. I'm going to change my diagram now, and if I'm going to give you cells like these, just be patient with me. Then I will say that this is going to be stratified columnar epithelium, stratified columnar. But if I give you these cells, but the nuclei are at different level. The nuclei are at different level. Like if you check out the nuclei, then that would be pseudo-stratified columnar. Pseudo-stratified columnar. The bottom line is that when it comes to the first one is the transitional one. Okay, I'll just write it down here. The first one that I've shown is the transitional one. Then is yep. Let me just check out. Yes, yes. This is the stratified columnar one. Stratified columnar. and this is pseudo-stratified columnar that I've shown, where the level of the nuclei in stratified columnar at least 2 layers will be present. Stratified columnar में कम से कम 2 सेल का लेयर ऐसे अलग अलग होगा. Pseudo stratified में क्या होता है, एक ही लेयर होता है, single layer होता है, and that single layer will be having nuclei at different levels. So I'll show you the image also, that will make it much more clearer to you, because जो questions आए हुए ना पिछले सालों में वो यही वाला, या तो transitional देता है या वो pseudo stratified columnar देता है from the trachea or the airways. Basically, either he is going to give you transitional epithelium from the bladder, or he is going to give you pseudo stratified columnar. The correct answer for this one to be given is option number D for option number C for the current one that I've currently discussed before you. And I'll now be giving you diagrammatic representations for the next one. The first one is columnar epithelium, easy to identify. I mean that physical appearance of the cells, the columnar epithelium that is present. Then you can see 2 layers present here, like, you know, one cell, and then this would be the next cell that is present. It is having cilia also, so ciliated columnar. And then if I look at the extreme right hand one, there the nuclei are at different level. It's a single cell only. It's a single cell only, but it is the nuclei are at different levels, so we will call it a pseudo stratified columnar. So the difference is, somebody said, what is the difference of transitional epithelium? It is plasticity. No, it can get deformed, like urinary bladder gets distended with urine multiple times. So if you look at the arrangement, this is vertical arrangement, horizontal arrangement. Then if you check out this particular diagrammatic representation, vertical, horizontal, horizontal. So this kind of epithelium is is capable of getting stretched and then comes back to its original size. That's the highlight of a transitional epithelium. But when it comes to columnar and these are much more fragile. I mean, they would not be in a position to get stretched. And the physical difference is what I have described here before you. My final suggestion to you is transitional epithelium and pseudo stratified columnar are two that should always go correct, because they are the ones which have been commonly asked in the exam. Okay, moving to the next one, he says which defect will occur due to lack of fusion between the metanephros and the ureteric bud components and would be presenting with hypertension. Okay, yes guys. Quick answers in this case, lack of fusion between. Okay, so I'm getting multiple answers for this one also. If you check out this one, there is a unilateral renal agenesis. Like one kidney is not there at all. And kidney is derived from where? Metanephros. So person is having like there are 2 kidneys, 2 metanephros, metanephric blastomers are used to develop the 2 kidneys, and one side there is none of them present. So renal agenesis is present in this particular case. And then you are having duplication of the collecting system. You can see that there are two ureters which are present here. The question is with respect to what is due to lack of fusion between the metanephros which is forming. What does metanephros form is the following things: glomerulus, proximal tubule, loop of Henle, distal converted tubule. All of this infrastructure is formed by metanephros: glomerulus, proximal tubule, loop of Henle, distal tubule. The ureteric bud would be responsible for the collecting duct onwards, like collecting duct, then it is the renal pelvis, and then subsequently the ureter part. So if there is a failure of fusion between the filtration system and the collecting system, then the kidney that develops is called as polycystic kidney. I repeat that again. There is a collecting system of the kidney and there's a filtration system of the kidney. If there's a lack of fusion between the collecting system and the filtration, the filtration system is glomerulus onwards. The filtration system and the collecting system fusion is not occurring, then we call it polycystic kidney. So the correct answer for this question would be given as option number B. And you just have to read the words carefully. Lack of fusion, that's the word that was given. It was not written abnormal fusion. Suppose the question mentioned that the kidneys could not extend to the normal level, and there is a lack of, and there is a fusion present at the inferior pole of the kidney, then I'll say horseshoe kidney, as you can check it out here, right? You can check out here, that's a horseshoe kidney. So if it was an abnormal fusion happening in the lower pole, then I'll say horseshoe. But here the question was lack of fusion. That is going to be occurring between the metanephros and the ureteric bud. Then it will become polycystic. And in polycystic kidney, one of the presentation is hypertension. Now that's a separate issue. Whether it will be autosomal recessive variety, whether it will be autosomal dominant variety, that is a separate issue. That it depends on the genetic reasons. That whether if it is autosomal recessive, it will have a pediatric presentation. If it is autosomal dominant in inheritance, it will have an adult presentation. But the difference to be remembered would be, the difference, the main reason for the difference in presentation or age group of presentation is the genetics behind it. but it will present with development of hypertension in a patient. So the correct answer for this question is option number B, as I've explained to you. And one more point that I wanted to remember is for the horseshoe kidney part, that horseshoe part kidney would be having that isthmus at L4 level. So you guys, without checking out this slide, let me know which is this blood vessel, which is this blood vessel which is limiting, the, if you can see the red, which is basically limiting the ascent of the kidney to a normal level in horseshoe kidney. Very good. The answer in this case would be inferior mesenteric artery. Spot on, man. Inferior mesenteric artery. That's going to be limiting. That's the important statement to be remembered. It is just below the origin of the inferior mesenteric artery, and horseshoe kidney will be then associated with Turner syndrome, trisomy 18, Wilms tumor, to name a few. The clinical manifestations would be mostly in the form of UTIs, because any malformed kidney will increase the risk of UTI, hydronephrosis stones, or even gonna be contributing to vesicourinary reflux. So they love to ask about horseshoe kidney malformation seen with Turner syndrome, where earlier they used to ask regarding was that flower vase appearance of intravenous pylography. But now that intravenous pylography is not done, so they tend to ask regarding the embryological aspect. So two parts in the kidney which I want you to be very good is, one is the aspect related to horseshoe kidney, which you have answered beautifully anyway and were present on the slide. And second is the polycystic kidney development part, which I've currently explained to you at the moment. Okay. Moving to the next one, we are having these various triangles in the neck, and he's saying what is correct about the triangle which is marked in orange. You can see an arrow at the orange triangle. This triangle would be called as muscular triangle. Gautam, because it's a genetic defect, no, where mesoderm derivatives are affected. So like liver, kidney, they tend to, liver, kidney, pancreas, spleen, lungs, they tend to develop at almost the same time, no? So most of the time the malformations would be seen in the liver and the pancreas and the spleen, along with that in the kidney. But as far as lung cysts are concerned, they're unlikely. No, in polycystic kidney, we usually don't get lung cyst. We can get dural cyst, that is okay, but not lung cysts in a patient. Yes, in the muscular triangle, bhai, yahan pe ho jayega na, that would be the thyroid and the parathyroid gland. The correct answer for this would be option number A, the content marked in the triangle of the patient. Carotid artery to bachche upar jaake hogi na. Carotid artery would be like this. I'll just mark it here. I mean, the blood vessel that would be going up here would be like the common carotid artery. So I'll mark it here. This is common carotid. And this common carotid will then bifurcate into two, no? That is the internal carotid and the external carotid artery. So they're like, if this marking that I'm doing here is of the common carotid artery, the marking that I've done is of the common carotid artery. I am talking about what is present here. Internal carotid to upar jaake hogi na, that will enter into the base of the brain and will supply. So what is going to be related to this is not going to be the internal or the external carotid. It is this blood vessel that I'm showing here is the CCA, that is the common carotid artery. Exactly, it goes up in the carotid triangle, no? The carotid artery would be in the carotid triangle, that is the blue triangle which is present. So in this particular case, marking नहीं तो एग्जाम में मार्क ट्रायंगल, यार ये तो मार्क ट्रायंगल है ना, एरो बना हुआ है ना यहाँ पे. तो the correct answer for this would be option number A, parathyroid gland, and the thyroid glands are the ones which are present here. अच्छा, blue arrow नहीं था. Okay, so you get 1 mark extra for that. Okay, fine. Answer to 19th is A. Fine. Triangles, I think you are very, very clear. This is the digastric triangle, so I'm writing D for it. Then is the submental triangle. That's, I don't need to even write the submental triangle. And then we are left between the carotid triangle and the muscular triangle at the moment. And this muscle that we are talking about is omohyoid. We have a superior belly of it and we have an inferior belly of it. That forms an important part of the boundaries of the various triangles that you can see, the carotid as well as the muscular triangle. So do remember about it. And yeah, quick comments regarding this triangle. This is present in the posterior triangle, that I know that this is in the posterior triangle, but can you comment on the yellow marking that I've done before you? Okay, quick answers please, guys. If you check out this particular yellow marking that I've done here, yeah, yep. Yes, we would be calling this as, yeah, it is supraclavicular, I understand, but sometimes it is written as subclavian triangle as well. So I agree, like supraclavicular area, supraclavicular fossa, but at the same time, this is also referred as a subclavian triangle. One more triangle added to your vocabulary. I mean, that part, what you said, supraclavicular is perfectly okay by English. I agree to it. But sometimes the word used is subclavian triangle. एग्रीड गाइस, वो मैं मानता हूँ सुप्रा क्लाविकुलर तो इंग्लिश से हो जाएगा, वो जानबूझ के सुप्रा में की जगह पे सब लिख देगा ना. व्हाट आई एम ट्राइंग टू एक्सप्लेन इज कि वो सुप्रा वर्ड तो इजी हो गया ना हमारा, तो वो जानबूझ के सब क्लेवेंट ट्रायंगल लिख देगा. Yes, this can contribute to issues because brachial plexus is going through this area, so injuries in this part of the neck can be pretty nasty as far as the arm part is concerned. The answer to our question would be option number A, as we have discussed, and let's move on to the next one. You are having a patient who is a construction worker and he is a smoker also. So the question that is being talked about is regarding thromboangiitis obliterans. Thromboangiitis angiitis obliterans is also called as Burgess disease, and this blood vessel that we're talking about is called as dorsalis pedis artery. The question is saying that what is going to be wrong with respect to this blood vessel dorsalis pedis. So how do you identify dorsalis pedis location? You will ask the patient to dorsiflex the big toe. You'll ask the patient to dorsiflex the big toe. So you can see a tendon present here. This tendon that I'm currently marking before you, the blood vessel is going to be present lateral to it. So there is going to be a tendon extensor hallucis longus. So this is the correct statement, lateral to the tendon of lateral. This is the tendon you can see. So it is lateral to the tendon. So option number B is correct. This blood vessel is a continuation of the anterior tibial artery. That's okay. And it runs along with the peroneal nerve, deep peroneal. I'll show you the image of deep peroneal nerve. But against which bone are you palpating this artery? So you are palpating this artery against two bones, that is navicular, and second you are palpating it against the medial cuneiform bones. Dorsalis pedis artery is palpated against the navicular bone. Yes, Yasmin, you're right. Asif, you're right. Dorsalis pedis artery is palpated against the navicular bone and the cuneiform bones, and not against the cuboid, because cuboid तो यहाँ side में हो जाएगा ना, laterally हो जाएगा, और ज़्यादा lateral हो जाएगा. So it is navicular and the cuneiform bone. So the correct answer for this is option number A. मेटाटार्सल हेड फिर और भी आगे चला जाएगा ना यार बच्चे, थोड़ा उससे पहले हम बात कर रहे हैं ना, मेटाटार्सल तो उसके बाद में शुरू होंगे. सो द डोर्सालिस पेडिस आर्टरी इज palpated against the navicular and the cuneiform bone. The correct answer for this is A. And what we need to do is, if we just check out this diagram, yes, it will be in 2 sessions, guys. Doing it in a single session will take too much of energy of yours and mine. I mean, if you have to study other things also, then this is an important week that you have to study. So I think we can do it in phases. Okay. Okay, Ji. So the tendon that I was talking about is extensor hallucis longus, that is one, and extensor digitorum longus. So there are two of them. One is laterally located, one is medially located. So एक तो वो भी याद रखना है कि भाई obviously वो नाम से पता चल ही जाएगा. You'll be able to figure it out, extensor hallucis longus and then digitorum longus respectively. Then there's a nerve that is going along with this. The nerve that we're talking about is the deep peroneal nerve that I was talking about, and along with that is the artery. This artery will then give off branches, that is arcuate, that will be supplying the toes. And if this artery will become narrow, then you can understand there is a big risk of digital gangrene that can be occurring in a cigarette smoker. The test that we do for quick answers, please. What is the test that is done for diagnosis of Burgess disease? Test for diagnosis of Burgess disease. Quick answers, please. Yes. Quick answers, please. Yeah, you'll be doing a Doppler, और Doppler करके चलो अगली slide पे लिख लेते हैं. The answer for this question is A. No, not biopsy, man. We in thromboangiitis obliterans, the test that we'll be doing, this is along with the deep peroneal nerve, so we have to be careful about not taking any biopsy from this area. It can damage the nerve as well. We don't do a biopsy, right? The diagnosis in this case is basically a Doppler, and this Doppler will be then be able to calculate for us ankle brachial index. How much is the normal brachial index quickly? No, we don't do angiography, and we do not do a four-limb angiography and a CT angio. All of them would be given. It's a Doppler only. We calculate ankle brachial index. Yes, guys, ABI. Normal ankle brachial index would be always more than ankle brachial index. Normal बच्चे, normal is always more than 1. Normal ankle brachial index is more than 1. Burgess disease is diagnosed. If I say, when do you say Burgess disease, then your answer is less than 0.9. So please be clear. If he says normal ankle brachial index, मतलब check the BP in the legs. In the BP in the legs is more now 140, and in the upper limb is 120. So normal is always more in the legs. So value is more than 1. If it is less than 0.9, that means Berger. And if it is less than 0.3, that means it is critical ischemia. This critical ischemia would mean that there is a high risk of development of a digital gangrene in this individual, digital gangrene in this patient. Yes, critical 0.3, 0.4, that's okay. Everything is expressed in a range, so that's okay by me. If it's in 0.4 in your notes, that's perfectly fine. But normal was not 0.9 is what I wanted to bring to your attention. Tell me the surgery that would be done in this patient. If there is development of critical ischemia before the development of gangrene, what surgery would be done? Yes, guys, surgery to be done in Burgess disease. ओके एम्पुटेट एम्पुटेट भैया गैंग्रीन नहीं हुआ ना अभी गैंग्रीन होगा तो एम्पुटेशन करेंगे ना एम्पुटेशन से पहले इंटरवेंट कर लेंगे ना तो ऑपरेशन का नाम बताओ ना हाँ जी आई थिंक somebody answered it very correctly we'll go on with the procedure that is called as lumbar sympathectomy the main surgery that is done in Burgess disease is lumbar sympathectomy if you just go by English no lumbar sympathectomy if you go for sympathectomy you are cutting off the nerve supply to uh, I mean, you're cutting off the sympathomimetic stimulation, which is causing vasoconstriction. So the blood vessels will dilate and the blood supply in this case will improve. So it's a lumbar sympathectomy, which is done in this case. Yes, most guys have given this correct. That's the surgery that would be done. And one of the side effects of this surgery has also been asked, that is retrograde ejaculation. The sex life of this person will be affected subsequently. So proper consent has to be taken, and if there is agreed digital gangrene, then we don't have an option, and we will go ahead with amputation in a patient. Okay. Moving ahead in our discussion. Yeah, L1 is one side to prevent, but that's a side effect of the procedure. Okay, so the bones of the foot are usually asked, and all you need to get used to is these bones which I mentioned as A versus B. A is the cuboid bone that is present laterally. I mean, the artery is going like this. I'll just mark the artery now a little more in a better position to mark it now. So this is what I was saying. This is my artery which is going dorsalis pedis, and therefore in this particular chart, we were saying that the bone that we are gonna be feeling is one the navicular part, and second is gonna be the medial cuneiform bones. So you can see the cuneiform bones anteriorly present. Okay, fine. Moving ahead in our discussion. Which muscle is marked below the nerve that is coming out. I've made it easier for you. The nerve that is shown is the sciatic nerve. So all you need to do is pick up the muscles in this case. And you can pick up gluteus maximus. And then you can be picking up is gluteus medius. We'll talk about one more question on gluteus medius also. Yeah, the muscle in this case is piriformis muscle. The muscle that you can check out here, just below that, the sciatic nerve is coming out is piriformis. If they give an arrow below this, if they give arrow just below this, I'll just zoom into the diagram. One possibility can be that the arrow can be in this area. Then if it is related to the nerve, then it is the superior gemelli muscles that I'm talking about. I'll just use a finer font size to mark it. And if the arrow is given just adjacent to this particular area, then it is quadratus lumborum. Usually because they love to ask about muscles which are related to the hip per se. So that's why I thought I should mention about it. Not quadratus, I mean, we're not talking about quadriceps femoris, I'm talking about quadratus lumborum. In this particular case, the answer is piriformis, it is gluteus medius, then is gemelli, superior gemelli, then is the quadratus lumborum muscle that I have said. Okay. Yeah, you can use any kind of mnemonics for it, but then I think that the orientation for like which muscle present and which nerve originating beneath it is the important one. The correct answer for this one is B. Okay. Okay, this would be quadratus femoris. We can move on to the next one. Meanwhile, I'll just correct it. Which muscle is called as kicking muscle, guys? Which muscle is called as kicking muscle? Question for you guys, kicking muscle. Leg में से kick मारते हैं ना इसे. So which muscle is called as kicking muscle? Yes, the answer is fine B, guys. Which muscle is called as kicking muscle? Yeah, quadriceps, more specifically, like quadriceps muscle is the quaking muscle. Yeah, that's okay. It is the kick जब मारेंगे ना यार, तो anterior compartment of the thighs होगा ना, so it is quadriceps, and more specific answer is rectus femoris. Exactly. जो जो anterior compartment of the thigh है ना, जैसे हम kick मारेंगे किसी को, तो it is from the anterior compartment thigh that the kick would come, so it is rectus femoris for the quaking muscle. That quadratus femoris is perfectly okay. It's rectus femoris as a specific answer. That would be quadriceps femoris, not rectus, not quadratus, but quadriceps femoris. Fine. Anatomy terms are always tongue twisting. And when you try to speak them in a hurry, it can cause errors. Okay, so person is having a waddling gait, and then this is an easy one. In fact, he's having waddling gait, and when he's able to stand, when he's asked to stand on the right leg, there is the pelvis drop to the left. Yes, guys, quick answers, please. Yes, 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 yes. I think this is a repeat question and is easy. The pelvic drop is occurring in the patient to the left when he's standing on the right. So it's a Trendelenburg sign that is happening. And the muscle that is involved in this patient would be the one on a particular side. That is, on whichever side there is going to be the pelvis drop, the muscle on the opposite side, which is the stabilizer, is the one which will be affected. The answer in this case would be option number C, that is right gluteus medius is the one that is involved. And in one of the sessions in the paper, like, he did not mention the name of the muscle, but what he did was, instead of mentioning the name of the muscle, he mentioned regarding the nerve supply of the muscle, that is superior gluteal nerve. And another session he mentioned regarding that this is going to be an abductor of the thigh as well. So I mean, that's perfectly okay. These are abductor group of muscles related to the hip, and superior gluteal nerve is the one, and the sound side would be sagging. Okay, and the muscle of the opposite side would be affected. So it's the superior gluteal nerve, and gluteus medius is the muscle that would be affected. Perfectly okay for this particular question. Additional question for you guys. In which condition do we do a Trendelenburg test? This that I'm describing before you is Trendelenburg sign, but Trendelenburg test 1 is done for. Okay, I'll say that once again, Yugal. The basic thing is कि जैसे उसको we ask the guy to stand on the right side, so pelvis is sagging on the left side. So to prevent that sag of the pelvis on the left, the muscle on the right side is weak. So it's always gonna be like the side on whichever you are asking the person to stand on, that side muscle is weak. That is why on the opposite side the pelvis is sagging, because it's like a fulcrum, right? So pelvis is sagging on one side. That sag that is happening is because of the muscle on this side is not strong enough. Yes, varicose. Trendelenburg test is done for patients who are having varicose veins. Trendelenburg 1 test is done for, and Trendelenburg 2 is done for. Quick answers, please. Trendelenburg test 1 is done for, Trendelenburg test 2 is done for. Yeah, varicose veins is perfectly fine. Trendelenburg test 1 is for varicose veins which are gonna be having a saphenofemoral junction incompetence. Trendelenburg test 1 is for saphenofemoral junction incompetence. Yes, saphenofemoral junction, perfectly fine. And the second one would be perforator incompetence. That would be below knee, basically, that the perforator incompetence would come up. So Trendelenburg test is always done for VV, that is for varicose veins. Very good. Moving to the next one, there is the image. I'll zoom into the image here as well. This is the urinary bladder of the patient. And from the urinary bladder, you can see this structure, which is gray. And this gray structure is going all the way to the umbilicus of the patient. So the question is saying regarding, it's more of an embryology based question, a structure which is present. Yes, this would be urachal remnant that we're talking about. The correct answer for this would be option number A. Rathke's pouch is related to craniopharyngioma, so that is immediately ruled out. And cloacal pouch will be related to the rectum, so that is also ruled out. So two options we could rule out immediately were Rathke's and cloacal pouch, which are related to rectum and craniopharyngioma respectively. It was either a vito-intestinal duct, which is Michel's diverticulum, and urachal remnant related to the urinary bladder. Uh, the Trendelenburg test. So that would be like we'll make the patient lie down, then make him stand. We'll cite some tourniquets as well. So it's just that you have to remember one is upper and two is niche. So one is for saphenofemoral junction incompetence, which will cause the varicose veins to fill from the top if it's a saphenofemoral junction, because that's the connection between the deep veins as the superficial vein. So if it fills from the top, it is saphenofemoral junction incompetence, that is Trendelenburg test 1. And if it fills from the bottom upwards, then it is Trendelenburg test 2 for varicose veins. Okay. Moving to the next one, which is not a feature of von Gierke's disease. This is a glycogen storage disorder that we always read. The enzyme which is involved in this case would be glucose 6-phosphatase, not glucose 6-phosphate dehydrogenase. I'm waiting for your answers here, guys. Quickly hit the comment button. Which of the following is not a feature that is seen with von Gierke's disease? So in glycogen storage disorder, we'll be having is a hepatorenomagaly. Normally, we always read about splenomegaly, but the only condition in which you will ever read is hepatorenomagaly, because glycogen is stored in the liver and in the kidney also. So renal enlargement would be present in this case. Along with this, because the body is not getting sugar, so there would be burning of fats. So there would be hypoglycemia with hyperlipidemia, because fat is being metabolized, and this would be a chubby baby, doll-like faces would be present. But option number D is an easy one, that is crumpled tissue paper appearance. That is seen in the bone marrow study with respect to Gaucher's disease, glucocerebrosidase deficiency. But yeah, an important thing to remember here would be option number D. Crumpled tissue paper appearance is a feature that is seen with respect to Gaucher's, and here the question is on von Gierke's disease. So yep, absolutely perfectly right. And von Gerke is extensively asked, it is the only example where glucagon will not work. You see, normally whenever there is hypoglycemia, we first give dextrose correction to a patient, and if dextrose is not working, we give subcutaneous glucagon. But the only medical condition where subcutaneous glucagon does not work to correct the hypoglycemia is the condition that we're discussing at the moment, that is von Gerke disease. I mean, the clinical presentation most of the time will be the child will be having recurrent hypoglycemic attacks. And when we do correction of hypoglycemia with dextrose, then it causes thrombophlebitis. So very soon all the veins of the patient will become thrombosed. And even then, because the person is having hypoglycemic seizure, possibly you decided to give subcutaneous glucagon. Glucagon acts by utilizing this enzyme, glucose 6-phosphatase, and here this enzyme is not there. So if the enzyme is not there, glycogen will not be converted into glucose. So the only example in medical science where glucagon will not work, the only example in medical science where glucagon will fail to rise the blood sugar of a patient is von Gerke's disease. And then it will not contribute to too much of issues in a patient. So let's move on to the next one. We're having this infant with seizures, irritability, and developmental delay. The blood glucose in the patient is normal, but CSF glucose is markedly reduced in this condition. Pompes will cause cardiomyopathy, so the cardiac involvement would be given in a question. You see, this will be having RBC lysis, this will be having a hemolytic anemia, so it can be easily ruled out. The basic pick-up point in the question is blood glucose is normal, but CSF glucose is markedly low. That means the transporters are affected. Like if I say blood glucose is normal, but the CSF glucose is affected, that means it would be a GLUT1 deficiency. The answer for this is option number C. I mean, clinically, we could anyway rule out A versus B, because when it comes to glucose 6-phosphatase, then it is the blood sugar that will be low. I mean, the reason why I ruled out option number A is that blood sugar should be low in this condition. It is given to be normal. So once A and B are ruled out, then it becomes easier for you to figure out that there is a defect of transport of sugar. That is why GLUT1 deficiency is to be answered. Okay, a longish question now. This 9-month-old kid. Yeah, absolutely true. Akhil, that is perfectly fine for Pompes, but then cardiac involvement should be given in the question for Pompes. We have a 6-month-old infant, progressive developmental delay, and there are milestones which are delayed in the question. That's a time wasting tactic in the second line. The main findings are cherry red spot is present, but there is no organomegaly. I mean, normally when we have is a cherry red spot, we also have a organomegaly present, but in this case there is cherry red spot with no organomegaly. The movement that happens, you are thinking in terms of Tay-Sachs disease in a patient. So the answer in this case would be given as B, that is hexosaminidase. And what I want you to do is take a snapshot of this table that I mentioned, because these are permutation combinations which are asked. Like most of the time the question will mention regarding a cherry red spot that would be present, and there is no organomegaly, so it becomes Tay Sachs. But if both are present, then we will think in terms of Niemann-Pick in a patient. Gaucher's does not have a cherry red spot, but organomegaly will be present in a case, and then if it is none and none, then it is Krabbe's disease. So just take a picture of this, guys. I think this would be beneficial, because if they give you a question with respect to lysosomal storage disorder and cherry red spot and hepatosplenomegaly, combination is given, then we'll have to figure out on the basis of the information that is present. Sandoff's disease is a variant of Tay-Sachs only, no? So that's the Indian version of it. I mean, Tay-Sachs is common in Ashkenazi Jews, and Sandoff's is common in Indian population. But then it is like yep. So if you can just work out the combinations that I mentioned here, especially with respect to like Krabbe's disease, where there's no cherry red spot, there is no hepatosplenomegaly, but at the same time there is peripheral neuropathy given, or globoid bodies which are given. Like they ask for globoid bodies, that is for Krabbe's disease. So the differentiation that I mentioned here before you are the ones which are to be picked up. This table basically mentions the differences between the two, guys. If you can just go through. Okay, so I understand. I mean, prolonged starvation is again a good one. I mean, that would be having ketoacidosis present. So the clinical presentation would be totally different in that case. Okay, so we are sorted for the current one, guys. The answer is hexosaminidase, basically because there's a cherry red spot without an organomegaly and a neurodegeneration is present. Moving to the next question, he says riboflavin deficiency will be affecting the functioning of which of the following enzymes? A fact-based question only, so you guys can quickly comment on this one. A glutathione reductase. So we talk about glue and we talk about ribbons. Though there's a lot of logic going into it, that riboflavin is gonna be responsible for synthesis of FMN and FAD, and these are oxidoreductase enzymes. So if they're not gonna be functioning, then we can be having is anemia in a patient, glossitis and seborrheic dermatitis occurring. But just remember that ribbon and glue thing, that is more than sufficient to remember this. Glutathione reductase is perfectly fine. Yes, magnetatung is a good input there. Okay, moving to the next one. What is not correct with respect to Cheyne-Stokes respiration? Quick answers, please, guys.
Anaerobic respiration produces more energy than aerobic respiration.
This is AI nowadays listening to you. When I'm talking, the AI is listening and is giving answers. Okay, what is not correct about Cheyne-Stokes respiration? Very good. I think Cheyne-Stokes respiration is seen in high altitude. It is seen in advanced heart failure, and then is central sleep apnea is a close answer, and conditions that lower intracranial pressure. I mean, conditions that will contribute to raise ICP are the ones where we usually would be having it, and not with respect to conditions that would be having is a lower intracranial pressure. So it is. Yeah, yeah, perfect, perfect. We will be doing this. So it is like I can say like advanced heart failure and high altitude can easily be ruled out in this case. Now, what is happening is there are two close answers that we have to think of, right? One is gonna be central sleep apnea, and second is gonna be a lower intracranial pressure. But my point is only one, guys, that if I say low intracranial pressure, the issue with that low intracranial pressure is also that even that can cause stretching of the dura mater. So it will affect the respiratory center in some sense or not, right? But when it says central sleep apnea in a patient, then I mean, when I say the word central sleep apnea, that implies like Ondine's curse, right? So even in that condition, yes, yes, I think most guys are getting this correct, but I still wanted to give an explanation for the same, that lower intracranial hypotension will affect the brainstem, but it's then going to contribute to apneusis. It not contribute to a Cheyne-Stokes respiration part. So the correct answer in this case would be option number A. Okay. Moving to the next question, sodium potassium pump. They love to ask about this also. So let's have your inputs for the current question. Yes, guys. Yes. Yeah. Okay. Okay. Fine, guys. I just want to bring to your attention that the question is not asking the coupling ratio. The question is not about coupling ratio. It is about alpha and beta subunits. Please read the question carefully because couple of questions were straightforward. That doesn't mean that everything is gonna be a piece of cake here. So the message for you at the moment is that this question's answer is gonna be that it is a heterodimer and it will be having 3 alpha and 3. Guys, it is not 3:2. The question is not talking about the coupling. It's not talking about the coupling ratio. It is talking about how many alpha units and how many beta units. The answer for this question is option number A. It has 3 alpha and 3 beta units. If you read about the sodium potassium pump again, just check out your notes once again. It will be having a cytoplasmic side which will be having 3 alpha and extracellular side which would be having 3 beta. I mean, beta is on the outside and alpha would be on the inside. And then it's going to be sending sodium and potassium. That's okay. That's the coupling ratio, right? That is going to be the coupling ratio for 3 sodium and 2 potassium. So just get the fact right. It is regarding the components of the sodium potassium pump. Okay. Yes, the answer is 3 and 3 in this case. Answer is option number A. I hope you got the point there, guys. That the question is not with respect to how much sodium and how much potassium it is sending in to generate the resting membrane potential. It is about how many alpha and how many beta units it is having. The correct answer for this question would be given as option number A. Okay, great. Great. Let's move on to the next one. Which is correct about action of renin. I mean, that would be coming from the JG cells and it would be responsible for, if I say anything, the answer will become obvious. So you guys can quickly comment here. The main function of renin would be, yeah, Pihu, you're right. Conversion of angiotensinogen to angiotensin 1 in the plasma. The correct answer for this one is option number A, and then ACE enzyme will be catalyzing that angiotensin 1 into angiotensin 2 reaction. Yes, yes, yes. The answer for this is A. Then we're talking about the arterial waveform. I always love to draw it in my medicine discussion also, but since it's coming today in a physiology one, so still okay. We're talking about the arterial waveform during a cardiac cycle. He says what is correct about this? Yes, this would be a dichrotic notch that is happening just after S2. No, this is S1. This is gonna be S2. So movement after the aortic valve will close, we have this notch in the pulse arterial waveform that is called as a dichrotic notch. The question is not with respect to JVP. If it was JVP, then I would have answered it as a C wave, but then the shape of the JVP will also be different. I mean, the shape of JVP would be like this, and there would be much more different waves that would be present. So the physical appearance of a C wave is grossly different. The JVP waveform is totally different. The question is on an arterial waveform, which is why the answer in this patient can be given as option number C. That is a dichrotic notch. तो 100 नंबर तो देखो ऐसे ही आ जाते हैं यार, उसके बाद में ही वो नेगेटिव मार्किंग वाले आते हैं ना, तो जैसे वो एक दो नेगेटिव मार्किंग करवा दिया तो वहां से दिक्कत हो जाती है, तो बस वो ये नेगेटिव मार्किंग नहीं करनी ना, अदरवाइज तो स्पॉट है। 100 नंबर तो कहीं से भी मतलब लाने मुश्किल नहीं है। 100 इज ओके, बट वो 150 100 के ऊपर जो जाना होता है ना, 120 फिर 130 फिर 150, उसी में थोड़ा सा एफर्ट लगता है। अदरवाइज लॉट ऑफ दीज क्वेश्चंस आर गोना बी easy ones. So you can see that sigmoid shaped curve and you can see that parabola. So if I look at that sigmoid shaped curve, that would be for oxyhemoglobin, the blue one, and then you can see the parabola for the red one, that is myoglobin. So answer would be B. So these are like those easy ones just to build up your confidence, and I'll move on to the next one. I did have errors in this one also. Did I have anyone blue for carboxyhemoglobin? Okay, and blue for, okay, it's not for carboxy, no, but it's not for carboxy, no, it is for oxyhemoglobin, no, it's not for carboxyhemoglobin. The sigmoid curve is for oxyhemoglobin. Okay. The glucose in the kidney tubules is absorbed by SGLT2, and he says that which part would this be mainly contributing to maximum absorption of glucose? Answers, please. It is GLUT2, but would be present with respect to, yes, guys. Okay. Maximum absorption is the workhorse, no? Proximal tubule is called as the workhorse of the kidney, and the max work would be done by S1 segment. That is like normally we read S1, S2 for heart sounds, but I mean 90% of all the work that is being done is via the I mean glucose absorption. 90% is gonna be via the S1 segment. Then amino acid absorption, salt, bicarbonate, all of those are important aspects that would be absorbed. So the correct answer for this one is option number A. The basic point is proximal tubule is the workhorse. And among the workhorse, like when it comes to glucose, max absorption would be occurring from the S1 segment. Okay. Then we have is this simple graph where two values are given that will help you identify ट्रांसपोर्ट मैक्सिमम 10 मिलीमोल्स लिखा हुआ है. सिंप्लीफाई बिफोर यू. अगर ब्लड का शुगर 180 के ऊपर जाता है तो जो शुगर होता है वो यूरिन में आना शुरू हो जाता है. तो एक फिल्टर्ड हो गया और एक एक्सक्रीटेड लोड हो गया. एक तो फिल्टर रेट है कि जितना ब्लड शुगर बढ़ेगा उतना फिल्टर होगा ग्लोमेरुलस से, and then some part will obviously be excreted. So this curve is primarily for sugar because transport maximum value is always taught to you. I mean, what I mean by transport maximum is that if the sugar in the ultrafiltrate is more than this value, then it will ultimately start getting lost in the urine of the patient. So there are three curves which are given here that would be filtered, then some part is reabsorbed and some part is excreted as well. So the same part of TM maximum of glucose word was missing there, but the mathematical value 375 was given. And then the blood sugar more than 180 is when we start having development of sugar in the urine. The correct answer for this one would be option number A. And yeah, the values for remaining ones are different, so I decided to put the easier one. Okay, yeah, differential. Simran, you're right. The splay is because of differential nephron action, because not all the nephrons will be working optimally at the same value. So that is why the splay part would be coming in all the curves, including the one where the filtered part is represented. Okay, main regulator. The main regulator in phosphate metabolism will be. I'm having multiple answers at the moment. The main regulator, ये बच्चे मैंने एक्सप्लेन किया हुआ है कि जो कैल्शियम का रेगुलेटर है वो पीटीएच और कैल्सिटोनिन और विटामिन डी होते हैं, लेकिन फॉस्फेट का जो मेन रेगुलेटर होता है वो FGF23 होता है. FGF23 इज बेसिकली प्रोड्यूस बाय द ऑस्टियोसाइट्स इन द बोन एज वेल एज ऑस्टियोब्लास्ट्स. एंड ये करता क्या है, तो ये फॉस्फेट का लॉस कराता है. Why it is important to have a phosphaturic action is because phosphate अगर बॉडी में बढ़ जाता है तो it causes calcification. It binds with calcium. It causes hardening of blood vessels. It will worsen atherosclerosis. Phosphate can cause problems in human body by binding to calcium, causing hardening of blood vessels, and can cause it can worsen pre-existing atherosclerosis, or it can cause hardening of those blood vessels. So the body has an inbuilt system where FGF23 is gonna be produced, and it will have a phosphaturic action. It will cause a urinary loss of phosphate. We don't need too much of it. We just need okay amount of it. So the answer for this would be option number D. As far as PTH, calcitonin, vitamin D are concerned, they're mainly regulators of calcium. The top three, I agree. PTH has a phosphaturic action, that is okay. We want to lose phosphate by the urine, but main function of PTH is bone reabsorption. ना PTH का क्या पढ़ाते हैं? Bone reabsorption. और calcitonin क्या करता है? It sends calcium in the bone. Whenever you read PTH, what is the function of PTH? Bone reabsorption. So it's related to calcium. And then calcitonin sends calcium. Reverse action is done by calcitonin. Vitamin D is gonna be absorbing calcium from the GI tract. No, whatever we eat, then vitamin D is gonna be absorbed from. Vitamin D will help in absorption of calcium from the intestine to make the bones relatively stronger. So 1, 2, 3 are regulators of calcium. And FGF23 is gonna be related to FGF23 is the main regulator for phosphate metabolism. Okay, answer is D. So ठीक है भाई, it doesn't matter, you know, you got the previous ones right ना भाई. अब देखो सारे तो नहीं हो सकते ना ऐसे कि भाई सारे बोलो कि भाई वो इजी पीसी हो जाए. चलो नेक्स्ट चलते हैं. व्हाट विच ऑफ द फॉलोइंग इज कॉल्ड एज काउंटर करंट एक्सचेंजर. तो दो टर्म्स होती है, एक होता है काउंटर करंट मल्टीप्लायर एंड द सेकंड टर्म इज काउंटर करंट एक्सचेंजर. इफ यू विल से द वर्ड, if we say the word counter current exchanger, then it is vasa recta. And if he says the word multiplier, then it is the thing ascending limb of loop of Henle. Like I can draw like this. This is gonna be like the kidney tubules, and then are the blood vessels. So this is the loop of Henle, the thick ascending limb, and the thick ascending limb of loop of Henle here will be responsible for. I mean, what it will do is that it will be removing. I'll use a different color. It will be responsible for removing sodium and potassium and chloride. It is impermeable to water, but it is going to be responsible for removal of sodium, potassium and chloride. The movement of the ultrafiltrate and the direction of blood flow is opposite, so we call it a counter current system. This counter current system basically helps in solute exchange, and there are two terms to be remembered. One is EV, that is if he says the word counter current exchanger, जैसे EV पढ़ते हो electric vehicle, वैसे ही if he says counter current exchanger, then answer it as vasa recta, that is the blood vessels that are shown in color red before you. These are the blood vessels. The flow in them will be opposite to the flow of the ultra-rectrate. So EV is the word to be remembered for counter current exchanger. And if he says the word multiplier, then for multiplier, your answer would be given as LOS, that is loop of Henle, and that to the ascending limb of loop of Henle. Basically, the aspect to be remembered is that they will help in facilitate solute exchange. और counter current mechanism किडनी में तो होता ही है, मेल्स में टेस्टिस में भी होता है, बिकॉज टेस्टिस का टेम्परेचर इज लोअर देन द रेस्ट ऑफ द बॉडी ना. तो हाउ इज द स्क्रोटम कूलर एज कम्पेयर टू द रेस्ट ऑफ द बॉडी? टेस्टिस का जो स्क्रोटम का टेम्परेचर होता है that is lower than the rest of the body. The reason for that is counter current mechanism. Then counter current mechanism is present in our tips of fingers also, so it will help in heat loss also. So counter current mechanism is present in the kidney for facilitating the solute exchange. It is present in testes, it is present in the fingertips, in the toes for heat exchange as well. And answer for this question would be given as option number D. And question तो देते रहना यार, कभी भी स्ट्रेस नहीं लेना, चिल बैठो और आराम से क्वेश्चन करो. Which of the following is called as Golgi tendon reflex? Quick answers please. डरना मना है भाई, डरना ही तो नहीं है, करते रहो बस, जस्ट परसिस्ट एवरी डे. लाइक यार स्पेशली यू गाइस डू जिमिंग राइट, लाइक जिमिंग का टाइम नहीं होता तो मतलब कोई ना कोई एक्टिविटी आदमी रोज करता है ना, तो वही व्हेन यू डू द सेम एक्टिविटी अगेन एंड अगेन, देन यू टेंड टू गेट यूज्ड टू द सेम स्टफ, देन इट डजंट लुक लाइक you have to do something extraordinary. Okay, which of the following is called as a Golgi tendon reflex? Yes, we always, myotactic and stretch reflex basically mean the same. And every time there's a stretch reflex, it will always contribute to a muscle contraction. I mean, whenever we have ankle jerk, knee jerk, all of these reflexes will always contribute to a muscle contraction. But God has given us a system which will also help in muscle relaxation if the load on the muscle is very high. Like आप जिम करने गए फर्स्ट डे, आपने सीधा 25 किलो के डंबल उठा लिए, तो वो डंबल गिर जाएगा आपके हाथ से, उठा नहीं पाएंगे हम. The muscles will relax because that is inverse stretch reflex. The basic point is normally always muscles will contract whenever there is a reflex happening. I mean, every time we read about ankle jerk, knee jerk, bicep jerk, every time there is a contraction. But when it is going to be focusing on muscle relaxation, that is always an inverse stretch reflex. This inverse stretch reflex is reflected via 1B fibers in the Golgi tendon organ. So do remember this fact, 1B afferent and alpha motor neuron connection for this association with Golgi tendon, which is present in the muscle. What does Golgi tendon do is it measures the tension in the muscle. और कभी भी अगर ये टेंशन इन द मसल इंक्रीज हो जाती है तो ये मसल को कॉन्ट्रैक्ट नहीं कराता है, वो रिलैक्स कराता है. जैसे एक विड्रॉल रिफ्लेक्स देखो, अगर मोमबत्ती को हाथ लग जाए, सपोज आई सपोज द लाइट गोज आउट, आई स्विच ऑन आई इलेक्ट्रिक कैंडल, इफ माय हैंड टचेस अ कैंडल देन माय हैंड विल इमीडिएटली विड्रॉ, दैट्स अ विड्रॉल रिफ्लेक्स. सो मसल्स वर कॉन्ट्रैक्टिंग ना, सम आर कॉन्ट्रैक्टिंग, सम आर रिलैक्सिंग, बट द मेन एस्पेक्ट इज द मसल इज कॉजिंग अ कॉन्ट्रैक्शन फॉर योर हैंड टू मूव अवे. बट if you are having is a relaxation of the muscle, that is Golgi tendon reflex, GTO, which is going to be related to 1B afferent and alpha motor neuron. The answer for this is C. Okay, then I think this was easy because Z to M line was given. I initially wanted to remove the Z to M lines and just give the figure as X, the red arrow that is given. But then I thought that it will make it easier because in case the image is not clear. So Z to M line, if Z disc to M band connection is what I'm talking about, we're talking about muscle spring. We are talking about the muscle, one of the largest muscle proteins, in fact, one of the largest proteins in the body, and that is called as titin, not tintin, but titin. The answer for this is B. And suppose if the arrow was on the green wala protein, right, then your answer would be given as nebulin, right? If it was on the, यहाँ से Z से start हुआ, I'll just mark it in green only. If it is starting from Z line and it is ending where the actin filament is ending, then this would be nebulin. So there are two proteins that are marked in the diagram. One is nebulin and the second one is titin. The green one is nebulin and the one that you have answered very correctly is titin, that is the muscle spring here. Troponin to बच्चे regulatory protein होता है ना. Troponin is a regulatory protein. We are talking about the contractile system that is operating, right? So it is like titin, and I mean, if even when you're thinking about this question, none of the options should be coming because all of them that would come into picture would be then regulatory proteins. Okay. Okay, so the PDF would be available. If I get into theory, then it will change the focus of our discussion today. Next is a question on Saturday night palsy. Like this guy, he slept over. Easier would be we removed the word Saturday night policy, but just to increase the strike rate, we kept this here. Hard to remember this one. No. This won't be. Just check out the diagram, no, that I've given you, and just you need to focus on these theory parts, which will come in the PDF subsequently. Just read them up. No, zebra in a hat. This I band is separated by Z line, and dark A band by letter HAZI is how you remember it, or zebra in a hat, whichever you feel like. But then these are relatively easier stuffs that are to be remembered. Yes, moving on. We are talking about neuropraxia. And he says which of the following would not be correct about this case. Okay. Neuropraxia is a temporary block. It is okay. Okay. And type 1 Sidon classification is perfectly fine. And then is gonna be yes. Valerian degeneration. No, जब भी Temesis लिखा होता ना, every time he says the word Temesis, whether it is neurotemesis, T is for that nerve is torn issues, right? Torn injury is present. So whenever he says Temesis, that is when we read about Valerian degeneration. So the correct answer for this question would be option number D. Neuropraxia में तो it's like a temporary thing that is happening, no? Like the nerve जैसे हम बोलते हैं ना हाथ सुन पड़ गया, something like that. So I hope that Hindi part is okay, but then जैसे बोलते हैं हाथ सुन पड़ गया, that is the neuropraxia component that is coming in. And if it's a Temesis component that is presented, then the answer would be given as option number D, that is a Valerian degeneration. The answer is D. Okay, the Sidon classification is given anyway. Okay, Tanmay, fine. I take that point, maybe given in a different way. Next is basal electrical rhythm is not present in which of the following organs? Basal electrical rhythm is the fluctuation in the resting membrane potential of the smooth muscles of the intestine. You can understand this like an angry young man. जैसे अमिताभ बच्चन का हमेशा angry young man वाला image होता है, then he explodes, तो फिर वो intestine contract कर जाएगा. So similarly here, basal electrical rhythm is that fluctuate. Angry young man is anger is simmering inside, and then there's a firing or action potential that is occurring. So basal electrical rhythm is present in where the food would be received in the stomach, duodenum, jejunum onwards, and would not be present in the esophagus. The answer for this would be given as option number B. Yes. Okay. Yeah, would be available on YouTube. Yes, obviously. Moving to the next one. Intestine is contracting to mix chyme from the stomach with the pancreatic and the intestinal secretion. So he says that this action would be called as a bit of theory here. I'll give you a slide to remember this also, but let's look at your answers also. Yes, the mixing part is what is called as segmentation. एक बार देख लेते हैं इनको. Migratory intestinal housekeeper, no? Intestinal housekeeper is like the continuously our stomach keeps on contracting every few minutes to keep on moving the residual food in a forward direction. One way to remember migrating a motor complex, I can give an example, is like ORS को हमेशा every 2 minutes देना होता है with a katori spoon to a child who's having diarrhea. Why we give every 2 minutes is because that will correspond to that migrating motor complex, that the cyclical peristalsis in the stomach and the small intestine continues to happen. And lots of time if you are in a quiet room, तो हमारे tummy से जो आवाज आती है, that could be due to migrating motor complexes. So this MMC is the cyclical peristalsis. Basal electrical rhythm would be the fluctuations in the RMP, like I gave example of angry a young man Amitabh Bachchan suddenly exploding, and then otherwise some fluctuation, some anger is simmering inside, the spontaneous fluctuations in the RMP. Segmentation is what was asked here, that is the mixing of the food, the chyme and the pancreatic juice. And suppose if somebody is trying to drink beer, or somebody is trying to, two guys are doing a competition drinking beer fast, so then there is a deglutative inhibition that is happening, that would be hyperpolarization of the smooth muscles. So the correct answer for this would be option number C here. And yeah, don't change your answers is another learning point in this question. Lots of time English would be life-saving for you. Okay, Ji. Moving to the next question, we have this neonate is brought to the hospital with difficulty in feeding and poor cry. And there's a hypertonia with opisthotonus. So the question is about neonatal tetanus, right? Because he's saying opisthotonus, that means only the occiput and the heel of the patient would be touching the hospital bed. And he says that how will tetanus toxin be acting? So tetanus toxin will bind to synaptobrevin. It will inhibit the release of GABA, and by inhibiting the release of GABA, the inhibitory neurotransmitter is less. So that is why the rigidity will develop in the body of this patient. The correct answer for this is option number B. And when it comes to option number C, toxin binding to Rancho, says this is for strychnine poisoning. We're talking about two questions at the moment. One is with respect to strychnine poisoning, and the second is with respect to tetanus. If he says strychnine poisoning, then it is the toxin binding to the Renshaw cells, inhibiting the release of glycine. And if it is toxin binding to synaptobramine, inhibiting the release of GABA, then it is tetanus that would be present. Okay. Yeah, strychnine also have offers the tonus. Absolutely, yes. But then to have a neonate having strychnine poisoning is a little less likely, no? In a developing country, and then a neonate brought to you, first few days of life, it's always tetanus which is to be considered. Yes, Botox is perfectly right. Boni, you are perfectly right in that. That is synaptic cleft and then decreases the release of acetylcholine. That is due to Botox. A results in floppy baby is also right, Raj. You were right there. For the first one, it is Botox, botulinum toxin that I'm talking about. That would be a floppy baby. Okay, so which hormone will spike at night and fall at daytime and has no role on blood sugar values? I think easy one because blood sugar value rule is gone out. So I think at least you could rule out a growth hormone there. Yes, the answer would be given as melatonin because it will spike at night time. No, melatonin tends to spike at night and fall at daytime. The graph of that would be opposite of what is that for cortisol. I mean, the cortisol values will be falling at night time. You can see the cortisol values are relatively less, but the melatonin values will be spiking at night time. So this graph basically beautifully puts it up for the behavior of both cortisol, which affects the blood sugar, and melatonin that does not affect the blood sugar. The answer to this would be option number C. Okay, so distance by which two touch stimuli should be separated to be perceived as two different stimuli would be maximum on. And I'm given an image in the diagram only here. I mean, it's obviously not in the actual exam, but I've given it here so that you can find an answer to this question. Yeah, growth hormone also elevated, but it will affect the blood sugar value. So that is why it was ruled out. Okay, so here, guys, what you have to pick up is you have to go by English here. The question is not with respect to the maximum sensitivity. The sensitivity would be on the lips or on the fingertips. I understand that lips and fingertips are highly sensitive, but here the question is like, read the English in this case. Distance by which two touch stimuli, we are using a caliper. If you touch a caliper to the lip or to the fingertip, even if the eyes of the patient are closed, he can pick it up very easily. But to be perceived as two separate points of the caliper, he says distance should be maximum with respect to which particular area. So you can see here the distance is maximum with the two tips of the caliper to be on the back because back is having less sensitivity. The correct answer for this question is option number B. If you thought in terms of lips and fingertips, then you were imagining that the language of the question is that which area of the body is most sensitive. Because he's written the word greatest, so the assuming part was that we thought that he's talking about that sensitivity to touch and sensitivity to 2-point discrimination would be maximum at, that is, lips and the fingertips. I agree to it, but the question was framed in such a fashion that it is not asking you regarding the sensitivity part. He's rather asking you the area where the sensitivity is the least, so there is more separation required. That is why the answer to this question would be given as option number B. So I hope now the concept is much more clear here. Like, the framing of the question, of the language of the question would basically change. Lips are most sensitive, doctor. that I did not fall into the trap of putting that in the question because I know that's always a controversy. But I think lips are the most sensitive part of human body, and then is fingertips, obviously. Okay, so moving ahead with the 44 is option number B. We move on to the next one. You can see that this would be a Homer Wright rosettes. And why I'm calling it Homer Wright is because there is no clarity, right? There is pink neuropils which are present in between these. So this is a Homer Wright rosette. That is one. Rosettes would be like if you go to any church, like you see those designs in the windows, so that's some light is coming in. Similarly, that this is area where I can say some light is coming in. So Homer Wright rosette is what I'm talking about the movement, and in between this is the pink material which is present, which is called as a neuropil, and this is a presentation that is usually seen with neuroblastoma. No, it will not be seen with both A and B because when it comes to patient who's having retinoblastoma. I'll show you an image for the retinoblastoma also. That would be flexner wintersteiner, and in that there would be clear gap that would be present here. There would be a white area that would be present here. It is the pink area that is present. So since I'm talking about neuroblastoma, the neuroblastoma can present with dancing feet and dancing eyes. This dancing feet and dancing eyes is called as opsoclonus. The answer for this question would be option number A. Yeah, Flexner Wintersteiner is more common. Agree to that. But then how does it look like? So check it out right now. You are mixing up the two things. Check out the two images. Flexner Wintersteiner will be having this white gap in between. There is a well-defined lumen that is surrounded. So if this image was having that white gap in between, the gap in between, then I would have answered this as a retinoblastoma, and then the answer would have been given as a B. But if you check out this image, there is no white material present here. It's all pink material which is present in this particular case. So it's the difference which is to be remembered here, guys. ये तो बहुत एक general question है जिसमें वो Homer Wright और Flexner Wintersteiner के बारे में पूछता है, and then he includes the word pseudo rosettes. सूडो रोजेट्स कब बोलते हैं? जब देयर इज अ ब्लड वेसल विच इज प्रेजेंट इन बिटवीन. तो इसका फोटोग्राफ ले लेना. इफ यू आर एबल टू पिक इट अप, इट वुड बी रिलेटिवली बेटर बिकॉज लॉट्स ऑफ टाइम you might be having pseudo rosettes as a presentation as well. So when it comes to Flexner Wintersteiner, there will always be like that gap in between, or like there's no pink material that is present. And true rosette is like a dil saf. Medico United, you had a very clear way of describing it. And then is the pseudo rosettes where there would be blood vessel in between, and Homer Wrights are gonna be mainly related to where the pink material is present. So if you just look at these images here, you will be in a better position to understand the implications. The correct answer for this particular question is option number A, that is Homer Wright rosettes was described here for neuroblastoma. Blueberry muffin rash, yeah, extramedullary hematopoiesis can be a manifestation. It's an abdominal tumor basically. Great. Answer is A here. Okay. So I hope you were able to get this right. I mean, वो दिल साफ है तो ठीक है, पर दिल साफ यहाँ पकड़ पाए कि नहीं पकड़ पाए वो important है. इस वाले का दिल साफ नहीं था तो इस वजह से इशू होगा. चलो, moving to the next one, we are having a patient who's having early satiety, which अगर blood cancer पे क्वेश्चन हो ना जिसमें CD वाले क्वेश्चंस होते हैं, और जब भी अर्ली सेडेटी लिखा हो तो समझ लेना स्प्लीनोमेगेली डिस्क्राइब कर रहा है. आई मीन जब भी सीडी वाला क्वेश्चन होता है और उसमें अर्ली सेडेटी लिखा होता है, मतलब वो स्प्लीनोमेगेली की बात कर रहा है, बिकॉज इट इज प्रेसिंग ऑन द स्टमक. देन देयर इज अ पैनसाइटोपिनिया एंड अ ड्राई टैप दैट इज गिवन. सो द मूवमेंट यू रीड अबाउट पैनसाइटोपिनिया एंड ड्राई टैप, पहले तो सोचते हैं यार इज इट माइलोफाइब्रोसिस. Myelofibrosis will be not having a splenomegaly. Here is written massive splenomegaly because the moment I read that the person is having satiety, I thought it is splenomegaly. But then he said pancytopenia dry tap, so I thought यार myelofibrosis होगा. But myelofibrosis does not have a splenomegaly. Myelofibrosis, aplastic anemia don't have a splenomegaly. And then is the word CD103 that is present here. The moment you read this, the diagnosis in this case is hairy cell leukemia, and the gene which is responsible for this is option number D, that is BRAF V600E mutation. Among the remaining three options, I mean they're easy because they're all related to either chronic myeloid leukemia or to acute myeloid leukemia. This is CML, and obviously these two are related to acute myeloid leukemia. So if you just go by exclusion here, the answer for this would be given as option number D. The main aspect to be remembered is flow cytometry number CD103 is hairy cell leukemia. That is one way. And then if you have a pancytopenia given, think in terms of myelofibrosis. But if it is pancytopenia with a splenomegaly and a dry tap, then it is hairy cell leukemia. The answer for this question is D. Because bone marrow is fibrous, no, so everything like here their cancer cells infiltrating. Go by English, myelofibrosis is fibrosis of the bone marrow. So if you have fibrosis of the bone marrow, then there is no organomegaly. But in hairy cell leukemia, the cancer cells will infiltrate. They'll come out of the bone marrow and they'll infiltrate the organs, and that is why hepatosplenomegaly is present. I mean, anytime in any blood cancer, क्यों liver बढ़ता है, क्यों spleen बढ़ता है, क्यों lymph nodes बढ़ते हैं? The reason for organomegaly in any blood cancer is the organ infiltration that would be occurring. Okay, yes, exactly. Ma'am has made it so easy for everybody. And then bone marrow biopsy showing a fried egg appearance, and then BRAF V600E mutation are the aspects which are to be remembered. In this case, with drugs being cladribine and pentostatin, I mean the only statin which is used in blood cancer is pentostatin. Otherwise, statins are used in cholesterol management for patients who are having atherosclerosis. Okay. The next one talks about a female. She's having weight loss, mediastinal lymphadenopathy, with a pleural effusion. So since I'm reading pleural effusion and lymph nodes in the chest, so my first thought process is it could be tuberculosis. I mean, in India, we always, anybody with weight loss, lymph nodes in the chest and pleural effusion, we think it's in terms of TB. Then is tree in a bud appearance with the lung consolidation and effusion. So that again goes in favor of tuberculosis. The point against this is low ADL levels and lymphocytic predominance in the pleural fluid. Okay. It says what is the most likely biopsy finding that would be seen in this particular case. So waiting for your answers in this case. Yes. Though this is a repeat question and I've discussed it earlier, what I want to say is that low ADL levels, normally they always teach high adenosine deaminase levels in pleural fluid is diagnostic of pleural TB, but low does not rule it out. Low does not rule it out. I mean, if I look at the pointers given in the question, weight loss, mediastinal lymphadenopathy, pleural effusion, lymphocytic predominance, there are at least 4 points in favor of TB, and there is 1 point against the possibility of tuberculosis. So the more appropriate diagnosis in this particular case would be that this is tuberculosis only, which is contributing to the manifestation. So it's a necrotizing epithelioid granuloma as an answer for this particular case. And suppose in this particular question, like the pointers against TB were not given, then I could have thought of even a fungal hyphae surrounded by lymphocytes. But considering it also fungal etiology in a immunocompetent person, suppose this was immunocompromised, even then I could have thought, no, immunity is less. Maybe had a patient had a bone marrow transplantation, he had a solid organ transplantation. I could have thought in terms of fungal hyphae surrounded by lymphocytes. But considering immunocompetent individual, it is tuberculosis, which would be the correct answer. I think I've given the rationale for this one very well, considering that there is a high incidence of TB in our country. Okay, wrong about celiac disease. This I think you can answer straight away. Tissue transglutaminase antibody is the correct statement. Marsh criteria are used for histological classification, and anti-gliadin antibodies are specific for diagnosis. Sensitive is TTG, but anti-gliadin antibodies are specific for diagnosis. But this would be this would be HLA DQ8 and not DQ6 and D11. I mean, the main problem here is with respect to these numbers which are given, that would be DQ8 and not DQ6 and 11. The answer is D. It is DQ2 and DQ8 which are to be answered as the correct versions for this. The answer is D here. Okay, moving to the next one, we have this 68-year-old guy, early sedentary again, so splenomegaly. There's enlarged lymph nodes with the, okay, he's himself mentioned regarding organomegaly. So let's analyze this. There's an anemia. The TLC is super elevated, 25,000 cells, and there is an absolute lymphocyte count of 8,000. The clinching point of this MCQ is this particular statement. Every time you read about absolute lymphocytosis, if more than 5,000 cells, always think in terms of chronic lymphocytic leukemia, that is CLL. And when you check out the image, you can see that classical fragile cells, which are the smudge cells which are present here. So one I can pick up is the smudge cells here. These are the fragile immunocompetent B cells, and the best test for this guy would be a peripheral blood flow cytometry for diagnosis of chronic lymphocytic leukemia. Considering old age of the patient, absolute lymphocytosis, and then presence of smudge cells, the diagnosis is chronic lymphocytic leukemia. We'll be starting fludarabine in this particular person. Popcorn cell, no, the popcorn would be in a physical appearance of Hodgkin's lymphoma, no? And that Hodgkin's lymphoma then would be giving a different history of cervical lymphadenopathy, and Arbor classification would be given for this. The answer for this question is option number A. And yes, I think remaining guys have answered this correctly. Okay. Okay, somebody is watching the video on a live relay. Thanks for the ATLS input, but still I want to tell you the diagnosis is not tension pneumothorax in question 10. The diagnosis is hemothorax. Please read the question again. That is for just a random comment that came in the question. So I think some people might be watching it from the beginning only. So just for his benefit, right? It is not a question on tension pneumothorax. So I have read the ATLS guidelines. The question is not on pneumothorax. Fine, guys. Cutoff is 5,000. No, the diagnostic feature is not gonna be only 5,000 cells. It is lymphocytes, right? आप देखो sir, in you and me the TLC is 4,000 to 11,000, and in that 20% are lymphocytes. Here I'm saying lymphocyte count is 5,000. Only lymphocytes are more than 5,000 for more than 3 months. I suspect chronic lymphocytic leukemia. Suggestion is check out the CLL video, first 2 minutes, 3 minutes max, and you get the concept behind whatever I'm saying. It's absolute lymphocyte count more than 5,000 for 3 consecutive months is when you suspect it. But confirmation is obviously a flow cytometry. Okay, fine. Which of the following will be helpful for reducing transfusion dependency in a beta thalassemia patient who's having a serum ferritin of 1500 nanograms per ml, more than 1000, and I want to reduce transfusion dependency in this case? Guys, answer is not deferoxamine. The question is not talking about a chelator. Is the question saying you need to give an iron chelator to the patient? Is he saying that you need to bind to iron? No, he's saying how do you reduce transfusion dependency in a patient? It is like number of blood transfusions required in this guy is 12. I want to reduce the number of blood transfusions in this patient from 12 to 6. So the drug that I'll be giving to this patient is luspatercept. The correct answer for this is option number A. Guys, the question is not on iron chelation. Please read it carefully. Question says best for reducing transfusion dependency. I want to reduce from 12 blood transfusions to 6 blood transfusions in a year. So the drug that will be giving to this patient would be option number A, that is luspatercept. And voxelotor, somebody is answering, बच्चे, that is answer for sickle cell anemia. ये जो option number D है, तो ये तो FMG एग्जाम में उसने पूछा था कि सिकल सेल अनीमिया के लिए नई वाली दवाई कौन सी है, तो वो वॉक्सलेटॉर है, और थैलेसीमिया के लिए जो नई दवाई है जो कि ट्रांसफ्यूजन डिपेंडेंसी को रिड्यूस करती है उसका नाम luspatercept है. यस, मेंशन बोथ ऑफ देम. गाइस, अगर आप एफएमजी एग्जाम के लिए भी पढ़ रहे हो, सिकल सेल अनीमिया में पूछा क्या देते हैं, तो पहले सिकल सेल अनीमिया में हाइड्रोक्सी यूरिया देते थे, वो फीटल हेमोग्लोबिन का लेवल बढ़ाती थी, उससे सिकलिंग एपिसोड होते. वॉक्सलेटॉर करता क्या, ये बढ़ाता तो ये भी वही है, वो फीटल हेमोग्लोबिन का लेवल बढ़ाएगा तो जो सिकलिंग क्राइसिस होता है वो रिलेटिवली कम हो जाता है. जैसे सिकल सेल एनीमिया में बोन पेन इज अ बिग प्रॉब्लम एंड सिकलिंग क्राइसिस विल कॉज रिपीटेड हॉस्पिटलाइजेशन. सो टू रिड्यूस द रिपीटेड हॉस्पिटलाइजेशन इन सिकल सेल एनीमिया, इट इज वॉक्सलेटॉर. And similarly, to decrease transfusion dependency, I've written the mechanism of action, written the mechanism of action. It will work by increasing fetal hemoglobin. It will decrease the sickling crisis. क्योंकि अगर fetal hemoglobin ज़्यादा होगा in the RBC तो sickle का concentration कम हो जाएगा ना. If you increase one particular type of hemoglobin inside, the sickle concentration is less because sickle makes the RBC sticky. If the concentration is less, then the stickiness is less. So the micro occlusions of the organs are less, and that's why the hospitalizations is less. So what we are doing in these patients are two things. The objective is decrease the hospitalization. The basic concept is decrease the hospitalizations in the patient, and you will be able to manage your patients relatively better for both of them. I'll say that again. For sickle cell anemia, it is going to be decreasing hospitalization by decreasing the sickling crisis, and for luspatercept it will increase the RBC production. वो जो signaling pathways होते हैं जो RBC के production को affect करते हैं उनके ऊपर असर करता है, and it increases RBC output. If you increase RBC output from the bone marrow, then the total requirement for transfusions will go down by something in the range of 25 to 50%. That is why I said कि 12 की जगह पे उसे 6 ट्रांसफ्यूजन्स की जरूरत पड़ रही है. The answer is option number A. यहाँ पे जो डिस्ट्रैक्टर था क्वेश्चन में वो सीरम फेरेटिन का वैल्यू था. In this question, the distraction was the serum ferritin ka value. Suppose in this question, if the serum ferritin value was given to be, even if it was given to be little more than normal and not so high, you would have then, I think if the value was lower than 1000, then the probability of you getting this question correct would have been much more higher. But maybe the examiner deliberately put that ferritin value higher to put you in line on thinking of iron chelators, whereas it is for transfusion dependency. और आरबीसी का प्रोडक्शन बढ़ेगा तो भाई ब्लड ट्रांसफ्यूजन की रिक्वायरमेंट कम हो जाएगी. ओके जी. No, Tanya, that is what I was trying to explain. No, that high ferritin is not relevant for this. That is a distraction in the question. Ferritin is not relevant. It is noise. तभी तो बोलते हैं cut the noise. वो cut the noise का मतलब यही है कि क्वेश्चन में there will always be some useless noise given. ओके जी. तो ये क्वेश्चन यार मुझे डालना था बिकॉज ये एफएमजी एग्जाम में आया था, तो आई थॉट कि वो कई बार रिपीट कर देते हैं नीट पीजी में भी, तो आई हैड टू पुट अप दिस क्वेश्चन कि 6 महीने का बच्चा है, उसे पॉलीयूरिया है, फेलियर टू थ्राइव है, एंड देयर इज अ हियरिंग लॉस गिवन. वो हियरिंग लॉस से मुझे पता चल जाता है कि ये जेटलमैन सिंड्रोम नहीं होगा, एंड दैट वुड बी बार्टर सिंड्रोम, क्योंकि बाकी तो अंडरस्टैंडेबल है कि भाई पॉलीयूरिया है, the patient is having signs of dehydration, so there could be salt loss which is occurring, in metabolic alkalosis with hypokalemia also tells me that there is aldosterone that is increased. I'll explain the logic here. In Bartter and Gentleman syndrome both there will be salt wasting. That is clear ना, क्योंकि दोनों में ही ट्यूब्यूल का डिफेक्ट है तो salt wasting होगी. If you are having salt wasting in a patient, the person will be having polyuria, and because of this there would be dehydration. Because of this dehydration, there would be a development of metabolic alkalosis, because every time there is going to be dehydration, it will contribute to hyperaldosteronism in a patient, and this aldosterone will then be contributing to urinary loss of potassium and nitrogen, so metabolic alkalosis will occur. So a distraction in this question was Conn syndrome. Conn syndrome has hypertension with hypokalemic alkalosis. In this case, there is no hypertension given in a bacha. So in this particular case, I mean, Conn syndrome का clinical presentation क्या होता है? तो Conn syndrome will be adult. He is having adult adenoma. He will be having is a hypertension with hypokalemic metabolic alkalosis. But there will be no polyuria in Conn syndrome. Conn syndrome will not have polyuria. उसमें तो salt will come back in the body, so Conn's is ruled out. Dent's disease is characterized by increased calcium loss in the urine. अब ए और बी से कैसे डिफरेंशिएट करना है? तो बार्टर सिंड्रोम में जो डिफेक्ट होता है टैल में, जो सोडियम पोटेशियम, इसमें बार्टर सिंड्रोम में क्लोराइड चैनल डिफेक्टिव होता है, एंड दैट क्लोराइड चैनल दैट इज डिफेक्टिव इन बार्टर सिंड्रोम इज डिफेक्टिव इवन इन द इनर ईयर. Bartter syndrome में the same channel which is defective in the tubule, a similar kind of channel is defective in the inner ear, which is why we will be having is a development of sensorineural deafness in a patient. So the answer for this question would be given as option number A. Answer to 51 is option A. A and B present the same way. There are some fundamental differences. From electrolytes, obviously I've discussed in main video, magnesium loss is a feature. Like if he says magnesium wasting, then magnesium wasting is a feature that is seen only with respect to Gentleman syndrome. So those minor pointers will always be there. But here the thing was that person is having sensorineural deafness. That's because of the common channel in the tubule and the common channel in the inner ear that will get affected in this patient. Okay. Then we talk about drug of choice for management of the following condition. You can check out this image where we are having a boot-shaped heart. So the condition that we're talking about is tetralogy of Fallot. Tetralogy of Fallot, we need to keep the ductus open. So we need to maintain ductal patency in this case. So the answer in this case would be given as alprostadil. Ductal patency maintain करनी पड़ेगी ना. Ductal patency will ensure better blood supply. So it will reduce the cyanosis in this case. We will not be using indomethacin. Will not be using ibuprofen. A and B are used for management of patent ductus arteriosus, where we have to close the ductus. A and B are used for patent ductus arteriosus, where we have to close the ductus. But in alprostadil, but in tetralogy of Fallot, we have to maintain ductal patency. The reason for increasing the ductal patency is increase the blood supply to lungs. And if you increase the blood supply to lungs, then what will happen is that the cyanosis of the patient will become relatively lesser. The objective is increase the blood supply to the lungs. If you increase the blood supply to the lungs, then what will happen is that the severity of central cyanosis that is present in tetralogy of Fallot will become lesser. So we will be using Blalock toxic shunt in a patient. इबुप्रोफेन और इंडोमेथासिन ही बताया होगा सर ने, मैम ने, जिनसे भी आप पढ़ रहे हो. इट इज फर्स्ट प्रेफर्ड इज इबुप्रोफेन एंड देन इज इंडोमेथासिन. it's only a apples versus orange kind of a description, 19-21 की बात जिसे कहते हैं. But yeah, ibuprofen better over indomethacin. They don't give questions like that, guys, and they just give you cold data. Like for tetralogy of Fallot, it is alprostadil that would be given. Okay, so moving to the next one. 50-year-old man suffers from a cardiac arrest in an emergency room. This is a kind of a question which would be like, long, which will take 1.5 minutes to read. And that's the kind of questions where you need to save time. So earlier, some questions that I was discussing, like they were having shorter options, so the time that you were investing were relatively lesser, but now it is like you have to invest time. So the guy has received 2 cycles of CPR and 2 defibrillation shocks, and thankfully, by the grace of God, is having a ROSC, that is return of spontaneous circulation. That is the word I want you to pick up in a question that will make the answer very easy for us to interpret. Now his blood pressure is 88/50, saturation is 92, and he's saying what is the most appropriate step. So we will not be giving epinephrine in this particular guy. And at the moment, immediately I cannot do a coronary angiography And I don't even know whether he's having a heart attack or not. I mean, why did he go into cardiac arrest? Was it due to electrolyte imbalance? Was it because of sepsis? Was it because of COVID-19? Was it due to MI? I don't know. So there is no point of doing coronary angiography in the patient as well. And discontinued risk of I mean, we need to discontinue resuscitative efforts, that is okay, but then we need to do something. I mean, just observation would not help. So the most important thing is, once you have had a rescue, return of spontaneous circulation, you need to go for TTM, that is targeted temperature management. What I mean by targeted temperature management is that we go for therapeutic hypothermia. Therapeutic hypothermia is cardioprotective as well as cerebroprotective. So TTM and maintain. There are two aspects which are always asked in the paper. One is they will ask you regarding therapeutic hypothermia. The objective therapeutic hypothermia is that it is cardioprotective and neuroprotective. So because brain has been without oxygen for such a long time, so if I want to decrease the metabolic rate in the next 24 hours, then it will help the organ tide over the crisis relatively better. So ROSC is followed by therapeutic hypothermia, one. And second is we need to use vasopressors to maintain a mean arterial pressure of at least more than 65 millimeters of mercury. These are the two main targets after ROSC. I mean, every time you get a question, ROSC obtained, what is the next thing to be done? Maintain the mean arterial pressure above 65 and ensure therapeutic hypothermia for at least next 24 hours, so that the heart is having less stress, the brain is having less stress, and the chances of survival of the stressed out organ will be relatively more. So answer for this question would be option number C, and most guys have given correct answer. I mean, in a sense that it will lower the metabolic rate, but this question was put to sensitize you to that this would be a mixed bag. Some would be having shorter options, some would be having like super long options. And those super long options questions are where you need some extra time. So you where do you get that time from? You get that from those shorter ones. Okay, child is undergoing a ventriculoperitoneal shunt surgery for hydrocephalus. Which would be the best anesthetic agent of choice for quick induction in this patient? Yeah, easy one. I mean, the preferred induction agent in children would be anesthetic agent for quick induction would be sevoflurane. Desflurane will usually be causing lung irritation, so it would not be suitable. It is sevoflurane uniformly, so was a relatively easy question. The only thing modification in this question was VP shunt surgery. Everything else you are anyway aware of. Excellent safety profile, rapid onset, preferred inhalational anesthetic in pediatric patients. So it makes sense. Okay, fine. Moving to the next one, there's a sudden drop in EtCO2 during neurosurgery. So what does it indicate? Yes, you're right, Fatima, Bandita, everybody's right there. A sudden drop in EtCO2, normal EtCO2 should be something in the range of at least 35 millimeter of mercury or higher, and obviously less than 45, but like at least 35. And if it is gonna be suddenly decreasing to zero, that means that there is a trauma to the dural venous sinuses, and if the dural venous sinuses are injured, then air can be sucked in, and that can result in venous air embolism. The air, because the pressure in the dural venous sinus is negative, so air will get sucked in, it will go towards the heart, and the heart will not be able to function blood. And if the heart will not be able to function blood, then the person is going to deteriorate. So it is VAE, that is venous air embolism, that would be occurring in this patient. Yeah, Durant's maneuver is what is used in this patient, but yep, at least the answer is very clear. It is VAE, venous air embolism, occurring in a patient. Okay, the next one is again a question from anesthesia. This is a bispectral index monitoring in a patient, and he says what is the correct. You are aware of that MCQ. Bispectral index is used to monitor the depth of anesthesia. So the question is not a one-liner, but is a modified version of the same question, and you can solve it by English only because you are processing EEG signals to provide a numerical value. So you have to put the sensor on the forehead of the patient, and okay, but it would not be indicating duration of anesthesia, right? It is the depth of anesthesia. The wrong thing here is duration of anesthesia is the wrong thing. So I'm ruling out option number A. It will be put right. It would be analyzing the brain, right? So not put on patient's chest, right? The answer in this case would be option number C, and does not mention cerebral perfusion also. The answer would be value 40. I mean, that value is not important. The important thing is it will check for the appropriate level for performing surgery, because it's just a mod. I mean, this statement that I'm marking here, This and depth of anesthesia, they both imply the same only. Na? After all, when we do give anesthesia to a patient, I want the patient's body to relax so that the surgeon can start operating on a patient. So it's just a modified version of the same question that you read for depth of anesthesia. The same thing is written in English in a modified fashion as appropriate level of anesthesia for performing surgery. The wrong thing about option number A, which still came up in the options, was not the duration of anesthesia, but depth of anesthesia. So if you go by English, this is very much solvable. Okay, rocuronium is rapid. So let's look at, yes, less than 40 deep hypnotic state. Agreed, Several. You're perfectly right. Rocuronium is a rapidly acting molecule. It is a non-depolarizing neuromuscular blocker. I've ruled out one option for you. It's written depolarizing. Yes, here the word non is missing, no? That word non is missing, so A is ruled out. And it is metabolized by the liver. So C is ruled out. Uh, it is safe. It does not cause significant histamine release resulting in hypotension. It's rapid, no? Rocuronium R is rapid in onset and has an immediate duration of action. So the correct answer in this case would be option number B. He says which of the following statements is correct. It is the correct statement that is present. A is wrong. It's a non-depolarizing one. C is wrong because it's metabolized from the liver. So left between B versus D. The correct answer is B only. Yes, which of the following is correct about the last component that is shown? You guys can quickly mention the answer for this one, and then I'll show you an image which I'll zoom in. Yes, this indicates recovery because there is, like, support mechanism that is being given. But I just want you to be familiar with the sequence also, because next time when he will ask you this, he'll ask you about in-hospital cardiac arrest and out-of-hospital cardiac arrest. He can ask you to set them in the correct order. So in hospital, you need early recognition, no? So just pick up that search mark, that search mark has to come immediately because patient is already admitted. But in out of hospital arrest, at the moment, like, first thing is make a call, to the emergency services. So just check out this image which is given and make a mental note, because there are some things which are very, very common here. Like calling medical services is common here. Chest compressions is common here. These three steps are common here only, but then you can see now out of hospital cardiac arrest patient has to be transported to the hospital. Then figure is coming in between, and then there is a post cardiac arrest care where there's a return of spontaneous circulation that was being given. So just get a orientation regarding these two images, or just a click image of this or snapshot of this, so that if they ask you to correct them, arrange them in the correct order. For in hospital cardiac arrest, the search option comes first, then is the easy one. I mean, then it will become easier. And in out of hospital cardiac arrest, it is the ambulance that comes at fourth position after, like, we have taken care of the CPR and provided AED machine to the patient. The correct answer for this one, as discussed, is option number B, that is recovery. And let's move to the next one. This woman is presenting with the following lesions and a skin biopsy is being performed, and he says which of the following is like the most consistent option which is correct. The diagnosis of this patient is lichen planus. You can see those purple polygonal plaques which are present on the extensor aspect of the foot of the patient. Munro's microabscess is a feature that is seen with psoriasis, so I can rule out option number A. Sawtoothing or rate ridges, that makes more sense. The sawtooth appearance is seen with lichen planus. Not molluscum bodies, that is seen with pox, that is Henderson Patterson bodies for molluscum contagiosum. So two were ruled out, guys. It is I'm left between B versus C. The tombstone pattern is what you read mainly with pemphigus vulgaris. No, this is seen with PV, pemphigus vulgaris. So the answer for this question would be given as option number B. Great. So we read the sawtooth rate edges is what is trying to talk about. The sawtooth word has come up again. We read in atrial flutter sawtooth. I mean, that I'll just write that quickly. Atrial flutter is where we read about sawtooth. Then diverticulosis in a barium enema is where we read about sawtooth. And then sawtooth rete with respect to lichen planus is where we're reading the word sawtooth as a terminology is coming up. And then EEG also, that is REM sleep. 4 times we are gonna read sawtooth, that is barium enema for diverticulosis, lichen planus on a skin biopsy. and then REM sleep with respect to EEG in a patient. Psoriasis, yeah, we can differentiate ना. Psoriasis में तो they would be mica like plaques ना, and so psoriasis के जो plaques होते हैं, those lesions are gonna be like whitish lesions. They're gonna be present on the elbows, on the knees of a patient, and when you scratch them, then there's a ospit sign that is present. Lichen planus would be purplish in color, so the differences are like totally grossly different from the physical appearance. और अगर आपको ये वाइट वाइट जो दिख रहा है, चलो आप लोग कमेंट करो जिन्होंने लाइकन प्लानस आंसर किए, जो वाइट वाइट इसके ऊपर दिख रहा है, what is the technical term for it, guys? You can see now, I've zoomed into the image. You can see these white lines on the purple lesions. So what is the technical term for this, guys? Yes, this is called as, yes, this is called as Wickham striae. These white crisscross striations that are present is what is called as Wickham striae. Yes, this is called as Wickham striae. Very good. I think most guys gave a very correct answer, that white lines that you were seeing on the top of it is the Wickham striae that are present, and it is purplish lesions which are present. In psoriasis, there would be no purple present. It is totally white scaly lesions, mica-like plaques that would be present. Yeah, they can be present in the oral cavity also and will come up very soon. So I think that was the query. कि बेसर differentiate कैसे करेंगे? So that is Wickham striae. Okay, and you can see, in fact, the next question is on the same only, that we are having Wickham striae in the oral cavity also. So the diagnosis in this case would be given as lichen planus. The answer for this is option number A. It is not B, guys. It is not leukoplakia. Leukoplakia में Wickham striae वाले crisscross striations नहीं होते ना. If this was a white lesion, then answer would be option number B. If it is red patch, it is erythroplakia. Or oral submucosal. Answer to this question is A, guys. I've explained this multiple times in my routine videos also. And if they give you a question in which there is like this white lesion present in the mouth, and patient cannot even open the mouth, like there you can see a doctor is asking him and not even two fingers are going in the mouth of the patient, then it is oral submucosal fibrosis. It is oral submucosal fibrosis which is shown for the current image that is shown. ये आदमी गुटखा खाता है, betel nut खाता है. I mean, if he gives a history of betel nut, gutka chewing, then it will become even much more relatively easier for you to pick up the question. Okay, it's not visible, so I'll just write it again. The PDF otherwise would not look very nice. Oral submucosal fibrosis, the white lesion and inability to open the mouth. Okay, so two oral lesions have been discussed, and be clear that we are not discussing about leukoplakia, but usually it is A and D that are asked. Okay, G. Moving to 61. 35-year-old female came with complaints of like rash on the convexities of the face, and then she's having these lesions which are worsening on hot drink, sunlight, and emotion. So, I think most guys are getting it correct. This is not SLE, because in SLE you will not be having these acneiform lesions that would be present, and you can notice that the lesions are on the chin of the patient, they are on the cheek of the patient, even on the forehead of the patient, and the history is of lesions working with hot drink, sunlight, and emotion, that is flushing. This is flushing that is described in a question. So the presentation in this case would be that of acne rosacea. The correct answer for this one is option number C, and is not gonna be SLE. I mean, for SLE, I'll talk about then a woman who would be having that characteristic butterfly rash, and there would be a lot of other things also given, a musculoskeletal pain, anti-nuclear antibody present. But with the kind of history that is given in this question, the answer would be given as option number C, acne rosacea, which involves the convexities of the face. That chewing traction or keratosis that can occur is like you talk about cheek bite, na? So that cheek bite would be mainly the person would be having some problem with his teeth, after which that white lesion in the mouth can be developing. Okay. A patient presents with skin and oral lesions. The diffuse immunofluorescence finding is given of pemphigus vulgaris, because you can see the fishnet appearance here. In this condition, we have these antibodies which are anti-desmoglein antibodies. So option number A and option number B does make sense. They are okay. And IgG class of antibodies also fine. The problem is that the antibodies are against desmosomes, because normally cells to cell connection is hampered here. You see, I'll just do a quick diagram here. We have is a basement membrane, right? So what I want to say is that in this condition, the connection between the cells is lost. This connection between the cells is called as desmosomes. And because the cells are getting separated, that is why you're getting these gaps in between, no? And the green marking that I'm doing is hemidesmosome. The green marking that I'm doing is hemidesmosome. So in a disease where hemidesmosome is affected is bullous pemphigoid. The green thing that I've done the marking, that is bullous pemphigoid. And if it is going to be pemphigus vulgaris, it is the desmosomes that would be affected in a patient, and that is why that cell to cell separation would be present in this case. The correct answer in this particular case is option number C. तभी तो ये सेल सेपरेट हो जाता है ना, डेस्मोग्लाइन एंटीबॉडी डेस्मोसोम पे एक्ट करेंगे, जो रेड से दिखाया गया है वो डेस्मोसोम है, और डेस्मोग्लाइन एंटीबॉडीज उसको हार्म करेंगे, तभी सेल का सेपरेशन हो जाता है, जिसको हम एकैंथोलाइसिस बोलते हैं. एग्जैक्टली सुभाष, यू पुट इट वेरी राइटली. एकैंथोसाइट फ्लासिड बुल्ले would be described in the case. ओके, अब इससे इजी क्या पूछूं? ग्रुप्ड वेसिकल्स इन अ डर्माटोमल डिस्ट्रीब्यूशन. That is because hemidesmosomes are affected ना बच्चे. सब एपिडर्मल स्प्लिट इज बिकॉज ऑफ द हेमिडेस्मोसोम से ना, वो सेपरेशन हो गया. जो नीचे वाला लेयर मैंने बनाया था ग्रीन वाला, वो सेपरेट हो गया था, सब एपिडर्मल स्प्लिट हो जाता ना. That is why there's a subepidermal tense blister that is present. Okay. Exactly. Because it is given dermatomal distribution, so you will say herpes zoster. Even NEET PG, they gave an image where the lesion was on the chest of a patient, so pretty straightforward. Herpes zoster, reactivation of chickenpox. But in herpes simplex, there would be like a STD presentation, so he will say grouped vesicles on genitals. So two questions would always come. One is grouped vesicles on genital, that is herpes simplex, HSV2, and if he says grouped vesicles in dermatomal distribution, it would be herpes zoster. Okay, so moving on to the next one, there's an image which is shown. You can see that lesions in a Christmas tree appearance here. The diagnosis in this case would be pityriasis rosea. Yes, and considering pityriasis rosea, HHV7 is the organ that would be incriminated. Christmas tree appearance and mother's patch on a trunk. But civet bodies is gonna be seen with respect to lichen planus. So answer for this question would be given as option number D. Perfecto. Again, an easy spot diagnosis for you guys. You can notice the cracks in the tip of the finger. This would be called as, yes guys, the fingertips would be having these cracks appearance present. That would be mainly for mechanics hands, and mechanics hands would be seen with ASS, that is anti-synthetase syndrome. It is just that you can put up antibodies in its place, but these would be really spot ons and the easy ones that you have to pick up. Okay, moving to the next one. Quick answers, please. Spot diagnosis. You can notice two things. One is hyperpigmentation, and second is the hair. The combination of the two will make your answer very spot on. Hyperpigmentation is there, hair is present, so the answer would be going as Becker's nevus. Nevus of Ota will be involving the trigeminal nerve. So if they give me a image-based question with respect to the eye involvement as well as the trigeminal nerve involvement, then it is Ota. If it is the back of a patient, then I'll say Ito. But if it is a hyperpigmentation with hair, you can notice the hair also, you can notice the hyperpigmentation also, then I will call it Becker. So a quick comparison of these would be given. Not necessarily. Becker's can be on the anterior abdominal wall also, not only on the back of the patient. Okay, fine. We can move ahead to the next one. Fine. 16-year-old boy is having following skin lesions on the shin. Random blood sugar is 200 and the RIA insulin level is low. The diagnosis in this particular case would be, yes. So there are two images which I want to bring to your attention. Both can be having elevated blood sugar, but one will be having low insulin. The second one will be having is the high glucagon values. If they give you a question where insulin value is low and sugar is elevated, that means cases of type 1 diabetes, and the skin manifestation in type 1 diabetes would be necrobiosis lipidoica diabeticum. Acanthosis nigricans will present in type 2 diabetes, so it is getting ruled out. And then I would like to mention regarding necrolytic migratory erythema, this option number D, this is what you get with respect to glucagonoma. And this glucagonoma thing that I'm currently mentioning before you is what can be seen here. the question mentioned a person is having couple of D's present. That is, random blood sugar was given to be elevated. So one could be thinking in terms of type 1 diabetes lesion also. But then he mentioned regarding depression, dermatitis, diarrhea, and deep vein thrombosis. So then in those circumstances, our answer would be given as glucagonoma. The messages at the moment is there are three skin lesions with high blood sugar that have been discussed. One is for type 2 diabetes of insulin resistance, acanthus nigricans. That is a straightforward question. Then is a lesion in which central clearing would be present. If you check out the lesion here, you can notice a central clearing in the middle, and this is like a big plaque occurring on the shin of the patient. That is necrobiosis lipidoica diabeticorum. And migratory superficial thrombophlebitis. Somebody said, guys, you can help. Migratory superficial thrombophlebitis would be seen with respect to lung cancer, stomach cancer, and this is what is called as Trousseau syndrome, right? Option number C is what is called as Trousseau syndrome. Very good. C is seen in pancreatic cancer. It can be seen in lung cancer. We call it Trousseau syndrome. Exactly. It can be seen with lung cancer as well. So option A is for type 2 diabetes. Option number B is for type 1 diabetes. C is for Trousseau's. Necrolytic migratory erythema is for a glucagonoma. For glucagonoma, the symptoms can be very close to the D's of patient having Castle's necklace and pellagra, but at the same time, there would be no elevation of blood sugar that would be seen, and instead of depression, it would be dementia. Okay, so we are sorted with question number 67. The answer is B. Let's move to 68. 26-year-old primey, she's 24 weeks of gestation with cauliflower lesions on the vulva. Cauliflower lesions on the vulva. Okay. And she's having condyloma acuminata. So made it easier for you by saying condyloma acuminata, which is caused by human papilloma virus 6 and 11. And he says, how would you manage this patient? So we can be using imiquimod also, but then safer. No, imiquimod can be used in pregnancy, but if trichloroacetic acid is present, then why to take a chance with imiquimod, which is not having sufficient amount of studies available. So the correct answer for this question is option number C. Yes, if I remove trichloroacetic acid from the question, as I think happened in one of the papers, I don't remember NEET PG or FMGE, then imiquimod can be used in pregnancy is the statement that I would like to make. But yeah, I mean, wherever it's a safer alternative available, we'll go give the correct answer. Okay. Then is okay, psychiatry coming up here. So we'll do 100 for today, and let's move on to the next one. 25-year-old lady, she is having a history of vague and chronic physical complaints, and very common in India कि डॉक्टर्स को कुछ आता नहीं है, हम पढ़ रहे हैं इतनी देर से, 2.5 हो चुके हैं. And I think, guys, you're doing a great job, everybody, because concentration has to be minimum 3 hours. You know, the sessions that you are doing should be minimum 3 hours of concentration. So doctors cannot identify her problem. What is the diagnosis in this particular case? So hypochondriac person will always use terms like मुझे cancer है, मेरे को heart attack हो रहा है. So that's ruled out. Body dysmorphism will say I'm so fat, I'm so thin, like that. And then Tourette syndrome will be using repetition of words, and there might be profoundly, rude words as well. The correct answer in this case is answer is A, somatization disorder, where person thinks that something is wrong, but the diagnosis of the patient could not be made. So according to her, and that's a somatization disorder, that she's relating everything to some physical illness. Yes. So ये तो बहुत ही बदमाश बच्चा टीचर को काट लिया. बच्चे ने टीचर को काट लिया और जानवरों को टॉर्चर करता है, बाकी बच्चों को भी बुली करता है. सो द क्वेश्चन इज सेइंग व्हाट इज द डायग्नोसिस इन दिस केस. यस गाइस. हम्म. ओके. यस. Well, we'll not say ADHD, so that can be separation anxiety and ADHD are ruled out. We are left between two options in this case. One is conduct disorder, and the second one would be a oppositional defined disorder in the patient. Yes, guys. Yes. So goes more in favor of like conduct disorder, where he is hurting and torturing animals as well, bullies other students at school as well. So the correct answer in this question would be option number B, conduct disorder. More B more as compared to D, I would say. Oppositional defiant would be only with authority. Now, like if he was misbehaving only with a teacher or with parent, then I would have considered it. But if he's gonna be like torturing animals also and torturing poor animals and like bullying younger children at school, that would be a cause of issue. Okay, so what is a biomarker for Alzheimer's disease? Okay, yes. Fine, guys. Let's move on to the next one. Best biomarker for Alzheimer's disease. How do we identify that this is Alzheimer on basis of CSF study? Okay, so I'm getting all kind of answers in this case. See, beta 2 to anywhere ruled out हो जाता because that is seen with dialysis dementia. So you cannot give answer as option number C, and you will not answer obviously as lactate. So you're left between A versus B here. The correct answer in this case is A beta 2 42 upon 40. The correct answer for this question is option number A. थोड़ा technically demanding था, senile dementia, one liner, typical one liner with that two close options given. One is A beta amyloid for Alzheimer, and second is A beta with beta 42 upon 40 isoforms that are responsible for that neurofibrillary tangles that are seen and neuritic plaques that can be developing in the patient and can contribute to senile dementia in the patient. हाइपोकॉन्ड्रियासिस में तो वो डायग्नोसिस बना देगा ना, प्री फॉर्म डायग्नोसिस होगा ना, दे विल ऑलवेज बी अ प्री फॉर्म डायग्नोसिस इन केसेस ऑफ हाइपोकॉन्ड्रियासिस कि मुझे कैंसर है, मुझे हार्ट अटैक हो रहा है ना, वो खुद आके बोल रहा है कि भाई मेरे को हार्ट अटैक हो रहा है, तो दैट इज लाइक हाइपोकॉन्ड्रियासिस. ओके, गेम ओवर कौन से वाला? नहीं भाई, क्यों गेम ओवर क्यों हो गया? ये तो छोड़, अब सारी थोड़ी ना, कईयों में तो ऊपर नीचे होता ही है ना. चलो, answer for this question is option number A, man. Option number A is the correct answer for this question. Okay. A patient with AIDS, moving on to the next one, is having fever with cough and breathing. X-ray and sputum testing has been done, and I'll show you the image. You can see that the person is having a consolidation on the left side. Yes, the right looks decent, but the left is having a patch. And then there is a gram stain which is given. In the gram stain, you can notice that two blue organisms are given together, like two dots like this, and then again two dots like this, which is basically pneumococcus. So if you focus on the image here, the person is having AIDS. I think all of you are aware that the most common opportunistic infection in an AIDS patient is not pneumocystis jirovecii, it is lobar pneumonia. There was a question in NEET PG, I think it was 2023, where the auscultation finding of bronchial breathing was given, and that was giving the diagnosis again as lobar pneumonia. I repeat that statement again. The most common lung infection in an AIDS patient is not pneumocystis jirovecii. The most common lung infection in AIDS patient is lobar pneumonia. This is valid for even FMG students who are listening to this discussion, guys. That's a common misconception that people carry. In this question, I did not include that bronchial breathing aspect because you would have done that question already. And in that question of NEET PG, they had deliberately mentioned low CD4 count of only 50. So most guys were of the favor that, sir, because CD4 count is less, that is why the answer is pneumocystis jirovecii. No, man, rather pneumonia will be more common because lower the immunity, first common things will be more common. The correct answer in this patient would be given as option number C, that is lobar pneumonia. And because patient is fairly sick and is immunocompromised, so we are pushing and we are giving respiratory fluoroquinolones for the patient. So levofloxacin is given. When it comes to pneumocystis jirovecii, if it was jirovecii, then how will this question be given is what I teach you next. In pneumocystis jirovecii pneumonia, the X-ray will be having multiple small white patches, and then they'll give you a green slide. The slide will be green, that is gomorimethamine, and in this gomorimethamine you will be able to say that crushed ping pong ball appearance that is mentioned. I'll show you a slide that will come up subsequently also, but since it came in the chat, I had to speak about this crushed ping pong ball appearance for pneumocystis jirovecii with bilateral infiltrates present. So I think that's sorted, and pulmonary TB will come up subsequently in our discussion. The correct answer for this question would be option number C. Okay, so another opportunistic infection in a HIV positive patient, you can see those big oocysts, I can say, which are present in the stool of the patient. We are using acid fast stain, that is skin one staining. And what is the organism that is seen? So you can see that there are two of them, right? Two of them that are seen together enclosed inside. So this would be a feature that is seen of cystoisospora, and cystoisospora is best treated with cotrimoxazole. If they were single small cysts seen, we would have answered it as then cryptosporidium, and then our answer would have been given as nitazoxanide. But considering these two of these oocysts present together in a oblong oval shape, then our answer would be given as option number B.
Yeah, isospora, cystoisospora, both would mean the same. And we'll be using cotrimoxazole for management of these patients. Okay, so 73 sorted. We have this farmer from hilly rural area is having high grade fever for past 7 days. There's a headache, there's a myalgia, and you notice a black necrotic lesion with a erythematous base. That's a S char that he's talking about, in simple words. And there's a organomegaly also. So the diagnosis in this particular case, yes, would be scrub typhus, because any question that begins with farmer, no, either will end up with scrub typhus or will end up with leptospirosis or with heat stroke. I mean, anytime you read a question of farmer, no, either it will be heat stroke question or it is having fever with muscle pain. Then you will think in terms of that the patient is having leptospirosis. That's one. And the next possibility can be that he'll talk about a S char and scrub typhus would come up in the discussion. Okay. Okay. Fine, guys. Let's look at farmer foot ना बचे मधुरा foot ना, that is more common in beggars वाला question. But anyway, चलो अभी उस पर speculate नहीं करते. So scrub typhus is caused by rickettsia, and the S char is pathognomonic in this case. The correct answer for this question would be given as option number B. The treatment of choice is doxycycline, and mark my words there. Since you guys are preparing so hard, I just want to remind you that once there was a question in NEET PG where person was having a scrub typhus and there was a pneumonia also. So if scrub typhus patient is having pneumonia also, then we have to give combination of doxycycline with azithromycin. If he just says drug of choice, doxy is okay. But if he talks about infection spreading into bloodstream and then contributing to pneumonia also, then we have to give two doxycycline as well as azithromycin. Okay. Answer for this question is option number B. We move to the next one. This man has presented with the painful red swelling over his thigh, and the pus is aspirated from there, which is having gram-positive cocaine clusters on a gram staining. And then I think it's a super easy one. Hi, Mayank. And there is beta hemolysis, fermenting mannitol on a selective agar. So I think the question is like screaming out loud, pus hai on abscess. So we're talking about Staph aureus, and Staph aureus would be both catalase as well as coagulase positive. So the correct answer in this case would be given as option number C. Perfecto. वो clusters से ही solve हो गया. I think that cluster word was a discriminating factor that ideally should not be given in a question, but since we wanted to increase the strike rate, so we kept the statement on there. So I mean, lots of time they'll not put up information in a simplified manner like what we are doing at the moment, and some words will be hidden. Okay. Okay. Yes. No, gram staining लिखा है, gram अच्छा gram positive coca कर दिया. Fine. So half it is solved only. Sheep can be black. Esther, how to difference from Bacillus anthracis? Bacillus anthracis will cause hemorrhagic mediastinitis. Na, it will not contribute to manifestation of fever in a patient. और इंडिया में तो वैसे भी ज़्यादा कॉमन स्क्रब टाइफस ही है ना, खासकर रेनी सीजन के बाद में फार्मर्स जब प्लांट्स की वाटरिंग कर रहे होते हैं तो द baby mite will bite the person on the foot, so there would be a regional lymphadenopathy also present, so differentiation can be made. Okay. Fine, moving ahead. A 3-year-old unvaccinated patient presents with fever, cough, and stridor, and there is like gram-negative cocobacilli growing on chocolate agar. So, moment I read chocolate agar and I'm reading about stridor in a patient, the thing or the disorder that I'm suspecting in this patient. Yes, I think you guys are getting it correct. You can mention what disease are you suspecting also. The organism that we are suspecting is Haemophilus influenzae. Yes, this Haemophilus influenzae manifestation that is present is very good. We are suspecting epiglottitis, where the person will be sitting in a tripod position. Patient will be presenting or sitting in a tripod position. They can be drooling of the saliva present, And then the characteristic feature present is satellitism. Satellitism means that we will be using Staph aureus to grow Haemophilus influenzae. This organism will be producing factor X and factor V, and they promote the growth of this Haemophilus influenzae. So the correct answer in this case is option number C, that is the growth of Haemophilus influenzae is what we're trying to highlight in this case. Yeah, thumb sign would be present in this case. Hi, namaste, Ram Gopal. Just to say that, it's a live session, otherwise people start thinking it's a recorded one. Okay, answer to this is option number C. Fine, moving to the next one. We have this 35-year-old guy. He had a deep traumatic injury, and on the left calf there is a discoloration present on the skin with foul smelling discharge. Crepitus under the skin is the core thing. Injury and crepitus under the skin, you always think in terms of gas gangrene in an individual. And then he is mentioning regarding Robertson cooked meat broth also. So we know that we are dealing with a case of gas gangrene only because the selective media for that is Robertson cooked meat broth. So he says, what is the most appropriate therapy for this case? Okay. Yes, this would be a high flow oxygen because this is an anaerobic organism, and we'll give penicillin G for this patient as well. And then we do a surgical debridement of this case as well. So the diagnosis is pretty clear and the interpretation is also clear. The correct answer for this question is option number C. We have this 30-year-old veterinarian, and he's presenting with fever, night sweats, and arthralgia. Blood cultures are set, and we are thinking about like fever of unknown origin. I mean, he basically wants to know that what culture media will be used for identification of brucella, which is seen with contact with animals. And this person is basically a doctor for animals only. So we will be using a culture media which is biphasic. It will be having solid component also. It will be having a liquid also, that is Castaneda's media. And here you can see that the solid media component is also present and the liquid media component is also present. So this would be Castaneda's media, and this would be option number B. Option number A is the LJ media that can be seen. So we can solve it. And this is Loeffler serum slope. You can see Loeffler serum slope is for Corneobacterium diphtheriae. So A and C are ruled out. You are left between B and D. So there's a green culture plate present there. That is TCBS. That is TCBS, which is having that bile component present. So that's why it is appearing green. I mean, normally the culture plate is red, but here it is green because bile has been added here. And then Loeffler serum slope is Corneobacterium diphtheria, but we wanted to pick up Castaneda's media, which is a biphasic media. And this biphasic media would be having a solid and a liquid component present. So correct answer is option number B. Your TCBS is for Vibrio. Very good. Then is non-bile stained eggs. I'm waiting for your answers. I'll write a mnemonic here as well for that. Two non-bile stained eggs that are always asked are HEV. That is, one is Hymenolipis nana, and second would be Enterobius vermicularis. Initially, I thought Enterobius vermicularis would be given in the options. Without looking at it, I was looking and I was thinking Enterobius vermicularis. The answer in this case would be option number D. Great. Okay, Neha is a mnemonic. Fine. That's okay. Fine. I tend to remember it more by organisms. Okay. Then favorite of yours. AIDS positive truck driver is admitted with fever and nuchal rigidity. And he says, what is the most accurate test for diagnosis of Cryptococcus neoformans? Quick answers, please. ओके सो यू आर आंसरिंग मतलब नेहा से तो सारा सही बोल दिया, 20 वाले में गलतियां नहीं होनी चाहिए, मतलब यहाँ पे मिक्स्ड बैग आ रहा है. तो दैट्स व्हाई आई एम सेइंग कि इंडिया इंक इज़ नॉट यूजफुल फॉर डायग्नोसिस गाइस. इंडिया इंक से नहीं डायग्नोसिस होता है. इंडिया इंक का जो डायग्नोस्टिक सेंसिटिविटी है म्यूसिक आर्मिन, इंडिया इंक सेंसिटिविटी वुड बी 10 to 30% ओनली. The main test for diagnosis in this condition is lateral flow assay. The correct answer for this patient would be given as option number A. The most accurate test for Cryptococcus neoformans would be given as answer as option number A. I'll repeat the statement once again. CSF lateral flow assay is overall the best test for this patient. If patient will not give permission for CSF sample, we can do on the blood sample, that is blood lateral flow assay can be done. After this would come mucicarmine stain, which will directly stain the particular capsule. And then the option would be, the next one that would be coming would be India-INC strain. That is the order in which you need to remember. Cryptococcus is one of the very frequently asked data. I think everybody knows about it. And इंडिया इंक से इसको यूज़ नहीं करते हैं. दैट इज़ द मिसकंसेप्शन दैट पीपल हैव कि भाई इंडिया इंक से मेन टेस्ट यूज़ होता है. एंड इनफैक्ट ये इवन एफएमजी एग्जाम में उसने पूछा था कि क्या टेस्ट करेंगे. उसने बोला पेशेंट ने ब्लड लंबर पंक्चर का परमिशन नहीं दिया तो क्या करेंगे, तो ब्लड पे लैटरल फ्लो ऐसे करेंगे. Lateral flow is the same latest agglutination pay, but the most accurate test for diagnosis of this condition is CSF lateral flow assay, then is musicarmin, and then is India Inc strain. India Inc तो least reliable NIR because if the fungus if the pathological yeast का जो colonization है, if it is less in the CSF, the report may be false negative also. So you cannot rely on a technician who's using a stain. A stain भी अगर expiry date का है या पुराना हो गया तो it may not be able to delineate the organism properly. So you cannot rely on a technician for diagnosis. You have to rely on technology for diagnosis. Yeah, very good. CSF ELISA, I mean, lateral flow assay ELISA. I mean, there has to be some technology based test that would be done, and that would be helpful in diagnosis in this particular case. Yeah, we can use clindamycin MBBS life. We can penicillin, जिनको पेनिसिलिन से एलर्जी होती है उनमें क्लिंडामाइसिन तो देते हैं. अगर किसी पेशेंट को डॉक्यूमेंटेड पेनिसिलिन का एलर्जी है तो फिर हम विल बी यूजिंग क्लिंडामाइसिन इन अ पेशेंट. तो मेन क्वेश्चन तो क्लिंडामाइसिन पे नहीं था ना, क्वेश्चन था कि मेन इलाज क्या करेंगे. तो इट इज़ लाइक सर्जिकल डिब्राइडमेंट हैज टू बी डन. बाकी अगर उसमें गैंग्रीन लिखा होता तो फिर मैं एम्पुटेशन आंसर कर देता. आई वुड हैव आंसर्ड इट एज ऑप्शन नंबर ए. Yeah. If asked specifically for the capsule, then it is okay. Then it is India Inc and musicarmin stain. उसमें भी अगर if he says what stains the capsule, then it is musicarmin. If he says what stains the background, then it is India Inc. Like you had a question, right? What is specifically for the capsule? So if you say capsule, then it is musicarmin. If still not India Inc. India Inc तो background को stain करता है ना, और वो capsule को highlight करता है. But if if the fungal yeast spore low count is low, then there might be a false negative report as well. So I think I had to spend time on this and clarify this before you, that before we start the patient on liposomal amphotericin B with 5-flucytosine, we have to ensure that the diagnosis of the patient is made. और ये liposomal amphotericin B 5-flucytosine को minimum 2 weeks के लिए देते हैं और till the culture becomes, I mean the agglutination test turns negative. और उसके बाद में प्रोफालैक्सिस के लिए इस पेशेंट को हम फ्लूकोनाजोल चालू कर देते हैं. The patient will be started on hyperbaric Gautam, it is hyperbaric oxygen, and then we'll give fluconazole to this patient. Fluconazole will continue till the CD4 count of this patient. Fluconazole कब तक चलेगी, तो fluconazole चलेगी जब तक CD4 count is more than 100 for 3 consecutive months. Yes guys, people listening to NEET PG, from perspective NEET PG, please be very clear. FMG एग्जाम में तो स्टेनमेन पर्ट पूछ के छोड़ देता है आपसे, तो वो ट्रीटमेंट भी पूछेगा और वो पूछेगा कि फ्लूकोनाजोल वहाँ पे कहाँ तक करेगा. तो हम क्या करेंगे, तो व्हाट वी नीड टू डू इज, भाई एंटीजन पूछा ना, कैप्सुलर एंटीजन, detecting capsular polysaccharide antigen of the pathogenic yeast. It is not the capsule that has been asked, it is the capsular antigen that has been asked. And how do you determine an antigen? You have to do a ELISA or a lateral flow assay. So I think I've addressed all the queries there. If he's saying capsule तो मैं मान लेता है ना कि आप इंडिया इंक की बात कर रहे हो, उसी कार्मिन कर रहे हो. भाई टेस्ट कैसे, डायग्नोस्टिक टेस्ट एक्यूरेसी क्या है, एंटीजन डिटेक्शन. एंटीजन के लिए विल गो इन फॉर अ लेटेस्ट एग्लूटिनेशन. दैट इज पॉइंट नंबर 1. सेकेंड, दोज हु आर लिसनिंग टू दिस वेरी केयरफुली प्लीज लिसन कि उसने पूछा फ्लूकोनाजोल कब तक देना है. तो फ्लूकोनाजोल इन दिस पेशेंट्स हैज टू बी गिवन टिल द CD4 काउंट इज मोर देन 100 फॉर 3 consecutive months. एंड दूसरा पॉइंट याद रखना कि जो HIV RNA है that is less than 500 copies per ml. Both of these criteria should be satisfied. And fluconazole prophylaxis, the question was on fluconazole prophylaxis in NEET PG. और FMG में उसने थोड़ा आसान कर दिया, उसने बोला कि इनिशियली क्या करोगे, तो liposomal amphotericin B with 5-flucytosine. अब वहाँ पे भी कई लोगों ने fluconazole आंसर किया. It's not fluconazole, it is 5-flucytosine. And the diagnostics part are also what I mentioned. Yes, Priyansh, you're right. And then when to say hyperbaric and when to say high flow. हाइपरबैरिक होता है दो जगह पे ना, काइसन्स डिजीज में यूज होता है. चलो मैं लिख देता हूँ, ये भी एक क्वेश्चन बड़ा जेन्युइन सा है कि सर कहाँ पे हाई फ्लो बोलना होता है ना. तो एक होता है हाई फ्लो नेजल कैनुला. तो हाई फ्लो नेजल कैनुला को हम यूज़ कर रहे होते हैं जैसे कोविड-19 निमोनिया में, किसी भी पेशेंट को सिवियर निमोनिया है तो हाई फ्लो नेजल कैनुला कैन बी यूज्ड इन निमोनिया ड्यू टू एनी etiology, दैट इज HFNC, जिसमें ऑक्सीजन 16 लीटर पर मिनट पे होती है, 16 लीटर पे हाई फ्लो नेजल कैनुला। एक और होता है हाई फ्लो ऑक्सीजन, अगर सिर्फ वर्ड लिखा है हाई फ्लो ऑक्सीजन तो उसको हम देते हैं यूजिंग नॉन रीब्रीदर मास्क इन एनी क्रिटिकली सिक पेशेंट एट 12 to 15 लीटर्स पर मिनट इन एनी क्रिटिकली सिक पेशेंट। कोई भी बीमार है, ब्रीदिंग डिफिकल्टी के साथ में आ रहा है, if pneumonia patient is there, ARDS patient is there, then we can use high flow nasal cannula till appropriate ventilation strategies available for a patient. And then is hyperbaric oxygen therapy. तो हाइपरबैरिक कहाँ कहाँ पे आंसर करना होता है? हाइपरबैरिक फर्स्ट टाइम आंसर करना होता है कार्बन मोनोऑक्साइड पॉइजनिंग, जहाँ पे हिस्ट्री में लिखा होगा गैस गीजर, लाइक दिस गाय इज लिविंग इन अ स्मॉल अपार्टमेंट एंड गैस गीजर का एक्सपोजर हुआ, कार्बन मोनोऑक्साइड पॉइजनिंग। Second time you will answer hyperbaric oxygen therapy is for gas gangrene in which crepitus will be present. This crepitus would be in the soft tissues because of the anaerobic organism. And third is like when a person is suffering from, let me say, air embolism or Tyson's disease लिख देता हूँ, तो डाइवर्स में मिलता है, स्कूबा डाइवर्स में मिल सकता है रैपिड एक्सीडेंट की वजह से। Those are where hyperbaric oxygen can be used. So I have, okay, I'll just check that question please. ओके, हाई फ्लो ऑक्सीजन विद पेनिसिलिन जी एंड सर्जिकल डिब्राइडमेंट। यार देखो, जो मेन ट्रीटमेंट है ना, जो मेन ट्रीटमेंट है पेशेंट का, वो हाई फ्लो ऑक्सीजन है, हाइपरबैरिक नहीं है। जो मेन ट्रीटमेंट है ना, उस पर फोकस करो। द मेन ट्रीटमेंट ऑफ दिस गाय इज सर्जिकल डिब्राइडमेंट। मेरे पास अगर हाइपरबैरिक ऑक्सीजन चैम्बर नहीं है, मेरे पास, जैसे मैं गवर्नमेंट हॉस्पिटल में काम कर रहा हूँ, तो मोस्ट ऑफ यू गाइज यू हैव वर्कड इन अ गवर्नमेंट हॉस्पिटल ना, तो डू यू हैव अ हाइपरबैरिक ऑक्सीजन चैम्बर अवेलेबल? नहीं ना, तो हम हाई फ्लो ऑक्सीजन ही तो देते हैं, और क्या कर ले। मेन इलाज क्या है? आप सर्जिकल डिब्राइडमेंट करोगे ना, या तो एम्पुटेशन करोगे या फिर उसका सर्जिकल डिब्राइडमेंट कर दोगे पेशेंट का। तो क्योंकि अभी उसमें कोई गैंग्रीन डॉक्यूमेंटेड नहीं है ना, तो इस वजह से हम सर्जिकल डिब्राइडमेंट करके टिश्यूज को प्रिजर्व करने की कोशिश करेंगे। और यहाँ पे यार बिलो नी एम्पुटेशन मतलब पैर क्यों काटेंगे? अभी तो कहीं लिखा नहीं है ना उसका, कि उसने तो ये भी नहीं बोला कि हाथ है या पैर है, उस जस्ट गिवन अ डिस्क्रिप्शन ऑफ द लीजन। तो जब हाथ या पैर का डिस्क्रिप्शन नहीं दिया, नेक्रोटिक टिश्यू नहीं दिया, तो मैं एम्पुटेशन तो नहीं कर सकता। And then the point you said was, if I don't have a hyperbaric oxygen therapy, what will I do? I will give high flow oxygen to a patient. So I think that is a clear aspect to be done. The main treatment of this chap is like surgical debridement. That's the main issue. कि वरना sepsis से खत्म हो जाएगा patient. We will lose our patient gas gangrene to sepsis. So the main treatment is get that devitalized tissue out of the system. Get that devitalized tissue out of the system. That's the main concept for this question. Okay, so we are sorted for A, and then yeah, somebody mentioned a very good answer, cluster headache. So I'll write that. That's a good input there. Cluster headache for high flow oxygen. Agreed. That's a good one. It is given to be left calf. Okay. But yeah, there is no mention of any devitalized tissue na. So I know that you have to, you will have to answer regarding the amputation part, but let's not be so radical. Yeah, किसी का पैर काट देना would not be a very radical solution immediately. First and foremost, we go for surgical debridement, and if there are devitalized tissues which are found to the level that there is a destruction happening, then we might have to go in for amputation. एंड या वन मोर, काफ है तो फिर बिलो एंकल होगा ना एम्पुटेशन यूजुअली मोस्ट ऑफ द टाइम। तो ओके जी, सो अ हेल्दी डिस्कशन एट द मोमेंट। आई रियली लाइक आंसरिंग योर क्वेरीज, एंड बी गेट्स रूल्ड आउट बिकॉज ऑफ लेस अवेलेबिलिटी। लेट मी जस्ट चेक इट आउट ऑल्सो। बी गेट्स रूल्ड आउट बिकॉज ऑफ नो डॉक्टर, अगेन द सेम थिंग। व्हाट इज द मेन ट्रीटमेंट फॉर गैस गैंग्रीन? इट इज सर्जिकल ट्रीटमेंट ना, it is not oxygen, it is not clindamycin, it is surgical debridement which is the main treatment for the patient. Yes, so that's the basic reason है। ये क्लोज ऑप्शंस है भाई, यही होगा, सारे के सारे क्लोज ऑप्शन है, सारे सही लगते हैं। ऐसा नहीं है, इफ यू सेइंग बी, इट्स नॉट दैट यू आर रॉन्ग, बट देन द इशू इज कि भाई वो इतने क्लोज दे रहा है कि वी हैव टू सिलेक्ट द मोस्ट अप्रोप्रिएट वन ना, और वहीं पे तो हमारे को थोड़ा सा मतलब प्रैक्टिस करना है कि वी आर एबल टू फिगर आउट एंड एबल टू अराइव एट द मोस्ट अप्रोप्रिएट आंसर। चलो जी। Okay, so which is most commonly incriminated in biofilm associated infective endocarditis? The question is on CIED-IE, that is CIED क्या होता है? तो cardiac implantable electronic devices developing a infective endocarditis. And he says which organism is commonly responsible? The leading organism responsible for this, one of the important organisms is Staph aureus. and second can be coagulase negative staphylococcus, and they form a biofilm on the electronic device, and they can cause infective endocarditis. So the correct answer for this would be option number C. So there are two very good, I would say, hints given in the question. One is mentioned the word biofilm. That makes it easy, no? Biofilm se thoda easy ho gaya. That is, I mean, initially I thought of like, that in this question we should not mention biofilm associated. We should just mention the word CIED and mention what is the organism. But then that will obviously decrease the strike rate. So we thought that at least to make you sensitized to the concept that, okay, this can be asked, that we had to first put up some pointers towards it. But in the actual paper, we will have to first think in terms of no, even then, no. Golden yellow beta hemolytic. Yeah, staph aureus is one of the important causes. Yes, that is a good thing. D, neon, you have a good point there. That if I did not have biofilm associated word given, then I would have thought in terms of staph aureus also, which is number one, followed by cons. Clarification here, guys. CIED, the number one organism for this is staph aureus only. And after that is coagulase negative staphylococcus. So a good one. Okay. Enterococcus is for tower na bache. Tower, TAVR. If he says tower infective endocarditis, only then you are supposed to answer as enterococcus. And if he says the word subacute bacterial endocarditis, then it is streptococcus viridans, which is to be answered. My suggestion is just in rapid revision ना शुरू के सिर्फ 3 मिनट देख लेना. In rapid revision, screen went away. Okay, let me try to fix it. Try and get it back. Okay, so back. Computer भी थक गया. So we are hitting the 3-hour mark, guys. We started at 12. It's 3 o'clock. We're hitting the 3-hour mark at the moment. Prosthetic valve related epidermis will be the first answer, doctor. That is quans, no, coagulase negative staphylococcus, because it will come from a skin pocket, no, because if you're putting a pacemaker, if you're putting a implantable cardioverter defibrillator, then from a skin pocket it would be staph organism as a more common one. So the answer for this is option number C. Let's do it, guys. Let's finish. We have to do 100 MCQs today. 100 will be doing tomorrow also. So there are 2 sessions that I'll be taking, and what we are doing is 100 questions today, 100 tomorrow, and tomorrow our main focus will be gynae-obs will be discussed. Then we'll discuss some more aspects of medicine also. We'll discuss ENT aspects, opthal aspects. They're still pending, right? So, but I've taken care of some important micro. Some of them I've tried to handle today also. Okay, ji. Fine. So let's move to the next question, guys. Yeah, 12 p.m. The same time, guys. 12 p.m. We are gonna be with you to decrease, because होता क्या है कि as you come near the exam ना, तो खुद पढ़ते हैं तो दिमाग में जा नहीं रहा होता, टाइम वेस्ट हो रहा होता. तो I selected this time because this is the time people will either be sleeping या वो लंच वंच में टाइम वेस्ट हो जाएगा बातों बातों में. तो we selected this time कि भाई थोड़ा 3-4 घंटे you listen to this and you get into the mood कि हाँ यार questions करने हैं, and then you start studying yourself only, because this time is the one which is like, yeah, what I've seen is because I've gone through your stages and your days. So this time is like usually by the time शाम होती है ना, stress बढ़ता है, तब आदमी पढ़ता है. So we selected this part only so that, okay, we can get you into the groove. Okay. So 3-4 घंटे when you're sitting and like interacting and other people are also answering, थोड़ा motivation मिलता है, हाँ यार ये आंसर कर रहा है. So I'll also try to answer. So, and moreover, internet में you are anonymous, so that gives you more even freedom to be more participative. And I would like everybody to participate more. I mean, the number of people in the chat are more lesser as compared to people who are watching passively. So this is more. This is your day, guys. This is like your time that you should be talking and you should be taking the lead. So hit the comment button on vonoprazan, which is a potassium competitive, which is a new drug which is used for management of peptic ulcer disease. It is used to treat the hyperchlorhydria component. Yes, guys, it's a reversible potassium competitive, which is, he's saying, which is not correct. So this is a reversible potassium competitive inhibition. Basically, what we're trying to do is we are trying to block this hydrogen potassium ATPase, which is present in the parietal cells, and we are able to thereby decrease the acid production in the patient. Okay, then is it can be taken. Yeah, I mean the highlight of vonoprazan is that it can be taken with regard to any meals. Yes, that is perfectly fine. It has a long duration once a day, भाई पैंटोप्राजोल जो होता है ना, उसके आपने कभी कैप्सूल खाया हो या देखा हो तो पैंटोप्राजोल के अंदर छोटे छोटे पैलेट्स होते हैं, बिकॉज इट इज एसिड लेबाइल एंड इट रिक्वायर्स एंटी कोटिंग, लेकिन ये एसिड लेबाइल नहीं है। वोनोप्राजन इज नॉट इन दैट pellet format because it is not acid labile and does not require anti-ricotin. The correct answer for this particular question is given as option number D. I'll say this again, if you're taken a pantoprazole pantop DSR का कैप्सूल आप देखे हो तो उसके अंदर वो छोटे छोटे पैलेट्स होते हैं, so they're all having that anti-coating because of the acid debility of pantoprazole, but vonoprazan does not have acid debility and requires the anti-coated. So the correct answer in this question would be option number D. After you can send that question regarding that combined medical services paper that happened. I think a lot of questions came from standard information only. Why should I say came from our notes? Standard information only. But yeah, we'll check out those questions. Yeah, can be taken without regard to meals. Yeah, absolutely. You can take it empty stomach in the morning. Vonoprazan, never an issue. Okay, so 82 is sorted. Let's move to the next one. We have this woman. She's coming with a 6-month history. FMG के लिए मस्ट नो क्वेश्चंस हैं, मतलब FMG मजाक समझ रहे हो क्या? मतलब FMG का क्वेश्चन पेपर भी तो मुश्किल होता है, उसमें नेगेटिव मार्किंग नहीं होती है बच्चे, यू हैव टू लिसन टू एवरीथिंग। ओके, विच इज मोर प्रेफर्ड नाउ डे? देखो भाई, नई दवाई आती है तो सारे डॉक्टर उसको लिखते हैं, तो इट विल टेक सम टाइम, बट या ऑन पेपर एंड इन थ्योरी वोनोप्राजन इज सुपीरियर टू PPI एज ऑफ नाउ। Okay, then the question says this lady is having a 6-month history of pulsatile headache with photophobia and occasional vomiting. तो migraine का case है. And question says which medicine is to be used once a month for prevention of such particular attacks. So because he is mentioning regarding once a month medication, the answer will not be propranolol. Sumatriptan is for acute attack, and atogepant is also for acute attack. Both of these medicines A and C are used for acute attack. We are left between option number B and D. Propranolol is like daily, whereas it is fremanezumab. It's to be used. MAB, as people were answering, is the drug that can be taken like in a once in a month format also. So the correct answer for this question is option number D. यहाँ पे गलती सिर्फ वही है कि जल्दी जल्दी पढ़ने में इश्यूज हो रहा होगा, कि अगर प्रोपरलोल आप आंसर किए हैं तो दैट वुड ओनली हैव कम बिकॉज ऑफ दिस। एंड ओके, yes, everything will be very, very familiar to you. Yes, the correct answer is option number D. Okay, which is the shortest acting drug? Shortest acting CCB which is given here. Quick voting, please. Hit the comment button, guys, and I would like you to comment it as soon as possible. Quick answers, please. Yes. Yeah, doc, I'm using English only. 99% I've been using English. 1% maybe I deviated. Okay, so the correct answer for this shortest acting calcium channel blocker would be clevidipine. The question is not on a, I was having A as an answer. Landiolol is the shortest acting beta blocker that would be asked. So suppose this question was on a beta blocker, then option number A will be present. But you need to keep your horses in full enthusiastic mode, and it is clevidipine, which would be the longest, it is the shortest acting calcium channel blocker. Answer is B. It gives you more precise control. So the answer is landiolol is the shortest acting beta blocker, and the shortest acting calcium channel blocker would be answered as clevidipine. Okay. Another question for you guys. We are having a 65-year-old man. He's having coronary artery disease with hypertension, and is undergoing a coronary artery bypass grafting, and the BP is shooting up to 190/110. Okay, so intraoperative hypertension. Thankfully, no pheochromocytoma here. I was wondering about that. So the anesthesiologist wants to bring down the blood pressure in this patient. So which intravenous antihypertensive patient is the best drug about this? यार वो चेंज हो गया ना, डॉक्टर सैयद मुस्तफ़ा, प्लीज नोट डाउन दैट एस्मोलॉल इज रिप्लेस्ड बाय लैंडियोलॉल नाउ फॉर द शॉर्टेस्ट एक्टिंग बीटा ब्लॉकर. जस्ट अपडेट दैट इन योर pharma notes. It's already given. I think sir has mentioned that in the pharma notes. Okay, quick answers please. Which of the following intravenous antihypertensive agent would be best useful for management of this patient when there is a intraoperative hypertension which is occurring in this patient? Okay, yes. So esmolol is not an antihypertensive agent, so can be ruled out, right? Yes. You have to maintain the heart rate of the patient. You see, this is a technically demanding question. He says maintain the heart rate and avoid myocardial depression. That's important, right? Maintain the heart rate and at the same time avoid myocardial depression. Labetalol, the issue will be then it will be affecting the heart rate also, no? Beta blockers, because labeta is alpha plus beta, no? So it will affect the heart rate. So lol वाले तो इसलिए बाहर हो जाते हैं because the question says you have to maintain the heart rate in a patient. Esmolol will decrease the heart rate. Labetalol, because it is alpha plus beta, will also decrease the heart rate. The anesthesiologist wants to maintain the heart rate because big surgery is occurring, no? Coronary artery bypass grafting. And he says which antihypertensive agent will now be useful for management of this patient. Yeah, so we can give, yeah, nitroprusside is used. That's the logic, guys. Nitroprusside is used in management of our patients who are having pheochromocytoma surgeries, who can be used in this particular patient as well. The correct answer in this particular case would be given as option number B. Yes, the correct answer is option number B. And somebody asked about aortic dissection. Aortic dissection में सबसे पहले blood pressure control करना होता है. In aortic dissection, because the cause of that is hypertension, we first need to control the blood pressure and control the heart rate of the patient. So पहले बीटा ब्लॉकर देते हैं, और बीटा ब्लॉकर देने के बाद में फिर हम उसमें भी सोडियम नाइट्रोप्रोसाइड को यूज़ कर सकते हैं या कोई और ड्रग टू लोअर द ब्लड प्रेशर यूज़ कर सकते हैं, पर पहले बीटा ब्लॉकर देना है बिकॉज यू हैव टू कंट्रोल द प्रोग्रेशन ऑफ द टीयर. Aortic dissection question will come up later also, but at the moment I just wanted to mention regarding yeah, why not clevidipine? It's a good option, right? Clevidipine will usually cause a reflex tachycardia, no? Clevidipine, the problem is then clevidipine is a calcium channel blocker, and the biggest problem with a calcium channel blocker will always be reflex tachycardia. I mean, that's the point that would be mentioned in this case. Yeah, any Stanford, first you have to give medicine to control the propagation of TR. For aortic dissection discussion that is going on simultaneously, control the propagation of the TR is of paramount importance. Surgery is obviously to be done. There is no surgery done in type B. Surgery is done only in type A. But before we take the patient for surgery, we can just start the patient on beta blocker so that at least we are able to control the propagation of the TR. So beta blocker is also to be given. Yes, clevidipine has a side effect of contributing to development of reflex tachycardia in a patient. Oh, doctor, the explanation that I am giving is the one that is to be followed. Yeah, clevidipine is a very good answer in this question. I mean, always there will be two very close options present, but then clevidipine has a side effect of reflex tachycardia. So it's sodium nitroprusside that would be given in this case. So I take your point, Ankit, there. Okay, nitroglycerin in option. No, there's no nitroglycerin in the option here. No, nitroglycerin तो cardiac में use करते हैं ना, पर वो myodepressant activity कर देगा ना basically. But is nitroprusside that would be used. Okay, ji. So let's move to the next one. Good discussion we had on this one. Vessel dilation will not increase the workload on the heart. Yeah, but it will control the blood pressure, no? At least the blood pressure part, the blood vessels are constricted now, so I need to dilate them so that the load on the heart is lesser. उल्टा बल्कि भाई, अगर मैं blood vessel को dilate करूँगा तो load on the heart will become relatively lesser. Okay, mortality reducing aldosterone antagonist drug in diabetic nephropathy. The answer is Finrenon. This I've explained. Answer is not gonna be given as empagliflozin in this case. I mean, the question is not on SGLT2 inhibitor, which is useful for diabetic nephropathy. It is mainly aldosterone antagonist word is given in a question, which is why the answer is gonna be given as option number A. The next question of ours is on a patient of pulmonary embolism and he's on plain heparin, and he's saying like what medicine would be given in this particular case I mean, how does heparin work in a patient is the basic question in this case. The word is UFH, unfractionated heparin. A lot of people might be thinking it as enoxaparin, right? If it is enoxaparin, then if it was low molecular weight heparin, I would have thought as option number A as an answer. But if it is plain heparin, that is UFH, unfractionated heparin, it upgrades the activity of antithrombin 3 and it will be effective. So answer will depend upon whether the question mentioned the word UFH or whether the question mentioned enoxaparin. Like suppose I change this question and say that for prevention of pulmonary embolism in a patient, drug is being used, then it is enoxaparin. But yep, if it is for management purposes, then it is UFH that would be used. Answer is C. Okay, so we have this 28-year-old male. He's been diagnosed as having a multi-drug resistant tuberculosis and he started on the BPAM regimen. And he's mentioning mechanism of action of all the drugs here, and he's saying which of them is the wrong statement in this case. So beta-choline acts by inhibiting myocardial ATP synthesis. That is a correct statement. It also causes QT. I mean, two things they always ask about beta-choline is the mycobacterial ATP synthesis inhibition and the QT prolongation. So it's okay. Then pretomanate releases nitrogen species. That's okay, and that's again peculiar because normally you read about reactive oxygen species. This drug acts by releasing reactive nitrogen species under anaerobic conditions, so that makes sense. And here the only trick in the question is that instead of writing 50S is written 30S ribosomal unit. So answer is C. And then fluoroquinolones, they inhibit DNA gyrase. I think one of the easiest options you were able to rule out was option number D, the DNA gyrase one. So this would be a 50S subunit and not a 30S ribosomal subunit. The correct answer is option number C. Okay. Next is a patient who's having a neuroendocrine tumor which is causing flushing. Neuroendocrine tumor. I think that guy, actor in Pan Singh Tomar, no? Irfan Khan, he died because of carcinoid tumor. Irfan Khan, he was one of the best Bollywood actors if you watched the movie Pan Singh Tomar. And unfortunately, we lost that brilliant actor in 2020, just around when COVID had started, to carcinoid syndrome and carcinoid tumor. So, because the keyword is for FMG students listening to this, they have asked you like, what is the test that is done in this case? That is a 24-hour urinary HIAA levels. And in NEET PG, they went a step ahead. वो बोला कि भाई दवाई क्या लिखोगे इसमें? So, what medicine will be given to antagonize the serotonin receptors in this case? Then it is cyproheptadine. Mainly, we would like to block 5-HT2. So to block this serotonin 5-HT2 receptors, it is cyproheptadine that would be used for management of this patient. But at the same time, I would like to change the MCQ and say that suppose this question mentioned carcinoid crisis and said what is the drug of choice, then the drug of choice for carcinoid crisis should be answered as octreotide. So if he says the word carcinoid crisis, then answer should be given as octreotide. And if the question says, I mean, routinely for management of symptoms, then it is cyproheptadine that would be used for the patient. The correct answer for this question is option number B. Do take care of the fact that the question is not mentioning any worsening of symptoms or carcinoid crisis. Just like you read about hypertensive crisis in pheochromocytoma, similarly carcinoid crisis, octreotide would be given as an answer. Okay, so next we have a patient of COPD and he is having MMRC grade 1 dyspnea. Grade 1 would mean that the dyspnea would come on going up an incline. Incline पे धीरे धीरे जा रहा है. ग्रेड 2 इसकी कछुए की चाल चलता है धीरे धीरे. Kachua is tall ties. Grade 3 is he will walk 100 meters then stop. Then he will again walk 100 yards, stop. But there is no stopping in grade 2. And in grade 4, the patient will become wheelchair bound. So this guy is on a wheelchair, motorized wheelchair, and is refusing to walk. So that would be MMRC grades of dyspnea. The monotherapy for this patient would be that patient would be requiring a LABA alone. And for LABA in this patient, I mean, the most appropriate therapy for patients who are having minimal symptoms would be a LABA to cause elevation of symptoms. That would be once a day. And the medicine that we can be using in this patient is indacaterol. So it is LABA, and to that we add drugs like we add LAMA or we add inhaled corticosteroids. People were answering steroids also here. Please understand the question is not on asthma. The question is not on asthma. It is on management of COPD. I mean, whenever you read about COPD classification, no, they'll mention like categories like class A, class B, and class E. So it is like this only, no, that you start with a LABA and then it is LABA to this, you can add a LAMA. And then you add all the things that is LAMA, LABA, and inhaled corticosteroids in a patient. So basically, the question is trying to know that initial part of management in this patient would be यही तो बता रहा हूँ बच्चे तन्मय, that is what I'm trying to say. Steroids are added on the basis of eosinophil count in the sputum. If the eosinophil count in the sputum is more than 300, when do you add steroids in COPD? When do you add steroids in COPD? When do you add steroids in COPD is when the sputum eosinophil count is more than 300. That is the indication for adding inhaled corticosteroids in a patient. आप करना क्या, आप सिंपली COPD का जो ट्रीटमेंट वाला पार्ट है ना उसको फास्ट सुन लेना मेन वीडियो से वर्जन एक्स से. माय रिक्वेस्ट टू यू इज फॉर ऑल ऑफ यू हु आर हैविंग इश्यूज विद दिस, जस्ट COPD में आपने वर्जन एक्स में स्विच करना है. और वर्जन एक्स में जाके सिर्फ आपको सीओपीडी का ट्रीटमेंट वाला जो पार्ट है ना उसको, सीओपीडी पिछले वर्जन 6 का नहीं सुनना बिकॉज वो तो पुराने गाइडलाइंस हो गए, अभी मैंने लेटेस्ट को हैंडल किया है। तो आप सिर्फ उसका वीडियो का फास्ट सुन लेना, बिलीव मी इट विल हेल्प यू इन द एक्चुअल पेपर गाइस। एंड आई मीन द class categories that are described for the treatment part. So it's LABA, then we add LABA plus LAMA, then it is ICS that is given. And Romiflumast is the last resort that is given. But अगर आप उसको सुन लोगे मेरे हिसाब से तो this question will become much more clearer and understandable for you. It will just take 10 मिनट लगेंगे आपको, है ना, 10 मिनट एक बार आप सुनोगे, फास्ट सुनना उसको, you'll get a better understanding of this. Okay. Moving to the next question is about paracetamol toxicity, and he's saying that we are giving an antidote in this case, that is N-acetylcysteine. So he's asking you regarding the mechanism of action of N-acetylcysteine. Yeah, Lama is the preferred drug. I agree to you. Lama is the preferred drug, ना, that is okay. But then इसमें तो देखो ना, उसने क्वेश्चन में क्या पूछा, मोस्ट अप्रोप्रिएट मोनोथेरेपी फॉर दिस पेशेंट, उसने क्लास बनाई ना, ये वाली क्लास इज गिविंग दिस क्लास ए फॉर मैनेजमेंट ना, क्लास ए इज नो रीसेंट एक्सर्बेशन, MMRC grade 1 dyspnea, no hospitalization history given. So we have to start from the bottom of the pyramid ना. Drug of choice is Lama, I understandable, but here he's starting from the bottom of the pyramid. That is why I said, because you have to look at these classes, no, that is it A, B or E categories that I basically mentioned in the treatment part. So when you listen to this, then these treatments will make sense to you. No recent exacerbation, no hospitalization, MMRC grade 1, that means is at the bottom of the pyramid. When is tiotropium given? When he goes into this particular class, no? Tiotropium is given when he goes into this particular class that I mentioned, B, and then we upgrade to E. So it is A, B, and C initially, and then it is the one that I've described. N-acetylcysteine कैसे काम करता है? तो N-acetylcysteine will act by replenishing glutathione. The answer for this question would be given as option number C. Very good. Next, we have a patient who's having overactive bladder. This patient is not having benign prostatic hyperplasia. There is no poor urinary stream. There is no straining that is described. If in this question, if the clinical history was of benign prostatic hyperplasia, then for management of this patient, I would have answered as option number C, that is tamsulosin. But the diagnosis in this particular case is that of overactive bladder, OAB. And considering that it is an overactive bladder in this particular patient, and he has been diagnosed with S-Jogren syndrome also recently, so there is a possibility that that could be contributory to the manifestations in this person. Not in a sense that it will cause overactive bladder. I'm not saying S-Jogren will cause overactive bladder. That is the pointer to that there would be a dry mouth present, and tolterodine has a big side effect, that is with dry mouth occurring. So the best answer for this patient would be given as mirabegron. That would be a drug that would be a beta-3 agonist. It will relax the detrusor muscle, and this will basically ensure that the overactive bladder of this patient can be achieved. The basic answer is the treatment for overactive bladder can be tolterodine, mirabegron, and oxybutynin. Among these three, mirabegron, because it will not have that side effect of dry mouth in the individual, and oxybutynin is relatively older drug, has some memory issues also associated. So among the drugs which are given, mirabegron would be the best one. या वही बताया ना बच्चे, why not D? Oxybutynin is not recommended in old people because it tends to make people more forgetful, and here like the age group is also on the higher side. So mirabegron is recommending the bladder overactive. It's trying to counterbalance the overactive bladder relaxation. The correct answer for this is option number B. I'll say the rationale once again. Tolterodine is ruled out. Yes, if okay, if S-Jogren is not given in this question, then even then I will answer mirabegron, because dry mouth तो यार is a big disability ना, मुंह सूखता है। कितने पेशेंट आते हैं यार हमारे पास, जब हम दवाइयाँ लिखते हैं तो क्या बोलते हैं, पानी ज़्यादा पीना बेटा, मुंह सूख रहा है, तो पर्सन रिपीट कंसल्टेशन में नहीं आएगा ना। तो tolterodine would still not be preferred in this patient because of the side effect, और यहाँ तो उसने S-Jogren दे दिया है, तो it becomes still more easier for you to, I mean, justify that you would like to avoid tolterodine. Tolterodine से visual issues भी होते हैं, visual blurring भी present होती है. So if you check out a patient who's have taken tolterodine versus mirabegron, less complaints would be seen there. So I'll give the rationale once again. C was ruled out because this is not a BPH. I'm left between A, B, and C, and between A, B, and C, the safest drug that I can be giving to this patient is mirabegron. Tamsulosin तो बताए ना बेटा, tamsulosin is given for benign prostatic hyperplasia. This guy is having a OAB, straining, poor stream. That is a feature कि यूरिन का धार कम हो जाता है. That is a feature of benign prostatic hyperplasia. Okay, so I think we are sorted for this one, guys, and had a good, healthy discussion. Next is a one-liner. Tofacitinib will be exerting its anti-inflammatory effect by quick answers, please. जैक 1 एंड जैक 3 इनहिबिटर टोफासिटिनिब पे दो क्वेश्चन है भाई, आएगा टोफासिटिनिब अच्छे से पढ़ लेना इस पे हमेशा, बिकॉज दिस इज द रेज नाउडेज ना, जितने रूमैट वाले सब टोफासिटिनिब लिख रहे हैं, लेफ्ट राइट एंड सेंटर फॉर मोस्ट पेशेंट्स विद रोमैटिक डिसऑर्डर्स, एंड गैस्ट्रो वाले भी आईबीडी में. तो आई मीन जस्ट रीड अबाउट टोफासिटिनिब वेरी वेल. दिस इज अ मस्ट नो. दिस स्लाइड दैट आई मेंशनड दैट आप पीएसएम में पढ़ाए हैं, वहां से पढ़ लेना, या ये वाला जो मेरा टेबल का पीडीएफ है, दैट वुड बी, दैट इज प्राइमरली टू बी रिमेंबर्ड. ओके यार, दोनों सेपरेट सिनेरियोज है ना, सेपरेट सिनेरियोज है. यहाँ पे वाइवैक्स एंड फैल्सिपेरम का इन्फेक्शन है, और एक है कि जिसमें अनकॉम्प्लिकेटेड वाला है. तो दोनों में ही देयर इज अ डिफरेंस इन द ट्रीटमेंट दैट वुड बी गिवन. ओके okay, JAK2 inhibitor would be used in severe ulcerative colitis. Okay, this I was saying only na, that the JAK inhibitor used in severe ulcerative colitis. Yes, this would be tofacitinib. Yes, yes, yes. भाई ये तो भारत सरकार का है यार, ये मैंने तो बनाया नहीं है ना, तो ये तो गवर्नमेंट ऑफ इंडिया का ही है ना चार्ट जो है. दैट इज अ चार्ट फॉर गवर्नमेंट ऑफ इंडिया फॉर ट्रीटमेंट ऑफ मिक्स्ड इन्फेक्शन. सो यू नीड टू चेक इट आउट, गाइस. Okay, we are down to the last four MCQs for today. We have this kid, he is 4 years of age, high grade fever, purulent sputum, and then there is gram positive cocci in clusters, that means Staph aureus. And he is asking about what will we do for this particular case for management. Yes, the biggest problem with this would be development of pneumatoceles. Pneumatoceles would be small cystic cavities in the lung, and these small cystic cavities in the lung can burst and can cause a development of pneumothorax in a patient. So we need to give linezolid to the patient. The correct answer for this question would be given as option number B. Staph aureus, whenever is present nowadays, will be multi-drug resistant only, so it is vancomycin resistant. So we give linezolid to the patient, and we simultaneously use. I mean, the biggest problem with Staph aureus is the radiological finding. The radiological finding given in the question is pneumatocele, and pneumatocele can rupture and it can communicate with the pleural cavity, resulting in development of pneumothorax in a patient. That is why the answer is B. The close option was empyema can also occur, but less likely. Empyema is more common with streptococcus pneumonia. I mean, any bacteria can cause an empyema, I'm not saying that, but because of pneumatoceles shown in the X-ray, you have to be aware that pneumatocele will cause a pneumothorax. Yeah, but I showed na that there is no radiological finding of empyema given in the question na. Like if the question showed any pneumatocele jo hota, that's a cystic cavity filled with cystic cavity caused by lung destruction. When it will burst, the complication of pneumatocele is mainly a pneumothorax. Why not A? Pneumonia में सेफ्ट्रोक्सन नहीं देते, और निमोनिया का कॉम्प्लिकेशन ब्रोंकेक्टिसिस तो फिर सिस्टिक फाइब्रोसिस के साथ ही होता है ना. निमोनिया में ब्रोंकेक्टिसिस तो तभी बनता है व्हेन देयर इज गोना बी लाइक एसोसिएशन विद सिस्टिक फाइब्रोसिस. ओके fine, we have this guy, he has a history of sleeping pill abuse, and he's coming to the hospital with this dry mouth, dry pupil, flushed skin, visual hallucinations after chewing seeds from a wild plant, है ना. भोले का प्रसाद खा लिया ये, और भोले का प्रसाद खाते ही बीमार हो गया. दैट इज धतूरा पॉइजनिंग. दिस गाय इज टेकिंग एन एक्सक्यूज, इज टेकिंग नेम ऑफ गॉड, but these people, what they're doing is the wrong thing, right? That they're taking the name of God, but in the excuse of that they are doing is a misuse, that is datura poisoning. And in setting of datura poisoning, what we do is physostigmine would be the drug of this patient. And the I would say the confusing thing given in the question is sleeping pill abuse. I mean, that makes him vulnerable, right? I mean, why would anybody go in for datura poisoning is what I'm trying to say, that sleeping pill abuse is a distraction that is given and might make you think in terms of flumezanil as an answer as well. Benzodiazepine overdosage is what you might be suspecting, but obviously you did not fall in the trap. Okay, so many people are drinking country liquor, which is mixed with methylated spirit, and is brought to the hospital in an unconscious state. So we are talking about huge tragedy in this case. That is, the person has consumed methanol, And he says, what is best for management of this patient? So for methanol poisoning, the main treatment that we give is, we give, सबसे पहले तो जो लोग इंट्रावेनस ए बोल रहे हैं, तो पहले तो ये बताओ, ध्यान से पढ़ नहीं रहे हो, इट इज इंट्रावेनस इथाइलिन ग्लाइकोल, नॉट इंट्रावेनस इथेनॉल. सो यहाँ पे पहली बात तो इथेनॉल नहीं है, और दूसरा बात क्या, इथेनॉल आईवी देते हैं क्या? अगर आईवी इथेनॉल देना परमिशन दे मिल जाए तो आपको मुझको इतनी मेहनत करने की ज़रूरत है क्या? है ना, कि 3 साढ़े 3 घंटे से हम लोग ये डिस्कशन कर रहे हैं. आप सुबह से घर में, घर घर के बाहर आपको कुछ नहीं करना, है ना, किसी को कोई, आपको कोई अपना बताने की भी ज़रूरत नहीं है कि आप कहाँ पे डॉक्टर हो. अब लोग अपने पता लगा लेंगे, एंड पीपल विल कम एंड क्यू अप आउटसाइड हाइस के, डॉक्टर साहब कैनला लगा दो, आई नीड माई फिक्स फॉर टुडे. सो आईवी इथेनॉल नहीं देते हैं. अगर इथेनॉल देना भी होता है तो नेजोगैस्ट्रिक ट्यूब से देते हैं. द करेक्ट आंसर फॉर दिस क्वेश्चन इज नॉट ऑप्शन नंबर ए. Intravenous ethanol is not given. We give it via nasogastric tube. The correct answer for this question is intravenous folate. Guys, methanol poisonings में बनता क्या है? तो toxic product बनता है formaldehyde. This formaldehyde is toxic to the retina. And after the toxicity of formaldehyde, which is toxic to the retina, there would be formic acid that is formed. This formic acid will damage the brain and will cause encephalopathy. If you want to inhibit all of them from getting, formed, then there are two things that you will be using. One, we give IV fomepizole. And along with IV fomepizole, the second thing we will be giving is IV folate. This is not a question to be forgotten. Please check out your toxicology discussion again. Check out your pharmacology discussion again. There are two things which are to be given, fomepizole and folate. दोनों ही देते हैं बच्चे. पहले main antidote is fomepizole ना. Main antidote is fomepizole. And along with fomepizole, it is IV folic acid which is to be given for this patient. So fomepizole for methanol poisoning is used for this patient. Yeah, absolutely yes. The answer for this question would be option number B. या दैट इज द पॉइंट. यही तो आप लोगों से पूछ रहा हूँ. फॉर्मिक फोलिक एसिड हेल्प्स इन मेटाबॉलिज्म. यही तो पूछना चाहता हूँ मैं. तो आपसे पूछना था, आप मुझसे पूछने लग गए. हाउ फोलिक एसिड वर्क्स इज, फॉर्मेल्डिहाइड इज टॉक्सिक टू द रेटिना. सो फॉर्मेल्डिहाइड मेटाबॉलिज्म के में एक्सपेडिशन में फोलिक एसिड इज लाइक अ कोएंजाइम. सो इट हेल्प्स इन बेटर मेटाबॉलाइजेशन, फास्टर मेटाबॉलाइजेशन ऑफ फॉर्मेल्डिहाइड, एंड देयरबाय द टॉक्सिसिटी टू द रेटिना विल बिकम रिलेटिवली लेसर. साइनाकोकोबैलामिन इज यूज्ड इन, आंसर है व्हाई नॉट सी. तो ये तो यूज करते हैं ना साइनाइड पॉइजनिंग में ना, फॉर मैनेजमेंट ऑफ साइनाइड पॉइजनिंग वी यूज साइनाकोबैलामिन ना. Yes, guys, never read about folic acid. यही तो बात है कि you have to be aware of all these things which are asked in the paper, because बहुत बारी क्या होगा कि you will read things in a fashion that you might be reading them superficially and you might think that you have read the topic, but उसके बाद में ये नया concept आ गया folic acid वाला, but still doesn't matter. Like I'll solve it for you guys. The final point is that if a person is suffering from methanol poisoning, there would be formaldehyde that would be produced, and that's toxic to the retina. This will damage the eyes. Because it will damage the retina, I need to metabolize this formaldehyde better. So for the faster metabolism of formaldehyde, it is folic acid that is used, and fomepizole is a drug that will cause inhibition of alcohol dehydrogenase, the same enzyme that metabolizes ethanol. So you will have prevention of formation of these products. So I said two things. One is don't allow formaldehyde to be formed, and whatever is formed, you want to get it destroyed. I repeat that again. One, I don't want it to be allowed to be formed. So that is how fomepizole will work. Prevention of formation. Second, whatever is formed, I want to destroy it. So that's what folic acid plays a role in. So the answer for this question is option number B. That is intravenous fomepizole and folic acid is used for management of this patient. And cyanide poisoning. कोई FMG के लिए पूछ रहे हैं भाई cyanide poisoning का antidote बोलो चलो. FMG में पूछा है what is the antidote for cyanide poisoning? Yes, guys, what is the antidote for cyanide poisoning? वेटिंग. साइनाइड पॉइजनिंग का एंटीडोट बोल दो. ओके. नो, एंटीडोट इज नॉट अमाइल नाइट्रेट. हाँ, मैंने कहा हाउ कैन यू फॉल इन द ट्रैप गाइज. ये FMG एग्जाम में पूछा गया कि साइनाइड पॉइजनिंग का ट्रीटमेंट क्या होता है. इतनी बार प्रेजेंट है, इवन FMG सॉल्यूशंस बुक में प्रेजेंट है. गाइज, हाउ कैन यू मेक अ मिस्टेक. इट इज सोडियम थायोसल्फेट दैट इज प्रोड्यूस्ड, and along with this sodium thiosulfate, the second thing that is used along with sodium thiosulfate is vitamin B12, that is cyanocobalamin. I would like to clarify this because lots of people are reading very casually. Guys, I would like to say there are two questions that will Either of the two will always come in the exam. One is methanol poisoning. If he says what is the antidote for methanol poisoning, it is fomepizole. And along with fomepizole, it is vitamin B9 that is given for management of this patient. It is two Fs that would be used in this patient, both intravenously. But when it comes to a person who's having cyanide poisoning, the antidote is not amyl nitrate. Amyl nitrate तो inhalation route से देते हैं. आप खुद सोचो, पेशेंट की डेथ हो रही है, उसको बोलोगे इनहेल कर. Guy is dying and you tell him inhale kar. Do you think that person will be able to inhale? No, na. We have been saying this for so long. Forensic people used to say, no, it is amyl nitrate. Now, even in Reddy, the textbook of forensic medicine, the answer is changed. In Reddy forensic medicine, the answer is not given to be amyl nitrate. It is sodium thiosulfate, and along with this is cyanocobalamin, that is vitamin B12. The first point that I've said has been asked in NEET PG. The second point that I've asked is asked in FMG. How does it matter, man? They can change the data and reverse it. No. I mean, अगर आप ये बोलते हो सर ये नहीं पढ़े हैं, तो मेरा क्वेश्चन ये है कि भाई पढ़ना है, right? You have to read about these. Yes. FMG नीट पीजी नहीं बच्चे, टफ नहीं है, उसमें नेगेटिव मार्किंग नहीं होती बस. बाकी तो क्वेश्चन तो डिजीज तो बच्चे वही रहने वाला ना. द डिजीज इज गोना रिमेन द सेम. इट इज जस्ट दैट द टॉपिक विल बी आस्क्ड इन अ मोर बेनाइन फैशन. चलो fine, I think we're sorted for this. We have 2 more to go before we end for today's discussion. Quick voting. I would like everybody to vote. And now hit the comment button. I would like 500 comments immediately in the chat box. What is correct about superfecundation? Yes guys, quick entries please. 2-4 कमेंट आ रहे हैं. वेटिंग 10 सेकेंड्स में. आई वांट द कमेंट बॉक्स टू स्पाइक. इससे आसान क्या पूछेगा भाई? सुपरफिटेशन नहीं पूछा ना, सुपरफिकंडेशन पूछा है. यस. अभी देखो गलतियां कर रहे हैं लोग. नाउ इन बिटवीन पीपल आर ओके, बट देन सुपरफिकंडेशन इज गोना बी ऑप्शन नंबर ए, दैट इज बी और ए भी आया था. So it is fertilization of second or more ova in the same menstrual cycle as fecundation. Superfetation means already one fetus is there and the second fetus is getting fertilized in the second menstrual cycle. If you go by English here, the second one is in a different menstrual cycle, a second fetus is getting conceptualized. So there's a superfetation that is happening. The correct answer here is option number A. I mean, after brainstorming about something as simple as ethanol poisoning, we can get issues with the easy question. Okay, so last one for today guys, and then we do the remaining ones tomorrow. So again a forensic question here. Yes, you can use that medicos. You have a point there that alphabet 2 T's in superfetation will help, but some people not able to remember that, so I said logic. Yes, guy brought to the ER in unconscious state is a farmer, and the pulse is 30, BP is low, garlic odor in the breath is present, and the ABG of the patient is showing pH is less, PCO2 is less, bicarbonate is less, so there is a metabolic acidosis component present. But bicarbonate is on the normal side, but still there is a acidosis. Maybe soda bicarbonate correction was given to the patient. That is why bicarbonate is normal, because maybe soda bicarbonate correction was given. That's the possible explanation, but the patient is having metabolic acidosis, and there is a garlic odor also described in the question. The main point in the question is, however, that the RBC cholinesterase levels are normal. That will immediately rule out OP poisoning. The answer to this question would have been A, if there was RBC cholinesterase levels are affected. But here, if they're normal, then it is not aluminum, then it is not OP poisoning, then it is sulfose poisoning. वो जो sulfose की गोली आती है, the sulfose goli is basically used to preserve grains, चावल. जैसे अभी तो you and me, like we in our houses purchase grains for like 5 kg bag like that. But earlier, like in a village, if you are from a village, then they purchase rice for the entire year. So to prevent that rice from getting spoiled, they used to put the tablets in it that is of sulfose, that is aluminum phosphide, and that can be dangerous, that it can contribute to development of or it can result in a person consuming those tablets and attempt a suicide as well. The correct answer in this question is option number B. And why answer is not A is because what I've underlined in red, RBC cholinesterase levels are normal in this question, which is why OP poisoning is ruled here. So clear lungs, yeah, clear lungs is also ruling out here. That is why the answer for this question is option number B. So guys, I think we've done 100 for today, and we've done them with reasoning and with logic. My speed has been like 30 odd questions in 1 hour is what I've tried to cover. So tomorrow, like we do ENT, we do opthal, we do medicine, surgery, a couple of other important subjects as well. So I'll see you tomorrow again at 12 o'clock onwards, and we try to do a session. I'll try to wind up by 3 o'clock tomorrow. So I think that this discussion will be worthwhile for your effort. And now you guys can, maybe take a break for a short duration and then go through turning the pages of your notes again to imbibe all the information that is present. And I think you'll be motivated enough to try and attempt more MCQs here, because see, you are getting those questions correct, some you getting correct, some you getting wrong. The only thing is that it's not consistent. Right, it's like right, then wrong, then right, then wrong. You have to minimize the negatives, right? That's all that is required. So practice more, and I think that with practice, that more corrects will gradually start increasing. So thank you so much, guys. It was really fun interacting with you guys, and I'll interact with you tomorrow again. See you. God bless you.